సత్యవతి మ్యామ్ ప్రతిభాది ఇచ్చినావా అక్కడ పెట్టినావా ఇక్కడ ఉంది మ్యామ్
అంటే ఒకవేళ మనిషి
session goes in order. There's no change. Always the last person. Otherwise, as soon as this, ask them to come out. If they come, we'll
Good morning, all. Very warm greetings to each and every one of you. This is Dr. Tejasvi signing into the conference as MC. On behalf of all the organizing committee members of Ankura Hospitals and on behalf of all the doctors of Ankura Hospitals, we extend our appreciation for your presence today. With the blessings of Lord Ganesha, let's move on to the second day of academic bonanza. I'd like to invite Dr. Anupama Hari Madam to come on to the dais. Madam is chairing the session. Sorry for that. Anupama Hari Madam, good morning, ma'am. Dr. Anupama Hari Madam, she did her MD, DNB, PhD. She's a formerly professor and HOD in the obstetric department of Gandhi Hospital. She's now working as professor and HOD OBG in Mallareddy Medical College for Women in Hyderabad. She has many publications in national and international journals to her name. Thank you for chairing the session, ma'am. Next, I'd like to invite Dr. Satyavati Madam to chair the session. Dr. Satyavati Madam is a retired professor and HOD in obstetrics department, Usmania Medical College, Hyderabad. She's a retired superintendent of GMH, Hyderabad. She's a retired additional director of DME. She worked as UNICEF consultant from Combined Andhra Pradesh for PPTCT for HIV. She worked as consultant UNICEF New Delhi for PPTCT training of Medical College. She is a chairperson of TRG PPTCT NACO New Delhi. She received Chief Minister Appreciation Award for establishing PPTCT centers in all medical colleges in Andhra Pradesh. Thank you for chairing the session, ma'am. Next, I would like to invite onto the dais Dr. Aditya Vikram Kapra sir. Please come onto the dais, sir. Sir is a managing director of Pearls Healthcare Associates. Now I would kindly request Dr. Anupama Hari madam to introduce Dr. Malti Ponnuru madam.
Nice introduction and inviting me as a chairperson today's session. Dr. Malati was Joint Secretary OJH in 2018, Coordinator MEDA, ICOG MEDA 2017, ISOCORP Treasurer 2022. And she is a master trainer, Telangana State 10 government programs like PPIUCD, BMONC, and maternal near miss audit and other things. And she got many awards. Best Poster Prize in 2019 and 2020, International Women's Day Award Health 2023. And now I request, now she is in Usmania General Hospital and Medical College in department. I invite Dr. Malati to present her.
Thank you, madam, for the kind introduction. See, induction starts always in the mornings, and the topic is also the first one to start. And I'm not nervous, but I definitely want all Vijayalakshmi madam, Pratibha madam, Hemlata madam to be my chairpersons so that I can still continue to learn. Apart from the August audience, I request all three of you to be the chairpersons for my session, madam. So I just going to speak within 15 minutes, the time given, about the recent guidelines, what I understood about the induction of labor. And when I interacted with few of the delegates, I understood that induction of labor, there is no standardized protocol within the institution also. It is consultant based, never an institutional based. That's what I understood when I interacted. So we know that induction of labor is something not new. The indication being always that when there is a benefit to the mother or to the fetus only, we decide on an induction. But still, when this is such an old method and done almost every day, why still medico-legal cases are being filed against doctors, obstetricians, for doing this procedure? See, on one hand, we are saying, when there is a benefit, I am planning an induction for you. But the mother thinks, the couple thinks the outcome is going to be something better for her and or to the baby. But when it turns other way around, the outcomes become bad, then they file a case. So this is one of the latest judgments where the judge has said the obstetrician has used some doses which are not acceptable as per the standard textbooks and as per the expert opinion. And also he said that there are no traces available, CTG traces, to defend her case, and a statement is made. Poor records means poor defense, no records mean no defense. Dr. Balamba madam used to insist on this documentation. So with this, I move on. So now the terminology. I hardly see this kind of terminology being used in the medical records and when we refer a case. Why we don't use this? Because each gestational age is something very special and then different. They are not the same. So we'll have to change and we'll have to move on to this new terminology. Still, I find records writing premature delivery. It is not premature. We'll have to mention the gestational age with the terminology. And if you are opting to give this facility of induction of labor, please check that your facility should be fulfilling all this. This is now mandatory to have this in your place. Then only you will be eligible for doing a induction process. Now, the important thing is, because inductions are always elective, one thing we'll have to start doing is share an information leaflet. In that, we'll have to mention the success rate depending on the audit of your own institution. It is not a standard one. That is one thing I would like to emphasize here. Regarding the complication, these are the complications which should be informed in the consent and in the information leaflet. Just mentioning the complication is not enough, but you should have something to prevent detect early and manage. That should come in the protocol of your facility. And always we think consent is doctor and the patient or the attendant. It is much more than that. You'll always have to include a witness also in your consent form. We all know the success of induction depends on variable factors, the most important being the gestational age and the Bishop score. Now, not only knowing the indications, when not to do a induction. Recently, we had a mother where the estimated weight was given as 4.6. Still, they have done an induction. And there was a case where the CPD had been cephalopelvic disproportion on an assessment, but still they went ahead with the induction, and both of them had a very bad outcome. So you are not realizing that indications and contraindications both are important, and you have to have this checklist in mind. And what are the things to be done prior to the induction? Gestational age, per abdomen, just not the scan, the per abdominal examination. And if your CTG, you'll have to run the CTG for 20 minutes, and if it is showing that there are 2 to 3 contractions in 10 minutes, please avoid prostaglandin as an inducing agent and use the Bishop score. Either now we started using the simplified Bishop score. It is approved to be a simpler one which has only 3 components. And when we are doing a PV, try to see that you have to assess all these important. It is not just the Bishop score or a pelvimetry, because vasa previa, cord presentation, all this becomes a contraindication for induction. Now, coming to the protocols, there is you'll have to have either an infusion pump and or a drip running. But what happened in the medical legal case, the doctor has said she has used 66 units of oxytocin. Stop mentioning the units, start mentioning the milli international unit. So no longer it is accepted, whatever method you use, whether the infusion pump or the regular drip, but please mention the milli international unit, and we need to know what is the maximum for a primigravida, for a multigravida when there is a scarred uterus. In that particular case, she has used 66 units. So how will she defend herself? So coming to you'll have to have a protocol, because whenever you're doing an induction of labor, tachysystole and hyperstimulation are likely to happen, and your record should reflect that you have done a vaginal wash with saline. And the new latest guideline says, even when there are no fetal heart changes, if you document there is a tachysystole or a hyperstimulation, what is expected from you is to use a tocolytic agent. Earlier, the recommendation was only if there are fetal heart changes. But now it says, if you document hyperstimulation with or without fetal heart, use a tocolytic. And also remember, whenever there is a hyperstimulation, it is not because of your pitocin or the prostaglandin. It could be because of the pointer for a malpresentation, malposition, CPD, or an abruption. So these are the things to be ruled out when you encounter a hyperstimulation. And what we use in our institute is the nitroglycerin, the IV bolus, because that is available in the institution. So in the same, continuing with the same medical negligence, there was a delay of 26 hours for the obstetrician to take a decision in that particular case to do a C-section. So this is not acceptable. Now we have the labor care guidelines, WHO guidelines, which clearly tells you what is the duration of each stage of the labor. So let us follow this and let us not get into the trouble. And we'll also have to, in the consent form, we said there is a failure of induction is also a possibility. So how do we define? Earlier, it was the failure of induction was defined as failure to achieve vaginal delivery by 24 or 48 hours. It is not so now. The failure is failure to achieve adequate uterine contraction after the maximum dose and the maximum time. It is not the vaginal delivery, adequate uterine contractions now. And you should have a management option too. If you fail, what is your facility going to adopt? Whether a reassessment, offering rest, and then further attempt of IOL can be with the same agent or with the other agent. Or if the woman doesn't agree for again a reinduction, then the option would be a C-section. But the couple should be involved in the decision making. So what is the right time for induction of labor? There's so many gestational ages. We always the term pregnancy is for us after 37 completed. But let us see what is right now. This is a good evidence where the FOXY and ICOG say it is 39 weeks. If you want to induce a labor, you are right. Okay, and especially for a low-risk primate. No indication, she's just a primate. 39 completed weeks now approved as a indication for induction of labor. And where in the private sector where they want the consultant to be there, maybe probably this becomes an indication. And women who conceives with IVF and nullipare with advanced maternal age, these are the conditions which are approved for 39 weeks of induction. And ACOG had looked at specifically South Asian women who are living in USA. So they also approved, saying that 39 weeks is the right age. I still remember Balama madam saying for South Asian Indians, the placenta matures early. Meconium stain liquor happens after 39 weeks. So probably this study is also supporting the same statement, and even in UK, NICE is also approving 39 weeks only for the South Asian background. For all others, it is 41 weeks. For us, it is 31. WHO is saying it is only 41 weeks. Whether you are South Asian or some other region, it is always 41. Why? Because it believes that majority of them, they set into spontaneous labor. So you select what is suitable to your facility and go. 39 is also right. Even 41 is also right as per the WHO. Now somebody refuses at 41 weeks or 39 weeks, then what is the thing? Then you offer them. If they refuse, they'll have to undergo this kind of monitoring. Otherwise, the risk of stillbirth increases. You become responsible. Now, for the specifically for certain conditions now, term pre-labor rupture of membrane, we have two options, induction versus expectant. So, do we do a routine GBS screening in your facility in Ankura? We don't do, but do you all do? So we don't do. So somebody comes with a pre-labor rupture of membrane. The cases are being filed for puerperal sepsis, something happening much later. So let us be alert. So whenever you are offering a expectant line of management, you should know the GBS screening, whether it was done. If it is done earlier in the pregnancy, because there is a recommendation that all pregnant women should undergo GBS screening, urine culture, at 36 to 37 weeks. And if it is positive, you have screened and it is positive, no chance for an expectant. You will have to immediately induce. And what we do is, we don't screen. But what we do is, we don't give an expected management. At term PROM, we go with immediate induction. And antibiotic, what we use is ampicillin 2 grams that I have mentioned there. And these are the risk factors which can increase the puerperal sepsis and chorioamnionitis. Restrict your PVs not more than 3 times. And when it comes to preterm, it is little different. See, always preterm, we want to wait at least till 34 weeks. Am I right? So that the maturity comes. But remember, whenever you give a tocolytic agent for the coverage of the antenatal corticosteroid, it increases the chance of chorioamnitis. So only when you feel there is a need, you give. Beyond 36 weeks, 34 weeks, there is no need of antenatal corticosteroid, because it is going to add to your chorioamnionitis. That's what I wanted to tell. And whenever you're giving a expectant line of management, be aware of the clinical features of chorioamnitis, which has a major and a minor criteria, which is simple, and we follow this in our institution. We put up a table and we monitor whenever we give a expectant line of management. So coming to the FGR, yesterday we had a session, workshop on that. Only stage 1 FGR, you are allowed an induction. Stage 2, 3, 4 are directly for most of the time for C-section. And the preferred method is the Foley's mechanical, and we go with oxytocin. But ACOG also says PGE1, because you can pull out if there is a hyperstimulation. And then for early FGR, there is the GRIT study, which says that you'll have to individualize. So individualization is the one for early FGR, and small for gestational age, it is like 37 weeks. So it is at 37 weeks for small for gestational week, and for uncomplicated. What is uncomplicated FGR? Only the growth is less. It is just like a SGA baby with a normal fluid and Doppler studies. So uncomplicated FGR and the SGA are almost the same, and the period of gestation is 37 for induction. There are certain cases of isolated oligamnias. So the diagnosis is always with the mean vertical pocket, not the AFI. And if the Doppler is normal and you have ruled out an anomaly, again the answer is 37 weeks. So till now we said for Asian it is 39. As per WHO, it is 41 if there are no risk factors. And now we have learned, this is the table with 37 as the indication for IOL. I just wanted to tell one point. See, in a corporate center, definitely the couple would like to ask you whenever there is you have done an induction for FGR, what is the risk of recurrence? So definitely you'll have to send, to answer this query, you'll have to send the placenta whenever you're delivering an FGR. Send the placenta for histopathology, and the pathologist should be following the Amsterdam workshop consistent statement. I've read this statement, it's very elaborate, I could not understand some of them. Maybe the pathologist would be the right person to understand, but that is one thing you can offer, you must offer if they ask you this particular question. And for gestational hypertension, it is always 37 again. HIPTAT study said, recently we had one case of gestational hypertension, no features of preeclampsia at all. So above 37 weeks. One of the consultant waited till 39 and it was a stillbirth. So HIPTAT, we'll have to go with these numbers. Okay, GDM, no abnormality, 40. But remember, reaching 40 is enough in GDM and not to cross 40. For insulin dependent, again, it becomes 37 to 38. Uncomplicated twin pregnancy depends on the chorionicity. And then about the obstetric intrahepatic cholestasis, the decision is made by the level of the bile acid. We have the mild, moderate, and severe, and that decides when to terminate. So bile acid is the one which tells us the period of gestation when we have to induce the labor. Now coming to the mechanical method, coming to the methods, the safe and the cheapest is the Follis bulb. And then which one, single or double? There are n number of papers which say the single, what we use, because Cook's catheter has double and it is expensive, not superior to the single bulb. So the answer is the single bulb, but distend the bulb to 60 ml. That is the thing. And extra amniotic saline infusion, this is again safe. How much to infuse? The warm saline, 1 ml per minute, that is 60 ml per hour. That is the infusion rate, and we do this in our institution. We don't have an experience with laminaria stent. Sweeping, when to do? 40 weeks. And most of the time we say, it is not admitting even a single finger. How do I do? Now the recommendation is do a massage of the cervix through the lateral fornices. That also helps in ripening the cervix. If the os is closed, that is where you do the massaging of the cervix. And there are the best dose of prostaglandin has been decided as 25 microgram. Well, if you are giving orally, it's second hourly. If you are giving vaginally, it has to be 6th hourly. And it is, somebody was asking, can we use for a scarred uterus? Prostaglandin is always a no for a scarred uterus. If you are using it, then the chance of rupture is going to be high. Now, coming to the recurrent episodes of reduced fetal movements. Reduced fetal movements or absent fetal movements, the recommendation is, if everything is all right and she is already 39 weeks, she's coming to you, you just terminate. If it is less than 39 weeks, maybe you can monitor and you'll have to rule out FGR. That is most important. And the comorbid conditions like diabetes and hypertension. Intrauterine fetal death, always the woman wants zahar ho jata, it becomes a poison. And we get lot of calls from so many places that immediate termination. But always there is two things. You can go by expectant, you go by immediate termination. How do you decide? You decide basing on this. Rule out abruption. If the abruption is the cause for the IUFD, it's immediate. If there is an underlying sepsis, it is immediate. If there is a rupture of membrane, it is immediate. If rupture of the uterus is responsible for the IUFD, it's immediate. If there is a hypertensive disorders, it is immediate. So you should know when to say immediate, when to go with a expectant line of management. And no ARM when you have a IUD fetus. And scarred uterus, the preferred method is oral mifepristone, 200 mg, 24 hours later, mechanical. But no prostaglandin is. And see, maternal request for C-section is very common. But maternal request for induction, I have not encountered so far. And it is not routinely to be done, only in special circumstances. Coming to, this is my last slide. So, selection. It is just not indication. Go with the list of contraindication. Then information leaflet is important. Give them, and then it should be always a shared decision making. In the informed consent, don't forget to take the signature of the witness. Then protocol, whichever guideline that suits you better, because one of them was saying we wait till 41. And some was saying we wait only till 39. So whatever suits you better. And the success and failure of induction of labor has to be done by your institutional audit. Choose the safest route. I feel oral is the safest. Because doing a per vaginal, again, you can introduce infection and there can be little discomfort. The lowest cost-effective dose of prostaglandin E1 is 25 microgram. And for the oxytocin, start with the low dose, that is the 2 milli international. Don't write units, write in milli international units. Choose the safest, that is the mechanical mifepristone extra-amniotic saline infusion. Choose the cost-effective method, mechanical with oxytocin, and the single time. And you can, it has a tag, you can pull out whenever there is a hyper stimulation. And I said, consider tocolytic even when there are no concerns with the fetal heart variation. Choose the method you can control best. One is oxytocin, short half-life, reversal is faster, and the PGE1 insert. Now, what I suggest at the end is let us have an institutional protocol instead of the consultant-based protocol. This is the variation in most of the centers. So our defense becomes weak when we don't have that. And finally, if you look at when you're reading any literature, it has one research question at the bottom. Why can't we, because there is a saying that either you publish or you perish. The statement is like that. So why can't we take up such simple things and see, because new interventions, discovery consists of seeing what everybody has seen and thinking what nobody has thought. So let us all, institutional collaboration or individually, let us take up this PICO questions and start exploring and see what is best for our population and what is best for the women coming to our facility. Thank you so much, madam.
Thank you, Dr. Malati, for your excellent presentation on induction. And madam, any comments on it?
Okay. Thanks for the opportunity. Anyhow, I do have some comments to make, Malti.
Yes, madam.
See, this, there are 3-4 things. Extra-amniotic installation of saline you mentioned. All said and done, it's an invasive procedure and you are introducing fluid extra-amniotically. This method was practiced in maternity hospital. Maybe Dr. Satyavati Garu would know, because we also, way back in 76, 77, when they were there, prostaglandins were introduced for induction of labor, abortion, and this installation of saline also was practiced, and there were cases of infection. So whenever we want to, I mean, you said in GMH right now you are.
Yes, madam.
you
For
have done a few
intrauterine
cases.
fetal death with the previous scarred uterus,
Intrauterine fetal death is much more risky
With
because of sepsis. There is a
scarred
risk of-
uterus. Yes, ma'am.
yeah,
Scarred
yeah.
uterus.
See, in rare cases, we may try out different rare
Yes.
methods also, but I am not for that because it's an invasive procedure. Another thing is, though you have, you have listed all the methods, but supposing I were to talk about this, I would say the simple methods like sweeping of the membranes. When you mention all the methods, you have to also stress on certain important, easy methods. Now, this sweeping of the membranes, what we used to call as sweeping or stripping of the membranes, that's a very effective method. And all the patients who are admitted in early labor, with labor pains coming from the districts, they come with labor pains, but they don't progress fast, and they are term.
Yes, ma'am.
So in such cases also we admit the patients in the hospital. So there also when we do a PV and the os is open, I mean whenever it's
Yes,
possible and the bishop's,
Yes.
bishop's score is favorable. We used to do sweeping of the membrane, which has to be practiced in an institute like GMH, because you have lots of patients, you just sweep the membranes.
Yeah, but there
and
also
supposing-
infection prevention practices again becomes important, and don't do an accidental ARM. We have seen the residents doing sweeping of membranes without hand wash, without cleaning the external genitalia. Now we have provided every place with normal saline swabs, because that is one thing we'll have to use before doing. It is also invasive. You're putting your finger into the cervical canal and rotating. So we have seen that also happening, madam, post sweeping. So infection prevention
So
practices are
sweeping,
important.
Yeah, sweeping of the membranes you can do not only on one day, but you can
Yeah,
by
multiple
next
times.
time, next day when you examine, it may become more favorable,
Yes,
and sweeping would become more easy. The third point I wanted to mention is diabetes. You mentioned 40 weeks and.
I didn't mention, madam,
no,
that's the
let me
guideline.
complete.
Guideline
No,
has
let the
said.
guidelines be there. Not all guidelines are. I don't agree with all the guidelines. We have our own experience also to back up. See, in diabetes especially, we have seen late fetal deaths.
Stillbirths, yes.
So
ma'am.
late fetal
Intrauterine
death.
fetal death, yes, madam.
Intrauterine fetal death.
Yes.
And where will you hide your
Antipart-
face if you have to face such
Yes,
a
madam. That's
my
why
God, such a
38 to
situation?
39 weeks. What we do is 38 to 39 weeks.
Yeah, that is one thing, because you let her get into what do you mean by 40 weeks? You let her go into spontaneous labor almost, isn't
No,
it?
yes.
So in such a case, if the fetal heart disappears, it would be a
Yes.
disaster.
Disaster.
So 39 weeks is normally
Yes.
agreed upon. The other thing that you mentioned was early rupture. Rupture of the membranes, PROM. There you mentioned if it is term. I hope you are meaning when you say term, I hope you mean 37 weeks and not 39 weeks.
Yes,
Isn't it?
37 completed is
37 completed weeks
early
with
term.
rupture
Early
of
term.
membranes, you would not give expectant management.
Yes.
So, thank you.
Thank you, madam. for
Hello,
your-
Malti, is a good presentation. One thing I want to stress to the youngsters is normal setting into spontaneous labor is always to be accepted. Let us not be in a hurry to induce in a low risk mother. If a woman sets into labor spontaneously, the progress of labor will be completely different from the induction of labor. That is one thing. Of course, she has mentioned so many risk pregnancies. Of course, I don't want, those are all, you have to, depending upon the condition of the mother, condition of the fetus, you have to decide the term of pregnancy when you have to induce. Another thing, I agree with Dr. Pratibha that if the Bishop score is favorable, stripping of the membranes will give you excellent results in the onset, because we have seen number of times when we never had those facilities of prostaglandins, other thing. If the Bishop score is good, the cervix is taken up, admitting one finger, strip the membranes, by the evening or by next morning, the woman comes in spontaneous labor. There we are very happy that the woman sets into labor on her own. That is one good point. Always remember that a woman who sets into spontaneous normal labor, vaginal deliveries are very, very acceptable, because induction always has its own risk. Another thing, I don't know, I don't have much experience about the Foley's catheter. Are you still using Foley's
Yes,
catheters
yes,
these
madam.
days?
Yes.
I don't much prefer that. I never,
Bishop
I
score
had
less than
not
6.
good, I didn't have much experience about
We
that.
are bad.
And personally, I don't use Polish catheter. Then other types of inductions and
When
other
the-
things depends upon the patient and other.
When the
So
Bishop
this is the
score
only
is poor,
Bishop
madam,
score.
no.
And before you go for induction, don't get taken away that you are going away of station that you are inducing, or the patient wants you to be there and you want to deliver in the morning hours. These are all not to be accepted. You stick to your norms. You be a good obstetrician, follow the protocols, and deliver the patient as per the protocol. That's what I want. So
yes.
spontaneous labor, always avoid for that. As she said, at least by 39 weeks
weeks.
completion. Till then, don't be in a hurry to deliver a low risk mother. That's what
Yes,
I want.
madam.
Thank you, Malti. You have
Dr.
presented well.
Malti, thank you. I have a small question, Malti. What about your previous sections when you want to give a V back? What's your experience with the Foley's?
We wait for spontaneous onset of labor,
Yeah,
madam.
suppose she doesn't.
Yes, then
So-
mechanical is our first option, and we
Foley's
use
you do-
only oxytocin, no prostaglandin at our center.
Oxytocin?
First, we use only mechanical. If
Yeah,
required, later oxytocin for acceleration. Only mechanical.
Okay. But oxytocin do you use for
Yes,
augmentation?
oxytocin for augmentation, but never a prostaglandin.
We have never used oxytocin in previous sections, no madam. Pratibha madam?
We use.
Close monitoring.
Yeah, if required, that is the only thing we use.
You have to be there.
Oxytocin.
Malti, it was excellent.
Madam,
I
thank you.
really appreciate it. I just want to tell a little about my personal experience.
Yes.
This is what happens when we usually are in the
Mike.
in a bit. So what happens is we like to see the primaries especially, and we were trained to examine, explore the pelvis before she sets into labor, before trouble starts. So what happens is, this is my personal experience. So she was actually, she was one of my nieces. She was actually, what happened, she was about to 2 days more. And it so happened to a Saturday and Sunday. So I thought if I induce on a Saturday, she may set into labor by Sunday and all that. And this is what I'm personally telling you. Partially taken up cervix, half centimeters long actually, admitting 2 fingers.
Sweeping.
It was so tempting, I did the stripping. I did the stripping and came back home. It was 2 o'clock when I finished my outpatient, came back home. And I sent her home. She was across the road. And I'm telling you, the very fast way she progressed, I mean, I never thought of rest at all. 4 o'clock, I had to go back. By 6 o'clock, by 5:30, she delivered. Remember this. The stripping of membranes is very effective, especially with the primary, when you think that you have to do exploration. We are taught we have to explore the pelvis before she sets into labor as a primary. So this is what I used to do, and I can never forget my experience. My Saturday went off. I wanted to wait for the Sunday so that I can have time. So remember that stripping of membranes, one thing is that. Second thing is, you may be trying to sweep the membranes, but you naturally get into the membranes. You will do an artificial rupture of membranes without knowing it. And this is very important to remember. This
Accidental.
has happened. Accidental. But you have done an accidental artificial rupture of membranes. You must be prepared for the consequences. This is what the juniors have to learn. So stripping of membranes is so easy to do, and so this thing and all. You should know the Bishop's score. You should know the cervical length. You should know where the presenting part is before you think of all this. Therefore, you take care when you are doing this stripping. Thank you.
Thank you, madam. Madam, I would like to explore on this massaging through lateral fornices when the os is closed, because we are so much dependent on sweeping of membrane, which is the safest. I feel I'll have to start using this and see how effective it is going to be. Massaging through fornices, because that is one thing we do when for non-descent vaginal hysterectomy. Massaging of the uterosacral, that 1 centimeter descent also helps us. So probably this is one thing I would like to explore. And
Okay, Malati. Thank you, Malati. Very
Thank you.
good. Well.
Thank you, madam.
It's a wonderful, thought-provoking discussion. I'm proudly saying that I'm a student of Malti Madam at MGMH. I learned a lot from her labor room rounds in OT and academic classes. Thank you, ma'am. I feel obliged. Next, I'd like to invite, I request Dr. Aditya Kabra sir to introduce Dr. Rishita Reddy madam. Dr. Rishita Reddy madam, please come on to the dais.
Good morning, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to chair this wonderful session with a wonderful audience. Dr. Rishita Reddy, she has completed her MD Anesthesia from Medicity Institute of Medical Sciences, and then she has finished her registrarship from Fernandez Hospital. She has done her obstetric critical care fellowship from Fernandez Hospital, and then now, after all due course, she is leading the anesthesia consultant at Ankura Hospital. So no better person than Dr. Rishita Reddy to take her to this process of a painless or a pleasant delivery.
Thank you, sir. Thank you for the wonderful words. I hope I can make this topic a little interesting. Labor pain is probably the most severe pain a woman experiences in her lifetime. The delivery of an infant into the arms of a conscious and pain-free mother is one of the most exciting and rewarding moments in medicine. International Association of Pain Medicine declared 2007 and 8 as a global year of pain, year against pain in women, real pain. Labor pain was found to be a good study for a model for acute pain. We'll just look into the history briefly. It was first done by James Young Simpson in 1847, first administered obstetric anesthesia with ether. In the same year, it was given to the poet, Henry Wordsworth Longfellow's wife during her delivery, then Charles Darwin's wife, Emma Darwin, during her delivery, and in 1953, that's when probably UK started accepting it because Britain's Queen Victoria, during her 8th childbirth, took labor analgesia. From the 1950s, spinal and epidural anesthesia have come into vogue. The last 2 decades, it's mostly about evidence-based management of labor pains. There are 2 stages of labor as far as we look at it. One is the first stage where it is mostly associated with the distension and the stretching of the lower uterine segment. The pain is mostly visceral, and it's from the T10 to the L1, as I can show in the picture. It's mostly in the upper part of the body. When it comes to the second stage, it is from S2 to S4. It's because of the distension and the perineal, distension of the pelvic and perineal structures and complexion of the lumbosacral complexes. So how painful are labor pains? As we can see, if they're multiparous woman, probably it's a little lesser. Nulliparous, when depending if you've been trained before, it's comparatively lesser, and the highest pain is for nulliparous who don't have any training or don't have an idea about it. What are the effects of the pain on mother and fetus? The normal effects that we see in the cardiovascular system is there's an increase in the heart rate, BP, stroke volume, cardiac output, systemic vascular resistance. There is hyperventilation and increased carbon dioxide consumption, but in between contractions, there is hypoventilation and there can be apnea as well. The adrenergic and acid-base balance, there's an increased catecholamine, maternal acidemia increases, and there's a respiratory alkalosis. So how does this affect the fetus? There can be a reduced uteroplacental blood flow. There may be fetal acidemia. But saying this, due to the absence of direct neural connections from the mother to the fetus, maternal labor pains have no direct effect on the fetus. So even when we're talking about fetal metabolic acidosis, these effects are well tolerated in normal circumstances and are effectively blocked in analgesia. So which mothers do we feel definitely may need and may find help with labor analgesia is those which are associated with any medical conditions, if there is any compromised uteroplacental circulation, if there's a prolonged labor, or if there's trial of scar. So do mothers actually need pain relief? Women in pain don't need an indication for pain relief in labor. According to the American Association of Anesthesiologists, in the absence of a medical contraindication, maternal request is a sufficient medical indication for pain relief during labor. So what are we looking at when we planning to give a labor analgesia to a patient? We want that drug or the medicine that we're giving to decrease the maternal anxiety, fatigue, and deliver a healthy baby. It should have minimal effects. It shouldn't it should probably minimally cross the placental barrier. It could be given in different kinds of dosages like IV bolus, intermittent, continuous. The effect should be rapid, profound, but consistent in both the first and second stages. It should be easily reversible if we need it to, and it should facilitate surgical anesthesia where we're avoiding general anesthesia also. So what are the options that we have? We'll start off with the non-pharmacological, TENS, touch, massage, intradermal, sterile, acupuncture, hypnosis, hydrotherapy, aromatherapy, there's music therapy, and there's many other things that are used. But they may be beneficial. There's no proven scientific data analysis of the quality of the pain relief that we get through it, but they're inferior to the other pharmacological options that are available. The pharmacological options that we have is inhalational, parenteral, and regional. In inhalational, it is the one that's used even now is Entonox. Isoflurane, desflurane, and sevoflurane were used in the middle for a time period, but then we needed different machines and instruments to get that delivered. So that was it. Then we got back to Entonox again. The efficacy range is from 36 to 49%. It's comparable to placebo. The satisfaction is also 36 to 49. The adverse effects are nausea, vomiting. There's reduced awareness, but there are no fetal adverse effects as such. So this is the cylinder. This is the Entonox cylinder, and that's the mouthpiece. So you just put it into the mouth, and then you can press the button, the blue button kind of a thing that's there on that. Whenever she's having a contraction, she can take an Entonox. A systemic review of the use of Entonox in labor concluded that Entonox is certainly not a potent analgesic. Places where neuraxial analgesia is not practiced and in parturients with short labor, Entonox is useful. The Obstetric Anesthesia Association in UK guidelines state that Entonox is being phased out in the view of poor analgesic effect and environmental pollution. Let's look at the parenteral analgesics that we're using. Pethidine, fentanyl, remifentanil, tramadol, not much. Remifentanil as such is not available for us that easily. So what are the advantages? There's convenience, it's simple, the experience is good, but the limitations of this are it has incomplete analgesia, neonatal depression, and maternal side effects as well. So mostly when we do use parenteral, it is done in the early stages of labor, as in pethidine and fentanyl can be used in the first stage of labor when the amount of time to deliver the baby is still long enough and it may not, or you can actually tell the neonatologist that we have used fentanyl and ask them to use naloxone. All the opioids cross the placenta in utero, so there's fetal bradycardia, decreased beat-to-beat variability, and neonatal respiratory depression. Regional. Most commonly performed regional techniques are epidural, subarachnoid block, that is spinal anesthesia, and combined spinal epidural. So the less frequent ones that we do are, most of the time we don't do them because there are lumbar sympathetic blocks, paracervical block, and pudental blocks. So the epidural analgesia is actually the gold standard. Its availability reflects the standards of obstetric care in many countries. In USA, the acceptance of epidural is about 67%. In UK, it is 60%. Finland has the highest epidural acceptance rate of 89%. In India, awareness is still lacking. Only few centers provide pain relieving options to the expecting mothers. So it can basically be done either in a sitting or a lying down position. It's done in the epidural space. Then after the catheter is put in through it, and we can either be using it for a continuous infusion or we can give top-ups. So what are the complications that I would probably explain the patient when I'm doing it? I would tell her that this is a blind procedure, so there is a chance of dislodgement of the catheter also, so she may have some amount of pain or now or a later time. There will be some amount of hypertension, so the fluids are already given. There may be some amount of shivering. Total spinal, yes. Transient paresthesias and intravascular injection, yes. We do give a test dose of the drug so that we know that there is no intravascular placement of the catheter. There may be fetal bradycardia, and these are the neurological complications. They're very rare. Yes, PDPH is fairly common. Direct trauma to the spinal cord, cauda equina syndrome, adhesive arachnoiditis, and thrombosis of the anterior spinal artery. So who should be cautious about taking? If you're allergic to a local anesthetic, have any neurological disease or a bleeding disorder, are you on aspirin, clopidogrel, any infection in the lower back area, has a previous back surgery, any psychological disorders, morbidly obese, or in the later stages of labor when they're unable to cooperate or sit, so that we put place in an epidural, and if there is an abnormal CTG pattern, then it's a contraindication. So these are the recent advances in neuraxial anesthesia. So there's a combined spinal epidural. Now the use of combined spinal epidural is relatively rare because it's either done in the early stage, because in the spinal we normally give opioids. So it's normally done in the early stage or pretty much in the later stage. Like I said, if the patient is not able to sit for an epidural, then we do give a combined spinal where we're giving a little amount of the drug so that she's able to sit, position herself, and then place an epidural catheter inside. Either in case of an inadvertent dural puncture, we do leave spinal catheters inside the dural space also. Ambulatory, because we're doing low dose of the drug and the low volume of the drug that's been used. The drugs that we use right now are ropivacaine, levobupivacaine, sufentanil, ramifentanil, and clonidine. Clonidine are used as adjuvants for spinal. Ultrasound guided localization of the epidural space so that there are minimal failures. Now we don't use ultrasound guided for pretty much every case that we do, but then this can be an example. So in that situation, so that we can reduce the failures, we do use ultrasound guided procedures. Patient control analgesia, role of CT and MRI in detecting complications associated with neuraxial blocks. I think this probably this probably must be more interesting. What are the obstetrician's concerns? Increased instrumental deliveries, increased cesarean rate. We'll just look into each of them. So cesarean section rate. Women at an increased risk of prolonged labor and operative delivery are likely to experience severe labor pains. Women who experience more breakthrough pain but twice as likely to undergo cesarean sections. Women who experience more breakthrough pain during the first stage were more likely to have AVDs. Now the Cochrane database systemic control trials have emphasized that epidural analgesia has no statistical significance impact on the cesarean section rate. However, it is known to prolong the duration of labor by an hour. Earlier, the rate of instrumental deliveries were higher because the concentration of the drug that was used also was higher. The COMET study, which was done recently, shows that the use of low dose of epidural infusions associated with 25% drop in the instrumental deliveries as well. So timing of the epidural. Should we take an early epidural or a late? In RCT of 750 primigravida women in early labor concluded that there is no difference in cesarean section rate when epidural anesthesia was admitted early, as in 2 centimeters, or versus the group that was admitted late at 4 to 5. So the ACOG and the ASA have jointly emphasized that maternal request is a sufficient indication for pain relief in labor. So does the CTG monitoring change? No, it's pretty much the same. In the low risk mothers, it's the same, and even in the high risk mothers, which even if there is no epidural, they are actually monitored continuously, and so are they in place of an epidural. But in most of the situations, what we've noticed is, as soon as we place in the epidural, because of the pain relief, there may be some amount of decrease in the sympathetic drive, which may reduce the heart rate very transiently, which may look as if the patient there's fetal bradycardia. So it's preferable to start an NST half an hour after we place in the procedure so that we don't see those effects. Labor progression. With the low dose drugs that we use, you can allow ambulation, upright position, you can allow liquids, they can be doula support or partner support. It does not affect in the first stage. Now when we come to the second stage, the urge, that is the pain, that reduces. So the pushing has to be guided. They do feel perineal pressure instead of pain. So all the other positions, that is on all fours, left lateral, propped up, can be allowed. Oral liquids can be allowed. Epidural analgesia may prolong the second stage of labor by 15 minutes. Now, what is better, early pushing or delayed pushing in case of an epidural? Early pushing, delayed pushing is advocated for patients under neuraxial anesthesia. Passive descent should be encouraged along with delayed and monitored pushing to effectively increase spontaneous delivery, decrease instrumental deliveries, and shorter pushing time. The pushing early or pushing late with epidural study also supports delayed pushing for better outcome. Withholding top-up in the second stage of labor. The instrumental delivery rate was not significantly different in RCT conducted between patients whose top-up was withheld and parturents who had continuous top-ups. However, there was a significant increase in the inadequate pain relief when the epidural top-ups were stopped. Maternal hypothermia. Epidural maternal hypothermia affects 1 in 5 women receiving epidural analgesia, with the risk increasing as the duration of the infusion increases. It is unclear whether epidural hypothermia itself has any negative consequences on the neonate. VBAC and epidural. Task Force guidelines for 2007, jointly issued by ISA and Society of Obstetric Anesthesiologists and Perinatologists, recommend neuraxial techniques being offered for patients attempting VBAC. Early placement of epidural catheter can be used for labor analgesia and also for anesthesia in event of an operative delivery. Epidural and breastfeeding. Epidural analgesia can modify the stress response in labor in women, which may increase the level of oxytocin and chances of breastfeeding success. However, potential prolongation of labor, mode of delivery, and adverse neonatal outcomes may negatively impact on breastfeeding behaviors. Several studies and trials have failed to demonstrate significant association between epidural and lactation failure or less successful breastfeeding attempts. Backache and epidural. There is no significant difference in the incidence of long-term backache between patients who took epidural and the women who took other forms of pain relief. Postpartum depression. Epidural analgesia was found to be associated with a decreased risk of postpartum depression. Intensity of labor pain and mode of delivery are reported to be associated with mood disorders in early postpartum period. This is the Cochrane database systemic review. The epidural analgesia has better pain relief when compared to other analgesics. There's reduced risk of fetal acidosis, reduced risk of naloxone administration to the neonate. There's no difference in cesarean section rate and no long-term back pain. So these are the myths that probably. So what does the joint ASA and ACOG statement say? Existing evidence suggests that women should not avoid epidural analgesia for fear of neonatal harm, breastfeeding difficulties, cesarean section, long-term back pain, or long-term urinary incontinence. Thank you. Thank you, sir.
Thank you, Dr. Rishita. That was a crisp presentation. So before the audience ask any questions, I would just like to add a couple of things. As mentioned again and again, what I feel, I'm not trying to judge anyone or something because most of my practice is based on obstetrics. Most of the obstetricians, they wait till 4 to 5 centimeter dilatation, stating some protocol. Here, the idea what we're trying to portray is, see, there is something called as Semmelweis effect. We are all, subconsciously tuned to it because the defense comes, this is how we are taught, this is how we'll do the things. The problem with the medical today is we are not ready to accept the change or be a part of the change. So what happens here is, what we advocate usually is, once the patient says, see, pain is now called the 5th vital sign, and most important, pain is a subjective sensation. It's not you or me to decide whether the patient is having pain or not, it is a patient. So if the patient says that the pain is not bearable, kindly go for epidural catheter. I do acknowledge your concerns of instrumentation, prolonged labor and all. We are just putting the catheter, we are not starting the infusion. When you put the catheter when the patient is hardly 1 to 2 centimeters dilated, the patient is comfortably seated, the chances of false positive or having a patchy effect with epidural is minimized, and the chances of single puncture epidural is very much high. So the other complications of neuraxial trauma or PDPH or all those things are avoided. And most important is, after 5 centimeters dilatation, it's very discomfort for the patient to sit. And most important, technically what we train all our residents is, the negative pressure of epidural space is lost when the patient is in active labor. In pregnancy itself it is lost. The chances of false positive are high in pregnancy per se, When the patient is in active onset of labor, it becomes further aggravated. So if all these myths connected, that's the reason I put this MLV's effect. No, 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 sir, we have been trained in our medical college, 5 cm dilatation, you don't touch the patient. That's wrong. Be a part of the change, point one. Point two is, when you go for epidural or anything else, the backup needs to be there. It's a team effort, right? We always used to tell, Sachin Tendulkar is a very great player, very good fan of Sachin Tendulkar, but India never won the World Cup unless and until the team performed. So now this process of getting a good team, because certain times with the medico-legal issues or the complications of epidural, they may become very difficult. And now with the onset of newer drugs, newer modalities, it has become very safe, very simple. So things can be done very easily, provided there is a good communication. So now I open to the audience if they have any questions or anything to be added.
Small comment. In this era of normal labors, normal delivery process, not giving any kind of a medication, the role of epidural.
See, madam, as
Now everybody, some people, they say not even episiotomy, no ARM, no PVs. So what's the place of epidural?
Ma'am, I feel epidural or any kind of analgesia is a matter of choice. If as a mother, she is okay and she wants to bear the pain, I think it's okay. But then that choice has to be given to her if she's okay bearing the pain, even when she's actually, because we've seen many mothers who come in and before they actually face the pains, they're like, no, we don't want to take anything. But then the moment they face the pains and they realize how painful it is, yeah, most of them do want to take it.
Choice is the patient, of course, because the patient is the one who is bearing the pain. But as a medical person, what is its role? I want the chairpersons.
Epidural anesthesia, as you said, Risika, it is the patient's choice, I feel, that it is not the doctor's choice. The patient, of course, there must be a good counseling before she sets into labor. What will be the normal labor? What will be the epidural anesthesia? This is, we are lacking actually. That has to be done, and they must be mentally prepared. And another thing is, we must give the option and choice to the patient only, just because I want the epidural for the patient. And another thing is, if the patient is a multigravida, she is going to progress fast, because when we do the examination, we know that she is a good progressing, and then within 2-3 hours, and I prefer no epidural anesthesia. But sometimes what happens, the patient is told that she will not have pain and she wants it, but by the time you finish your epidural, the patient delivers. So that's why primary gravidas, of course, they must have a proper counseling and they must know whether they want it or not. Some people, they don't like it. They want to go through the labor pains. As our grandmother said, that if you feel the pain of it, then only your child will love you very much. That is what is there in some people's mind. So the option, I feel, still is to the patient, not to the obstetrician, not to the anesthetist.
I just wish to make one point. I want you all to think about it. See, a woman, when she enters into labor, there is always a risk of maternal death and some complications and morbidity that is inherent in deliveries. Now, one of the confidential CMAC reports, confidential inquiries into maternal deaths they conduct in UK, they found maternal anesthesia complications heading the list of the causes of maternal deaths, and epidural was one of them just a couple of years ago. So when a woman who is healthy, young, goes to deliver a baby, loses her life or has lots of near-miss morbidity, are we justified in giving her, because epidural has its own complications, are we justified in adding another risk factor of giving epidural just for pain relief? And that is, I want you to think about it, and I'm not at all for epidural. Personally, I am not at all for epidural, nor is it practical in the Indian scenario. Somewhere posh woman, she has money, she goes for epidural. What about the rural women? They go through all that pain. They just take it as normal. It is just normal feature of life. The second point which you mentioned, early in labor, 4 to 5 centimeters, don't touch her. Regarding that point, I have gone through labor and I know what are labor pains. So I am saying up to 3 to 4 centimeters, not much pain. I mean, not much pain. you do have pain, but the contractions are of short duration, 30 seconds like that. So you are able to tolerate it. Early intervention giving
What
epidural.
he told was, he said it is to put the catheter in place, which is very easier in the early labor, then give the drug only when it is needed. That's what he said.
As I have tried to clear the myth, pain is a subjective perception. Yes. You might feel the pain is less, right? But the patient who is undergoing, it is her job. And regarding the maternal deaths, whatever you have said, that's a very old study. I'll quote you. I'll quote you the ISO certified. You'll be really shocked because the other day I was giving a lecture on maternal deaths on OT. Anesthesia department is the only department which has the least mortality rate of all the medical practices. This is an ISO certified journal. I'll share you the article with it. Coming to it, the problem here, what we understand is because anesthesia was born out of surgery. So what happens is, most of the things when in the previous era of late 90s, you know, the surgeon used to take a call. There was no proper ICU, no proper round-the-clock takeover. ICU practice was not there. Now with the advent of the advance in the medical practice, we have a lot of gadgets, monitoring. We have people to help around. So the mortality rate has very significantly come down. So this point, yes, what you said is correct, but that was a previous thing. We have learned from our previous exposures, and now the practices have become so refined that the chances of maternal death on OT itself has become a rarity. Now in the process, we are telling that the aspiration pneumonitis, RAS protocol, aspiration pneumonitis itself is a myth now.
See, there are, I have also worked in corporate hospitals. I have seen cases of hypoxic ischemic encephalopathy following spinal. They go in for hypertension. So it's not a rare phenomenon. There are many doctors here who have, like their patients, labor patients had epidural, and they faced complications. So once you face a complication,
I'm sorry to interrupt you. That is where I'm trying to focus. The problem with the obstetrician, that a problem with basic obstetrician practice per se, not individually obstetrician. When we are in the labor room, the idea is you only concentrate on the delivery process, but the monitor is not connected. There is no one monitoring the patient. Never will the patient suddenly collapse. Take it for granted. The saturation from 99 will never become 0. It will become through a process of 99, 94, 90. And you know, if you concentrate on your monitors also, go back to your hospitals, when the saturation is dipping, there is a change in the way the beep comes. So it's never a gradual process. In fact, even in ophthalmic procedures where they do cataract under topical, now the standard practice is to advocate to put ECG. I'm sure none of you practice putting ECG monitor onto the patient. I acknowledge it because I practice in a lot of obstetric hospitals. I totally acknowledge the fact. The only problem is that awareness and as a team approach. It's not you or me. It's basically a team approach. When you have a good practice of monitoring your patient, you will catch a lot of these missed effects or near-term misses where you can avoid the mortality rate. Maybe the patient may have some morbidity, as you rightly said, but for sure you can avoid the mortality.
I think, Pratibha, I think we are running out of time. Already we are more than half an hour early. So let us start the next speaker.
Excuse me, Chairperson, 1 second. You're talking about the pain in labor. Excuse me for that. The thing is, the pain is maximum at 2 centimeters, then at 4 centimeters, then at 8 centimeters. These are the 3 stages of labor when the pain is maximum. If she can get over that, she'll deliver normally, number 1. Number 2, I'm very sorry to say, the men who have decided it, they say a woman has to go through the labor and pain must be an essential part of labor. It's an old-timer's way of putting it. Of course, I'm very happy that we have come to a stage when you're thinking of a woman as a person and a person who requires help and all. I agree about the anesthesia and analgesia. But if you go through the ancient books, if you can, you see it's a must for a woman. As you said, she will feel attached to the baby, and those all things are myths. I don't believe in that. A mother will always be a mother and she'll always get attached to the baby. Okay. That's not the thing. Pain is not necessary for her. I'm very glad we have come to an area where there is no pain. Pain relief for the mother is thought of by men.
Thank you.
Thank you, madam. Thank you, madam.
Thank you, ma'am.
Very
I
nice.
humbly request Satyavati madam to introduce Pratibha Narayan madam.
I invite Dr. Pratibha Narayan, who is senior obstetrician and gynecologist at Ankura Hospitals. She is an expert in managing high-risk pregnancies, recurrent pregnancy losses, and her special area of interest is mommy makeup. She is an expert with over 25 years of experience. Dr. Pratibha's patients have consistently rated her as one of the very good high-risk obstetrician. I invite Dr. Pratibha to talk on her topic.
Thank you, esteemed panel, and thank you, ma'am, for the very kind introduction. We all know that, particularly in Telangana state, we are under a scanner for a very high C-section rates. So in August 2021, the cesarean section rate in this state was around 62%, which was brought down to around 56% in 2022. But it's still way away from the cutoff which WHO has laid for us, which is 15%. VBAC is an attempt to reduce the C-section rates. So according to ACOG, we all know women with a previous cesarean section, if she wants a vaginal delivery, that's what is a VBAC. It is considered a safe and appropriate option, and it should be the woman's choice. Patients desiring VBAC delivery undergo a trial of labor, and that is what is known as a TOLAC. So a woman with previous cesarean can have two options. She can either opt for an elective repeat C-section, or she can undergo a trial. Trial can have two outcomes. A successful trial in about 60 to 80% of cases, it's a vaginal birth after cesarean, which we know as VBAC, and a failed TOLAC, which is an emergency cesarean delivery in these cases. So the risk of mother and baby dying of childbirth is extremely low. But the risk is slightly higher in cases of elective repeat cesarean delivery for the mother, and slightly higher for the baby in cases of TOLAC. In addition to fulfilling a patient's preference of vaginal delivery at an individual level, VBAC has several advantages. So if successful, it has a shorter hospital stay and convalescence. There's increased chance of vaginal birth in future pregnancies. Similarly, an elective repeat cesarean delivery also has advantages where patient can opt for an elective date. There's lower risk of vaginal tears and no worsening of pelvic floor supports and continence mechanism. Surgical sterilization can be planned, and there are lower risk of complications like transfusions, endometritis as compared to a failed TOLAC. So we have found that a failed TOLAC has the highest complication rates, inclusive of uterine rupture, uterine dehiscence, hysterectomies, transfusion complications, endometritis, and thromboembolic diseases, as compared to VBAC, which is considered to have lower complications. So maternal risks of VBAC, in about 10 to 15% of cases, there are instrumental delivery and perineal tear which may require suturing. A failed TOLAC increases maternal morbidity and obviously a chance of emergency cesarean delivery. A 0.5% risk of uterine scar rupture, which is one of the most dreaded complications which prevents most obstetricians from giving a VBAC, and a higher risk of blood transfusion and endometritis. While an elective repeat cesarean delivery increases the likelihood of cesarean delivery in future pregnancies, there's a longer hospital stay and convalescence, about 0.1 to 2% chance of serious surgical complications like bowel and bladder injury. There's increased risk of surgical complications with each subsequent cesarean deliveries due to adhesions and the placenta previa and placenta accreta. The neonatal benefits are immense in VBAC. The there's only less than 1% risk of transient respiratory morbidity in cases of VBAC. And there's extremely low risk of antepartum stillbirth, perinatal deaths, and HIE during labor in VBAC. So the American Academy of Family Physicians have laid down certain criteria for a successful VBAC, namely the maternal age less than 40, BMI less than 30, prior vaginal delivery, prior VBAC deliveries, favorable cervix, any labor that has a spontaneous onset, a previous cesarean for a non-recurrent indication, for example, a breech indication in the index pregnancy, almost has an 85% success of VBAC in subsequent pregnancies. There are other factors which decrease the likelihood of success of VBAC, including the previous number of cesarean deliveries. The higher the previous cesarean sections, the lower the success of VBAC. Gestational age beyond 40, fetal macrosomia more than 4, and wherever the labor is induced or augmented. Assessing the likelihood for successful VBAC as well as individual risks are important in determining appropriate candidate for trial of labor. ACOG approves maximum 2 previous lower transverse cesarean sections, vertex presentation, no other uterine scars, no history of previous uterine ruptures, a clinically adequate pelvis, and an ability to perform an emergency C-section whenever the need arises. So vast majority of women who desire a normal vaginal birth are actually candidates for VBAC. But there are some absolute contraindications which are related to the previous cesarean delivery, like the previous classical cesarean section, previous uterine rupture, particularly the upper segment uterine ruptures, uterine surgeries involving the full muscle thickness, and more than 2 previous cesarean sections. There are certain obstetric contraindications to VBAC, namely malpresentations, antepartum hemorrhage, severe PIH, and eclampsia. However, Grobman et al. Says that certain medical disorders like hypertension, heart disease, renal disease, seizure disorders have been found to have inconsistent evidence regarding the contraindication for VBAC, and VBAC can be tried in these cases. Few relative contraindications where the previous uterine scar is unknown, or there was an extension of the angles in the previous cesarean delivery, low vertical scar, T or J-shaped incision, previous B-Lynch sutures, twin gestation, breech presentation, and suspected macrosomia of more than 4 kgs all come under the relative contraindications. So in certain special circumstances, VBAC can be effectively planned. A preterm VBAC has similar success rates to a term VBAC. However, there is a lower risk of uterine rupture. Several studies have supported VBAC in twins with a success rate of 69 to 84%. The rate of uterine rupture was not found significantly higher in twin pregnancies. ACOG in 2010 says that women with 1 previous cesarean delivery with a low transverse incision who are otherwise candidates for a vaginal delivery can be offered a TOLAC. In breech presentations, there are better outcomes with elective repeat cesarean deliveries. And there are some societies like the Canadian Obs-Gynae Society which completely contraindicates breech for a trial of labor. Fetal macrosomia, again, the trial can be given, but there are better outcomes with elective repeat cesarean deliveries. So, when we are planning a VBAC, the antenatal assessment and counseling is extremely important. Discussion about TOLAC and elective repeat cesarean delivery should be initiated very early on in the booking visit itself. One has to discuss the various risks and benefits of VBAC and elective repeat cesarean delivery with the patient. We also have to note down the contraindications to VBAC, and if there are any obstetric complicating factors. We have to assess the patient's attitude towards the rare but serious adverse outcomes like rupture uterus. We also have to find out the likelihood of successful VBAC, particularly if she has had a previous vaginal birth or a previous VBAC. Her plans for future pregnancies does affect our management decision in this pregnancy, and her personal preference and motivation to achieve vaginal birth or cesarean delivery has to be noted and documented effectively. So now coming to the mode of delivery. One, at the booking visit, we have to note down all the patient preferences, choices, discuss risks and all. When the patient is in the first trimester screening, we have to rule out chromosomal anomalies, and we have to review all the previous medical records, any operative notes that the patient has, and document it effectively. Do the fetal anomaly scan by 20 weeks, do the placental localization, reassess the growth at 28, 32, and 36 weeks, and if there is any low-lying placenta, that has to be documented. So at 36 weeks, we have to assess and decide the mode of delivery. We have to assess the pelvis, the previous indications for cesarean delivery. If the patient opts for a VBAC, between 36 to 41 weeks, we can await for onset of VBAC labor. At 39 and 40 weeks, we can try sweeping off membranes. If the patient wants an elective repeat cesarean delivery, the most effective time where it could be planned is 39 weeks of gestation. Now coming to the intrapartum management, my previous speakers have very elaborately spoken about pain relief, about induction of labor, the various protocols. I would just want certain important points to be highlighted here. There has to be a detailed, informed, written consent. The labor should be conducted in a suitably staffed, well-equipped setting with a facility for emergency cesarean delivery and neonatal resuscitation, which should be available 24/7. An obstetrician, anesthesiologist, and a neonatologist should be immediately available if in case there is a need for their expertise. Induction of labor is preferable with mechanical methods. Oxytocin and PGE2 may be used to induce labor, but with caution. IV access and adequate blood cross-match should be reserved. Patient monitoring of vitals is important in active labor. A continuous fetal monitoring is preferred. Water birth can be tried, but we have to let the patient understand that in case of emergency, it is likely to delay the treatment, and we can still monitor the patient with wireless monitoring. Restrict oral intake in case the patient requires surgery or a general anesthesia. Adequate analgesia should be given. No contraindication for epidural analgesia. In fact, it does not reduce or mask the signs of rupture. There are clear plan on assessment of labor progress. The CTG has to be monitored and reviewed by a senior obstetrician. Augmentation or intervention in case of any suspected delay. Delivery is like any other routine delivery, but we may cut short the second stage of labor by using instrumental deliveries. Routine postpartum exploration of scar is not recommended. Now, rupture uterus is one of the most dreaded complications in VBAC, with an incidence of about 0.5 to 2% and a fetal morbidity of about 10 to 25%. In rupture, 1.5 per 10,000 births have a risk of perinatal death, and 4.8 per 10,000 have a risk of hysterectomy. Most of the uterine rupture in labor happens with the peak incidence at 4 to 5 centimeters in about 90% of the cases. In about 18%, the rupture happens in the second stage, and in about 8%, they are identified post-delivery. So the diagnosis of rupture uterus during a TOLAC is extremely important. all the labor room staff and the resident doctors should be trained in identifying the signs of rupture to avoid any surgical intervention. So acute abdominal pain persisting beyond contractions, a popping sensation, abnormal vaginal bleeding, hematuria, acute onset scar tenderness, increased need for epidural top-ups for pain relief, cessation of previous effective uterine activity, dramatic loss of station of presenting part is a very important sign. Maternal tachycardia, hypotension, and shock could be indicative. Change in abdominal contour and inability to pick up fetal heart rate at the old transducer site. Most reliable first sign is the non-reassuring fetal heart rate, and most specific sign is a persistent variable fetal heart rate deceleration. So early diagnosis of scar, dehiscence, or rupture followed by an expeditious delivery and neonatal resuscitation are crucial to reduce associated fetal and maternal morbidity and mortality. An observational study indicates a potential upper limit of non-hypoxic neonatal delivery of 18 minutes from the time of suspected uterine rupture to delivery. There are various factors which affect rupture uterus. First of all, the type of the scar. The classical scar has the highest rupture rates at 12%. Then comes the myomectomy scar with the cavity open or a transfundal previous surgeries. Almost 10% cases can have uterine rupture. The number of previous cesarean section, obviously more than 2 cesarean section has higher rupture rates. Interdelivery interval, previous vaginal delivery, previous history of rupture, wherein the upper segment rupture has almost 32% rate of uterine rupture as compared to the lower segment, which is 6%. Maternal age, maternal obesity, history of postpartum fever after previous cesarean section, and Mullerian duct anomalies, the relationships to the risk of uterine rupture have been examined in small studies, but definitive conclusions cannot yet be drawn. Induced labor has a scar rupture rate almost 3.5 times higher than the spontaneous labor. Similarly, cervical ripening with prostaglandins have 2.9% scar rupture rate as compared to mechanical dilatation like Foley's as 0.7%. Induction of labor with oxytocin has 2.3% rupture rates. Oxytocin induction increases the scar rupture by 3 times. Exposure of oxytocin before active labor increases the uterine rupture rates. Research has shown that uterine rupture risk goes down with each successful VBAC. So we must definitely look for these cases if we are documenting a VBAC for any subsequent pregnancies with previous VBAC. So other controversial
Madam, sorry
issues.
to interrupt, ma'am. Time is up, ma'am.
Yeah. So just a few important points. I have covered most of these. The ACOG guidelines are there. There's just a little difference with the RCOG, which recommends trial in previous 3 or more cesarean sections. I wanted to talk about the CDMR, which ACOG defines as a primary cesarean delivery at maternal request in the absence of any medical and obstetric indications. And FIGO also entails CDMR as a positive right of women. Now, the rates of CDMR are increasing, and willingness of obstetricians to oblige to these requests are also increasing. One, namely because the surgeries have become safe because of good asepsis, advancements in anesthesia drugs, and surgical techniques. There is a need to develop a treatment guideline and protocol for CDMR that will suit our environment in order to stop overburdening the already existing healthcare system. Why doctors don't support VBAC? I have just one thing to say, that most obstetricians are sued for not doing a C-section than for doing it. But there could be other reasons also. But the most important step in reducing the C-section rates is by reducing the primary cesarean rates and by reducing the repeat C-sections. So one has to reduce the primary cesarean section rates by following the best practices guidelines laid by various organizations and avoiding unnecessary interventions and therefore a higher cesareans. We need to support women better about how their babies are born. Cesarean sections or vaginal delivery is a choice, and probably the need is there. But as an obstetrician, we need to ensure safety in the choices of the women. Thank you so much for your patient hearing.
Just I want to stress on one thing is, as you said, you have to think twice or thrice before doing the primary cesarean section. That's how you can reduce the VBACs. Then another thing is documentation of the first cesarean. Nowadays, we are very much afraid of giving a second vaginal VBAC because we don't know where it was done, how it was done, are there any complications associated with it. All these things have to be documented by the person who has done the primary cesarean section. Then our decision of VBAC will be very easy. So that is one another thing. Another thing is, I feel that in post-cesarean pregnancies, it may not be a frank rupture of the uterus, it is only the scar dehiscence which we are very much worried about. And how to detect the scar dehiscence when we were students, we used to tell is always keep your hand on the pulse of the mother. That is first thing that you must always look into, the tachycardia in a mother, then followed by the baby's tachycardia is another thing. So another thing in VBAC is that VBAC failures may not be there if you do a group practice or a institutional delivery rather than a single obstetrician taking the risk of delivering a post-cesarean deliveries. I think we are running out of time. So I'll call on Dr. Rajiv Menon.
Madam, last comment. Because VBACs are very important because of our Telangana, the goal
Yeah,
to
I
reach
heard.
at
I
least
heard
around 15%. See, the most important point for me is, if it's scar dehiscence happens, how much time we have. Of course, we will have the anesthesiologist in the house, in-house, but shifting and arranging, because we have seen within minutes losing the baby. I mean, way back when I was there in Fernandez, card prolapse case, and there is a door between a labor room and OT. We just shifted across the door.
Yes,
The patient, when we have diagnosed cord prolapse, we did a delivery, baby cried, we were very happy, but to feel very sad at the end of 1 year, baby is totally brain affected, cord prolapse. So many a times when we have opened for the repeat section, we thank our luck. Very thin, only the serosa is lying there, and she was not in labor, we have done the section. So during labor pains, the thin serosa, how much it will bear the labor pains.
That is very difficult.
So why nobody is mentioning about his scar dehiscence, how to monitor? Because I keep sending my patients
the
to one of the
VBAC,
best
that's what I'm
sonologists.
saying, no, primary cesarean documentation is 100% mandatory. If you have the documentation of the primary cesarean, then your decision of giving VBAC will, because when I was in Sultan Bazar, we used to get post-cesarean pregnancies from Bongiri. Beginning stages, we didn't know that we used to say that we'll give a VBAC and we used to end in scar ruptures. Then ultimately, one of our indications for cesarean is Bongiri cesarean section. That has become like that. So it is the person who is doing, it is the place where they are doing. These two are very, very important. And that's why when a periphery cesarean section is done, I don't dare to give a vaginal delivery because the scars are very, very high at the level of upper and lower segments instead of giving a low cesarean scars. Yes. So as you say, it is always walking on a fire when you have taken a decision for VBAC. These days, when compared to our places, because the cesarean sections were not done like this, in primary cesarean sections were not done at any place where they like, usually in the institutions with good indications we used to do. But the cesarean section rate has increased. So to go out of VBAC tragedy, we have to go back and see that the primary cesarean sections are reduced. That's
But
what I
at times when we repair also, we do see, we should accept that, because when a lower segment, there is an in proportion between the upper edge, upper flap and lower flap, and we hardly take that the stitches will be giving off. So even we do also, next time, I have seen that, there will be thin. So why can't we have a monitoring of or at least to have a rough idea around 38 weeks time where the maximum stretching with the big size of baby, so we can have roughly and counsel the patients. So you are not, definitely not a case when there is a 1.5 millimeter thickness of the scar, how can we give?
Okay, scar studying by scan is one of the things that you can go.
I wanted to add that by ultrasound and MRI, we do identify
Scar.
the scar thickness, but it is not considered as a very reliable
not a
marker for prevention of scar dehiscence.
I would just like to add, Pratibha, one small thing, that all the juniors, when we are allowing the patient for a VBAC, the catheter should be placed um, very early, because hematuria is a very good sign. And maternal tachycardia, fetal tachycardia, and ultrasound is important at 36 weeks to know the scar. Yeah, only then we can, these things are not being done nowadays.
Thank you.
I kindly request Satyavati madam to introduce Raju Menon sir.
Invite Dr. Raju Menon as a director and HOD of AIG Institute of Cardiovascular Disease, Hyderabad. Previously, he was a chief of medical services, Care Group of Hospitals, medical director, Care Hospital, High Tech City, consultant cardiologist, Care Hospitals between 2005 to 2019. He passed MBBS from Usmania Medical College, MD from Gandhi, and DNB from Care Hospitals. He has many publications to his credit. I invite Raju Menon to talk on his subject.
Good morning, everyone. Thank you, chairpersons. Thank you, Dr. Lakshmi Ratna madam and Ankura Hospitals for having me here. It's more of a homecoming coming here, because there are many people who are sitting in the audience with whom I used to play as a child. So my mother is a gynecologist, Dr. Vinod Kunwar, and Dr. Lakshmi Ratna, we used to call her gold medal candidate, because she got gold medal in obstetrics at that time. So that's how I used to recognize her. Venkat Reddy sir and many more here. Pratibha madam was my professor when I was doing my house surgency, and if you don't take it outside, she made me do some LSCS also. So, so thank you for having me here. And in the next, can I just have a show of hands of how many of you are postgraduates here? Okay, quite a few, because there is some pathophysiology and all which is being discussed, so it will be quite boring for practicing obstetricians. So next 15 minutes or so, we'll just try to touch upon certain practical aspects of management of peripartum cardiomyopathy. And probably when I gave this talk around 15 or 17 years back, not much has changed as far as the management is concerned. But our understanding of the disease per se seems to have improved, more because of some of the improvements which have occurred in the field of cardiology. So we'll just touch upon those issues. We'll start with a case vignette. So this was a 27-year-old lady, para 2 live 2 births, 2 LSCS. She had an uneventful first pregnancy. I think it's resounding. Sister had peripartum cardiomyopathy. So she had a family history of peripartum cardiomyopathy. Dyspnea after 5 days after delivery, and then she came to us and she was found to have severe LV dysfunction. This is about around 10 days back. And she was diagnosed as peripartum cardiomyopathy with heart failures. So if you look at the right, you can see a normally contracting left ventricle, and to the left you can see, or to the left you can see the normally contracting left ventricle, and see how briskly the LV is contracting. And the same thing here. You can see the amount of severe LV dysfunction. Pointer. Yeah. So this ejection fraction is around 20%. So this is a severe LV dysfunction. So what next? What do we do next? So this is the outline of the talk. These are basically the questions which we need to answer when we have a patient who comes to us with peripartum cardiomyopathy. The first is it peripartum cardiomyopathy? Why do we need to answer this? Because there are many other conditions which might mimic just like peripartum cardiomyopathy. So what is the definition of peripartum cardiomyopathy? Originally, when it was described as the last month of pregnancy to the first 5 months. But then they realized there are a lot of cases of peripartum cardiomyopathy which might be missed by this definition. So the European Society of Cardiology came with a more broad definition, a lenient definition where it says somewhere towards the end of pregnancy and then after delivery, where most importantly, no other cause of heart LV dysfunction is actually found out. So you need to, it's a more of a diagnosis of exclusion rather than a primary diagnosis. Now don't get really threatened or perturbed by this slide. I will just go through that very simply, and this will be extremely important to understand what actually is happening inside. So the pathobiology is referred to as a two-hit model, where basically the patient has genetic susceptibility. Now in the presence of genetic susceptibility, there are two competing things. One is the anti-angiogenic, that is, if there is an injury to the myocyte, it increases the injury to the endothelium and the myocyte, whereas the other is pro-angiogenic, which is helpful. Here the major part is played by the prolactin. So how does that occur? So there is a transcription factor which is called STAT3, which generally increases in pregnancy. In patients with peripartum cardiomyopathy or knockout mice, it comes down. That basically causes increase in oxidative stress and causes increase in cathepsin. Cathepsin is the one which changes the 23 kDa protein of prolactin into 16 kDa. Now this is the biggest villain as far as peripartum cardiomyopathy is concerned. It acts directly on the endothelium, causes lot of miRNA to be secreted, which causes a direct injury to the cardiac myocyte. So that's how prolactin is involved. This is important because the newer management strategies are trying to target these particular aspects of the pathobiology. The other concept is the concept of fetal mycochimerism, where the thought is certain fetal cells go and get deposited in the myocytes. There's autoimmune reaction, and that actually produces myocardial damage, but that has not been proven. Now, on one side is the anti-angiogenic, but there is also a pro-angiogenic factors like vascular growth, endothelial factor, and relaxin, which are actually beneficial to reduce the chances of peripartum cardiomyopathy. So if you look at the SFLT1, I think all of you might be knowing from the preeclampsia studies, this goes up significantly. Now this is a major blocker of VEGF, which again VEGF is protective. So the absence of VEGF causes endothelial dysfunction, and in effect it causes cardiomyopathy. So if you understand certain basic concepts, I just put in this diagram so that if you understand this, then you'll understand why the treatment strategies are targeted at each particular aspect of this. So what are the risk factors? These are all been known for more than 20 years, so I won't go into too many details, preeclampsia, race, zinc, selenium deficiency. None of those deficiencies have been proven. Genetics, if you are looking at a genetic study, you look at something like TTN and BAG3, and long-term tocolytic therapy, again, plus minus, whether it actually produces higher chances. And increasing parity, of course, increases the chances of peripartum cardiomyopathy, though it occurs most commonly in the first 1 or 2 pregnancies. So this is just to show you that irrespective of the year in which it was studied, as the age increases, you can see that there is a progressive increase in the chances of peripartum cardiomyopathy. Now the second step, so first you should know what is peripartum cardiomyopathy. So we have looked at the definition of peripartum cardiomyopathy. The second aspect is we told that we have to rule out other causes. So fundamentally we need to make sure it's PPECM after we have excluded other causes. So what are the other causes? Preeclampsia, eclampsia is a very close mimicker because it can produce what is called afterload mismatch, which can produce significant LV dysfunction. Ischemia in a pregnant lady could occur because of atherosclerosis, vasospasm, dissection, or because of embolism. Stress cardiomyopathy, this is just to show you an echo. So there is no reason why obstetricians should not read echoes. You do ultrasounds regularly, you read ultrasounds regularly. Echo is just an extension of ultrasound. So you should learn to read echoes, and it makes a huge difference. Whether a cardiologist or physician is there or not, you'll be able to identify certain major issues in pregnant ladies. So if you see here, I hope, pointer you're able to see, you can see that the basal segments are contracting very well and the apical segment is ballooned out. So this is called the apical ballooning syndrome or the Takasubo syndrome, which is stress cardiomyopathy. What are the other causes? Arrhythmias, valvular heart disease, pulmonary embolism, amniotic fluid embolism, asthma. These are all other differential diagnoses. Now, the common thought process is, okay, we don't know whether it is PPCM or not, let's get an echo done. But remember that there are certain situations where echo won't differentiate PPCM from other conditions. Like, say, a patient had already DCMP, not diagnosed. She did not present in early pregnancy. Then you land into trouble. Stress cardiomyopathy, as I just mentioned to you, if the apical ballooning is not there, it could be just a global LV dysfunction, then you will not be able to differentiate. Afterload mismatch, suddenly your BP goes up to 200, 120. Then it's something like you have clamped the aorta. The LV has no other way but to dilate and develop LV dysfunction. So again, you won't be able to differentiate whether it is PPCM or whether it is afterload mismatch. Of course, systemic conditions like inflammatory myocarditis, etc. Now, having said that, when it's difficult to differentiate, what are the clues? One, of course, we mentioned about the echocardiogram. Now, this is just to show you the different echoes. You see 4 echoes on the screen. All the 4 have severe LV dysfunction. You can see the heart is hardly contracting. But if you see the etiology, all these 4 are different. This is dilated cardiomyopathy, this is sarcoid, this is a valvular heart disease patient, and this is the patient which we just saw. So the first clue, and a very important clue, is of course the timing. So we know that the cardiac output peaks around the second trimester. So then it plateaus. So this is the place where it peaks maximum. Now when this occurs, we know that patients with pre-existing cardiac disorders, this is the time frame where they tend to deteriorate. Whereas if you have peripartum cardiomyopathy, as was mentioned, it is more later. So it's, we now know that PPCM can occur early in pregnancy, but this immediately gives us a clue whether we need to look for a pre-existing cardiac condition versus PPCM. What are the investigations? We of course have to do a ECG and echo. MRI 1.5 Tesla is safe, gadolinium is contraindicated, CT if it is a must. So again, mother's life is more important. So if CT is a must, do a fetal shielding and go ahead with a CT, like patients like pulmonary thromboembolism where you need to make therapeutic decisions. Endomyocardial biopsy is done very rarely, but there are few conditions like lymphocytic myocarditis, giant cell myocarditis, sarcoidosis. Here, the treatment can completely change. So if there is a high suspicion, then those are the cases where you would want to do endomyocardial biopsy. When do we send for genetic testing? If that particular patient, the index patient, has family history of cardiomyopathy, family history of sudden cardiac arrest, or family history of peripartum cardiomyopathy. So you need to do a genetic testing in those situations. Now, how do we manage? So having diagnosed a peripartum cardiomyopathy, is there anything different, or we just manage as any other routine cardiomyopathy? So loop diuretics, again, I won't go into too many details because this has been taught for more than 20 years now. Most of them are safe. Digoxin can be given. Low molecular weight heparin is preferred over heparin. The issue about anticoagulation, remember that warfarin is given in pregnancy only when the patient is having a mechanical heart valve, because the risk of thrombosis there is the maximum. But in all other conditions, it is low molecular weight heparin. Don't give warfarin for a patient with peripartum cardiomyopathy. So anticoagulation in PPCM, indications, if the ejection fraction is less than 30 to 35%. So we said less than 45% is definition, but less than 35% you continue with anticoagulation, or if the patient is on bromocriptine. What about shock? So in shock, there's controversy whether to give dobutamine or something else. Levosimendan is a calcium sensitizer. So if you have a peripartum cardiomyopathy and patient has gone into shock, you might prefer to use levosimendan rather than a beta agonist, which might have other side effects. Not to be used, again, ACE, ARBs, aldosterone antagonists, all this you know. And dobutamine, again, may not be the first choice. If you have no option, you have to start. But levosimendan might be advisable over dobutamine. Delivery considerations. So you have a patient with heart failure, she's still pregnant, not delivered. She's stable, of course, continue till vaginal delivery. The same thing which is similar to all cardiac conditions, assisted second stage with proper anesthesia. But if the patient has acute heart failure, you have no other go but to go ahead with the LSCS. Don't delay LSCS if the patient has deteriorated. Bromocriptine, again, probably the most used, least studied, and most controversial drug. So its use is still controversial. Risk of embolic phenomena in spite of anticoagulation. Way to use currently. Do we use for all patients or in specific cases? Severe LV dysfunction. If the EF is less than 25%, probably the benefit of bromocriptine is more than the risks involved with it. Patients in shock, again, start of bromocriptine. The rebirth trial is now enrolling, so I think we'll get some data on this drug which we have not known for such a long time. Now, what about lactation? So here there are two things which we need to remember. One, the benefit of breastfeeding might outweigh the risks of giving bromocriptine, but it is not that you are giving bromocriptine only for LV dysfunction. Patients with LV dysfunction who have decompensated heart failure, lactation is not advisable. So if you want to suppress lactation, at the same time you want to treat LV dysfunction, then it's an excellent drug because it is doing two things for you. But if you don't want to suppress lactation, then whether you want to give bromocriptine or not, you use that criteria of EF less than 25% and presence of shock. How do we give? 2.5 mg twice daily for 2 weeks and then once daily for 6 weeks. Now, these are all the experimental therapies. If you look at them, the antisense, all these we mentioned, microRNA, the SLFT1, VEGF, relaxin. So all these we had already mentioned in our pathobiology. So each part of it is being checked now, and hopefully we'll get some answers in near future where we'll get a less toxic therapy. The advantage of antisense therapy under of microRNA is they can continue breastfeeding, and at the same time they can reverse the LV dysfunction. What are the outcomes? Mortality is around 7 to 20%. Recovery generally occurs. If it occurs within 3 to 6 months, not later. 50 to 70% recover to EF more than 50%. What is the prognosis? How do we assess if somebody will have a bad prognosis? EF less than 30%. So this is the IPAC study where you can see the red line where EF is less than 30 and the blue more than 30. You can clearly see that there is a huge mortality difference between less than 30 and more than 40. LV and diastolic diameter more than 6 centimeter. If you have a EF less than 30 and diameter more than 6 at presentation, more than 90% will not recover their LV function. So it's better to prognosticate the patient and the family beforehand that these people are not going to do well. Of course, troponin, BNP, SFLT numbers, all these are being tested now to assess. RV dysfunction definitely is a bad indicator. And of course, the African-American do worse compared to the other population. What about better prognosis? So somebody who has a higher BP at presentation might be better. The reason, probably there might be a component of afterload mismatch. So when you have a pre-eclampsia, eclampsia, and there's afterload mismatch, all of it may not be PPCM. Some of it might be related to afterload mismatch. That's the reason why the recovery chances are higher. Complications, thromboembolism around 6.6%, shock, and arrhythmias can occur, which can cause 25% of the deaths. How do we plan the next pregnancy? So you have treated the patient, you have sent her back home, she comes back to you and asks, what about the second child? So the EF, again, before the next pregnancy is the strongest predictor. If it is more than 50%, remember it is not totally safe. That's a misconception that heart has recovered completely, so they can go ahead with the next pregnancy. 20% risk of deterioration is still there, but deterioration in LV function. Whereas if it is less than 50%, there is a 50% risk of deterioration and heart failure. So this is very high. It is an absolute no-no if the ejection fraction is less than 50%. Now what do you do? Now we know AC inhibitors, ARBs are given when in a lactating mother. Now the LV function has improved. They want to plan another pregnancy. What do you do with the AC inhibitors, ARBs and beta blockers? So in recovered ejection fraction, you reassess by stopping AC inhibitors, ARBs and spironolactone for 3 months. And then see what happens. If the LV function is normal, it comes back to the same thing what we mentioned, 20% risk. But if the LV function deteriorates, again, get them back onto the tablets and don't plan for another pregnancy. This is because there's a lot of literature on recovered ejection fraction. All these main 4 or 5 line of drugs which we use in LV dysfunction, if we stop after the LV recovers, within 6 months, most of the patient deteriorate again. So kindly do not stop the medications unless there is a definitive indication. Do we do stress echocardiography to this EF more than 50%? We still don't know, but strain rate limiting stress echocardiography, all this we are trying to find out if this will make a difference in the subsequent outcomes. So this is a kind of algorithm which you can follow. So you do an echo before planning pregnancy, for the second pregnancy in a PPCM, prior to conception, end of first trimester, second trimester, 1 month prior to delivery, after delivery prior to discharge, and 1 month after discharge. And if it deteriorates, what to do? Again, follow the same algorithm which was given in PPCM. So let's go back to our case, which we discussed. So she was started on a heart failure therapy, diuretic, ACE inhibitors, spironolactone were given. She was given bromocriptine and anticoagulation. As mentioned, EF was less than 25%. She was in heart failure, so there was no way that we wanted her to continue lactation. So anticoagulation along with bromocriptine, low molecular weight heparin was given. She had an uneventful recovery. She was discharged about a couple of days back, and she is to be followed up in OPD. We have sent the genetic analysis. We need to check because her sister also had PPCM. This report should come in probably about 4 to 6 weeks time. So ladies and gentlemen, just I would conclude saying that peripartum cardiomyopathy remains a rare cause of heart failure in pregnancy. Onset of symptoms and echo are fundamental in excluding other causes. Prompt diagnosis and management helps in improving outcomes. Counseling for subsequent pregnancies primarily is based on LV recovery. And finally, team approach is what makes all the difference. Thank you so much. I think current is not.
So, 1 or 2 questions from the audience, not many. Because time is, we are 1 hour away.
Is there a relationship of hypothyroidism, anti-TPO antibodies to peripartum cardiomyopathy? Because one of our case at Gandhi Hospital with hypothyroidism, and she was on treatment with levothyroxine, but she ended in postpartum cardiomyopathy. And in some other references also, I came to know that this anti-TPO antibodies and low thyroid levels relation to this postpartum cardiomyopathy.
So autoimmune myocarditis again has been studied in detail. Among them, some of the things which have been referred to are anti-TPO antibodies also. But the issue is there is no way of proving or disproving any of these things. Because of pregnancy and radiation issues, it's very difficult to prove or disprove. So just give the drug, and if it improves, say that, okay, it was probably related to hypothyroidism. But that's the reason why I think peripartum cardiomyopathy is definitely one of the less studied things in obstetric, though we see so many PPCMs. Pratibha madam actually published a paper also, and it's, yeah.
You are telling it is a rare disease, but how, as a obstetrician, how frequently we can recommend the 2D echo for all the patients, and which is the best type during pregnancy? Is it recommended for all the women or only any history?
It cannot be recommended to all the women because it is not possible. What I would suggest is symptoms. So if the patient has symptoms, very unlikely that patient will have LV dysfunction, and especially acute onset LV dysfunction, and will not have any symptoms at all. So all these, now suppose epidemiologically we are saying that it is towards the end of pregnancy and early period after delivery. We don't know whether this patient actually had PPCM somewhere around 4th month, but it came out after delivery, after labor. So that itself is not proven. But a routine echocardiography for everyone is not recommended unless they have symptoms. They have symptoms, yes, definitely at least one baseline ECG and echo should be done. Thank you.
I request Satyavati madam to present a memento to Rajiv Menon sir. Sir, please come on to the dais, sir. I request Satyavati madam to present a memento to Rajiv Menon sir. Sir, please come on to the dais, sir. I request Aditya Kapra sir to present a memento to Rishta Reddy madam. Madam has left, it seems. I request Aditya Kapra sir to present memento to Pratibha Narayan madam. Now I request our beloved Lakshmi Ratna ma'am to present a memento to Malti ma'am. Malti ma'am, please come on to the dais. I request Priyamvada madam to present a memento to Anupama Hari madam. I request Srilata madam to present a memento to Anupama Hari madam. Now I request Priyamvada madam to present a memento to Aditya Kapra sir. Thank you for chairing the session, sir. Now let's proceed to the next session. I would like to invite Dr. Uma Devi madam to chair the session. Uma Devi madam is a senior consultant and laparoscopic surgeon at KIMS Hospital, Secunderabad. She is a retired professor, Gandhi Medical College, Gandhi Hospital, Secunderabad. Now I request Meka Krishnakumari madam to come on to the dais to chair a session. Madam is a HM Lazarus gold medal in MD. Okay. Now Krishna Kumari madam is a professor Apollo Hospitals, Hyderabad. Now I request Lakshmi Ratna madam to chair the session. Please come on to the dais, ma'am. Meka Krishna Kumari madam is a HM Lazarus gold medal in MD. She is a professor Apollo Hospitals, Hyderabad. I request Lakshmi Ratna madam to chair the session. Now I request Durga Rao madam to come on to the dais. Please, I request Uma madam to introduce Durga Rao madam about the topic myths about AMH.
Thank you very much, Lakshmi madam. And I'm very happy to introduce Dr. Durga G. Rao. She's a co-founder and medical director of Oasis Fertility. And she's a specialist in reproductive medicine, minimally invasive surgery with overall 26 years of experience. And Oasis, she was in UK and Canada for a period of 12 years. She's a pioneer in research and practice of IVF, treatment and fertility preservation. She's responsible for introducing IVM, that is maturation, in vitro maturation in advanced fertility treatment in India, especially in women with cancer, PCOS, resistant ovarian syndrome, thrombophilia, oocyte maturation problems. She has set up exclusive academic and research wing in Oasis Hospital, and provides a training to center. It's a center for gynecologists for training, and she has numerous papers and publications. So welcome, Dr. Durga.
Thank you very much for the introduction, and thank you, Dr. Lakshmi Ratna Madam, for the invitation as well. And she chose to give me a topic which we think that we understand a lot of, which is AMH, because I think in terms of investigations, it is no longer the purview of fertility specialist. I think everybody, right from a postgraduate to a specialist, is ordering an AMH. So let's understand a little bit more about this particular hormone. Just to give us a brief outline as to what we are talking about in terms of the hormone, it's a glycoprotein, and the most important thing is it comes from the TGF family, and we have a gene located on chromosome 19 that actually helps in terms of transcripting this hormone. These receptors are not just in the ovary or the endometrium as we understand it. There's a wide ramification in terms of what AMH does in the system. It is also there in the males in terms of the Sertoli and the Leydig cells, and in the ovaries it is being released by the granulosa cell. It is being released by the prostate, endometrium, mammary gland, placenta, and so on. Now, what is it about AMH? The first thing that we have to understand about AMH is it actually starts even before the delivery of the neonate. It is from the 36 weeks of gestation, and it only stops getting secreted when you reach menopause. But when you're going to test it around the neonatal term, that's when you see it to be the lowest, other than when it is at menopause. The highest is when a woman is at 25. Now, what is AMH? Why is it something that has become so routine in terms of our investigation? It has become a routine in our investigations because we have to counsel patients in terms of their chances and how long they should wait before they consider having a child. Now, what we really need is understanding what the primordial follicle pool is. But unfortunately, the primordial follicle pool does not have cells which can release any kind of hormone. So we have to rely on the second best. So understand that AMH is actually the second best marker. And this marker is being released by the antral follicles from the diameter of 2 millimeters up to 7 to 8 millimeters. But the actual reserve is even below that in the primordial follicle pool. What are the actions of AMH? AMH, in fact, is one of the markers which keeps the primordial follicle pool intact. What do I mean by that? What I mean is that these primordial follicles, which in future should become the dominant follicles or at least get sensitive to the FSH, are being suppressed. So what AMH is actually doing is it is trying to conserve and keep as many follicles in the primordial follicle group rather than get them to get recruited. Because once they get recruited, they either dominate and they ovulate or they undergo atresia. So what AMH does is a very important function to keep the reserve intact. Now, the lack of AMH obviously means that the follicles will get recruited and the reserve will come down quicker. AMH is also supposed to inhibit the beginning of the follicle growth, that is, make the follicle FSH dependent. Now, once FSH, which is being secreted by the HPO axis, if the follicle gets sensitive to that, it starts to develop. And once it starts to develop, like we said, it either becomes an ovulatory ovum or it undergoes atresia. So what is the first myth? Whenever we are talking about AMH, the first thing we say is you can do it at any time. You know, when we are talking about FSH and LH, we said it has to be done between day 2 and day 5. What about AMH? Are we very sure that it is constant during the menstrual cycle? Currently, we are not very sure. And why am I saying currently is because the kind of assays that we have now for AMH are much more accurate. And what we have found is there is a variation of at least 10 to 20% in terms of when you are doing the AMH. If you do it in the early follicular phase is when it is most accurate. It tends to be highest at the time of ovulation, and then during the luteal phase it comes down. So that's one myth busted. Now, AMH is also correlated with ovarian response and is a very good predictor of oocyte yield following ART. So what is the first myth? Higher the AMH,
the better it is for the patient. Are we right in saying that? No. Why? Because it is a predictor of excessive response. So the higher the AMH, the more responsive the woman is to the medications that you're going to give them, and she will be at a high risk for OHSS. In fertility, fortunately, I mean, having listened to all the complications that obstetrics can provide, in fertility we have only two complications. One is OHSS, and the second is multiple pregnancy. Nowadays, with the kind of advent that we have, OHSS is really coming down because we have understood more about it. So, if anybody wants a safe field, please come to fertility. Now, AMH, in terms of once you see a higher range of AMH, you have to be very cautious as to what kind of medications you're going to give them, what dose you're going to give them, and how long you're going to give them. Because you don't want a woman to have an iatrogenic complications like OHSS. And the cutoff is between 3 to 4. Once an AMH crosses 3 to 3.5, that's when you realize that this woman is going to really respond too well to the medications, and you need to go extremely slowly. The second thing is once you have an AMH that is lower than 1.1 or 1.2, that's when you also have to understand that her response is going to be lower than expected for her age. Now the third myth, in PCOS, we know PCOS, AMH is high. So if you have a PCO woman and you see an AMH value, are we saying that the higher the AMH, the better the outcome? Again, the answer to that is no. An increased serum AMH level is actually inversely correlated with clinical pregnancy and live birth. So if you see the forest plot of the top one, that is about clinical pregnancy. And as you can see, the higher the AMH, the lower is the clinical pregnancy. And if you look at the lower forest plot, that is about live birth. And we also know that AMH has a correlation with the severity of PCO. We know PCO has different genotypes, right? We are talking about phenotype A to phenotype D. Now, as the severity of PCO goes up, so does your AMH, and so does your outcomes in terms of fertility treatments. Another myth, AMH is superior to AFC. As fertility specialists, and I'm sure most of the gynecologists as well, our tool which we depend on immensely is the ultrasound scan. So should we depend on an antral follicle count or an AMH? Again, a lot of analysis on this, and we have come to the conclusion now that if we had to pick either of them, our first decision is to see whether we can get both together. AMH plus AFC is the best. But if I had to pick AMH or AFC and then decide which would be better, for me, an ultrasound scan, which I'm doing. You're looking at the ovarian volume, you're looking at the accessibility of the ovary, you're looking at the number of follicles that you see, which are the ones that are going to be recruited in the following cycle. What did we say? We said AMH is from the small antral follicles. The ones that will respond to your injections are the ones that are actually visible on scan. So for us, AFC is important. But when you have a patient in front of you, does she understand the scan as you do? The answer is no. She understands a piece of paper with a figure on it. She can Google it, she can do whatever she wants to do, she can get a second opinion, she can get a third opinion, they will all tell you the same thing. AFC is something that I know. My colleagues will know, but not the patient. But if a comparison was done, they found that AFC was relatively better than AMH in terms of giving them the sensitivity in terms of their chances. Then are we saying that if AMH is very low, it means no pregnancy? If you see an AMH of 0.9, what does that actually mean? It means nothing really. Markers of ovarian reserve as predictors of future fertility, AMH is actually not a predictor of pregnancy. So time to conceive cohort, when they were looking at these patients, they found that they did not find a low risk of future live birth in a woman with a low serum AMH when you compared her to the normal ovarian reserve. And if you actually, adjusted them for age, race, obesity, or use of hormonal contraception. I'm sure we always looked at an AMH and said and got worried and got our patients worried too. But I think what we have to understand today is AMH is an indicator for you to plan, not for you to say you will not conceive. Now, there have been a lot of data on this. In fact, even now, out of 36, when they looked at this in a meta-analysis that was published just this year, out of 36 publications, 25 of them said that it does not appear to impact live birth. You look at another 11 in the same thing, which were retrospective, they said it is a good prognosticator. So where are we right now? We are still on the same dictum that it should not be used as a sole criteria for either rejecting a woman for fertility treatments or to convince her that she's not going to get pregnant. In fact, we looked at our own data. This is from Indian population and definitely from Andhra and Telangana. And our objective was to see what the association was between AMH and live birth. And this was rated as the best paper in SR, which was presented last year by one of our fellows. So what we really looked was a study population wherein the women were aged between 21 to 40. And we looked at these two groups, one in which an AMH was less than 1.2, and another one in which the AMH was more than 1.3. And if you look at the results, now we have actually segregated them and we found that their baseline characteristics and demography was all similar. If you can look at the p-value, there is nothing which is significant here. Look at the outcomes. Look at the implantation rates, look at the pregnancy rates, look at the live birth rate, and more importantly, look at the miscarriage rate. We don't see a difference. But where do we see a difference? It's here. The number of oocytes retrieved, the number of mature oocytes retrieved, the number that actually became blastocyst, and therefore the serum estradiol at the time of trigger. These made a difference when we looked at the two different groups, but not the live birth. So, low AMH, when compared to normal levels of AMH, gives you lower rates of oocyte retrieval, lower number of mature oocytes, lower number of blastocysts, but neither the implantation rates, clinical pregnancy, miscarriage, nor live birth was deferred when blastocysts were transferred. So what was our conclusion? Low AMH per se is not a risk factor for decrease in live birth rates in IVF. It is a quantitative marker, not a qualitative marker. And in case of low AMH, embryo pooling might be advisable rather than opting for a third-party reproduction. Let's move on. What about other myths? BMI has an effect on AMH. Right now, we are still not sure. There are some studies which say that the higher the BMI, the lower your AMH is going to be. But again, it's not very conclusive. Now, what about medications? Because most of the time, whenever we see patients, they have had a lot of treatments before they come to us. And then you do an AMH. When you put them on metformin, your AMH is going to be lower, which is why metformin is one of the drugs that is given for PCO women. What about DHEAS, which is given for people with low reserve? Well, the data is very clear that DHEAS does improve your AMH. What about, we have been discussing only about women. What about men? Even in men, if you have a low AMH, your counts, your motility, your concentration is lower. And the new kid on the block in terms of vitamin D, even that makes a difference. So this is a list of medications wherein if a woman is on oral contraceptive, your AMH is low. She's on metformin, it lowers your AMH. If she's on GnRH agonist, we are still not very sure. DHEA improves your AMH, vitamin D improves your AMH, Clomid and letrozole both reduce your AMH. So this is a comprehensive understanding of what medications actually do for AMH. Now, is AMH only an investigation for fertility specialist? Again, the answer is no. Why? Because as gynecologists, you do tend to see women with endometriosis. You tend to see women with cysts. What do? It's very important to have, at least in the reproductive age woman, a pre-operative understanding of what her reserve is. so that you can plan your surgery better. If she has a good reserve, go ahead, do your cystectomy and let her conceive naturally. But even before you're taking her for surgery, if her reserve is lower, the first thing that you have to think about is whether you should be considering fertility preservation. If she's a young child, even we have done fertility preservation for a child who had cancer at 13. So age is no longer a restriction for oocyte vitrification. And if this is a woman who's married, embryo vitrification. What about hysterectomy? Because that's another thing that as gynecologists we need to know. Even though we need to do hysterectomy for whatever reason, if she's in the reproductive age, if she's less than 45, what is the impact that just a hysterectomy will have on her AMH or her ovarian reserve? Why are we looking at that? We are looking at her menopausal symptoms. And as you can see, the hysterectomy also, even though you are conserving your ovaries, does reduce your AMH. So this also is one of the factors that we have to keep in mind when we are considering a major surgery like hysterectomy. Post-chemotherapy, you might come across people who are actually going in for either chemotherapy or radiation. Again, AMH is definitely going to get impacted here. And there's also cutoffs that we have, that if you have an AMH which is less than 0.5, she's more likely to end up being amenorrheic after her gonadotoxic treatments rather than when she has a better AMH. Again, a clue for us to consider fertility preservation. Another one. Since we are speaking about all of this, can we use AMH to predict menopause? When you come to my age, the first thing that troubles us is menopause. Can we do something about it? Because obviously HRT has its complications. Yes, HRT is still safe, and now I think we have understood how to utilize HRT. But in certain groups of people, we still cannot give HRT as easily as we would like to. So can we predict it with AMH? Right now, the answer is still inconclusive. Lots of data out there. What we can still say is that the lower the AMH, the quicker the menopause is going to be, but you do not have a cutoff which tells you in 5 years she's going to get menopausal. We don't have that data yet. But AMH has no implications in terms of your birth weight, your gestational age, at delivery, even if you adjust for maternal age. There is no relation to that and pregnancy losses like the study that I showed you, and there's also no relation in terms of congenital anomalies. To summarize, AMH tells you about the number of mature oocytes that you will retrieve at IVF. It is a better predictor than FSH or other markers. And it is used to help in terms of a specialist to understand what gonadotropin dosage to give and what stimulation protocol to maximize the number of oocytes to retrieved. But the most important aspect that you should remember is it should not be used as a fertility biomarker in women who are trying to conceive naturally without a history of infertility. I think at the end of my talk, this is what I need you to understand. Unless a woman is infertile, what do I mean by that? She has been trying for more than a year. But if she hasn't been trying for a year and we do an AMH, this should not be an indicator for us to consider fertility treatments. She should still be given the choice to start or try naturally, because we still do not say that an AMH is a predictor of successful pregnancy. Screening of AMH before fertility treatment should be used to estimate the expected response, and again, not to withhold treatment. So all in all, it is a counseling tool. Now, just to give you a brief update on what AMH does, if you look at race and ethnicity, the white people or the Caucasians seem to have a higher AMH than either the black, either the Chinese, the Latins, and please add Indians as well. Indians, we tend to have lower AMH than our counterparts in the West. If you have systemic illness, AMH decreases. You're a BRCA1 carrier, your AMH decreases. Another indication for fertility preservation. Fragile X mutation,
we are running short of time.
Another indicator for fertility preservation. Last slide, thank you. And if you're looking at reproductive factors, if you are suppressing it with OC pills, GnRH, then your AMH decreases. PCO, your AMH increases. Current pregnancy, please don't do it when a woman is pregnant. It decreases your AMH. Parity increases it. History of ovarian surgery decreases it. Endometriosis decreases it. Granulosa cell tumor, the only tumor in which this is a marker is granulosa cell tumor. BMI, we don't know. Socioeconomic status, no effect. Smoking, no effect in the past. But if you're currently smoking, it does decrease it. Chemotherapy decreases. Low vitamin D level decreases. Alcohol use, no effect. Physical exercise, no effect. So what are we looking at in terms of future of AMH? Hopefully for us to predict menopause. And if we can get a hormone like how we have FSH as an injectable or as a drug, if AMH is available, it can be used as a contraceptive. Why? Because I said AMH actually stops the follicles from getting recruited. So if you can give a woman who's undergoing chemotherapy or who wants to delay her fertility, you give her AMH. It's going to stop the follicle pool from getting recruited. Thank you very much.
Patients do come and ask, my AMH is low, what can I do? So we are at a loss of words at times to talk and counsel about this. You're very, very clear about when to use, when not to use the AMH level. So in the end, AMH is not a marker for menopause, right?
Not yet. Not yet.
Not yet. Thank you very much.
Very well.
Durga, I just have a question. Recently, one of my patients was asking me, I just want to delay my pregnancy. Can you give me can you assess by any marker, how long can I wait before I can become pregnant? So I was really surprised at the question, but I think you are a better person to.
This is where I think AMH is required.
Yeah. So, what does it predict?
I would say it would help if you did a scan in terms of understanding her ovarian volume and the number of follicles. AMH is, like I said, a counseling tool. It does help us plan. So if you have a woman who's got an AMH above 1.2, let us say, because that's the cutoff that we're looking at in terms of poor reserve. If she's got an AMH which is above that and your scan corroborates, I would say she can be reassured.
Okay.
But it depends on how old she is. Again, it's very, very important, rather than having an AMH, during my history, the first thing that I look at is the age. If I have a 26-year-old woman with an AMH of 0.2, and I have a 36-year-old woman with an AMH of 0.2, my 26-year-old will do. Because age is the trump card here, whatever said and done. So I think when you are counseling the patient, the one that you're speaking about, her age would be the most important factor here. And we do know that in Indian women, once you cross 33, I'm not even talking about 35 and 37.
33.
Unfortunately, we are 6 years behind a Caucasian.
Oh.
So if you have a woman who's crossing 32, 33, I think she needs to be told either to vitrify her eggs, embryos, or try conceiving naturally, which would be the best option.
Thank you. Thank you so much.
Thank you, ma'am. Now I request Dr. Uma ma'am to present memento to Dr. Durga Rao ma'am. Now I request Dr. Krishna Kumari madam to kindly introduce Dr. Srivani Kota ma'am.
Yeah. Good afternoon, everyone. Thank you, Dr. Lakshmi Ratna, for inviting me to chair this session. We now have the next speaker is Dr. Srivani Kota. She is having 15 years of vast experience in reproductive medicine. She is a best fertility and IVF specialist, one of the best, and is a dedicated dynamic specialist. She has done her MS from Osmania Medical College and has multiple degrees and accolades in the field of infertility. So she first started at Kraft Hospital at Kerala, and then she pursued a fellowship in minimal access surgery from World Laparoscopy Hospital. She also has a fellowship in gynec endoscopy from Germany, extensively trained in various ART procedures, and updated in her knowledge with exceptional clinical skills. As an academician, her best fertility and IVF center, she takes out time from her practice to participate in various conferences and CME programs. And so we'll be listening to Dr. Srivani on thin endometrium. I think we are moving out from ovary to endometrium. Again, another trouble for us as gynecologists. Over to you, Dr. Srivani.
Thank you very much, ma'am, for the kind words. Good afternoon, everybody. And till now, we had a very good session on AMH, and now I'll just take you towards the endometrium, the uterus, so which is also very important for us in achieving a pregnancy. And I thank Lakshmi Ratna ma'am for giving me this opportunity, and also the organizing committee. And I'm privileged today because my professor, Pratibha ma'am, Malti ma'am, they are Ambuja ma'am, all are my professors, and I'm standing in front of them and giving my talk. And my mentor, Durga ma'am, too. Thank you very much. So without any delay, we'll just get into the topic. So the topic for today of my session is management of thin endometrium in ART. As we all know that we have made a lot of progress in the field of IVF, but still the average pregnancy rates are just around 40 to 50%, but which cannot be increased further. But why? And still there are research which are going on to increase, and our goal is to increase the live birth rate. Why is it so? Because for a healthy embryo to needs for a successful implantation, a receptive endometrium, and we need a receptive endometrium and a very good blastocyst. When there is a synchronized development and there is the synchrony between the endometrium and the embryo, we tend to achieve a successful implantation. And for us to achieve a implantation, endometrial receptivity and endometrial functions are the major limiting factors in establishment of a pregnancy. And we have to tell you that implantation is the most vital part of reproduction, and it is a rate limiting step in the reproduction. Why is it so? We have made a lot of progress with respect to the treatments, IVF protocols, and we are able to get a good quality oocytes and the better quality embryos. Still, the implantation rates are not to a certain good extent, and we need to look into why there is a lot of changes in the receptivity of the endometrium, why there is a derangement in the endometrium. We have to know that because we have an implantation window, because the embryo doesn't implant it whenever we put back the embryo into the uterus. The endometrium is remodeled under the control of steroid hormones throughout the menstrual cycle, and it just exhibits only a shorter period of receptivity, which is called the implantation window. And this is the time wherein we place the best embryos, and this is the time that the uterus receives the embryos. But not in all patients the implantation window would be the same. Some might have an implantation which is around 120 hours. Some women might have an implantation around 140, and sometimes even the implantation might happen around 109 and 112 hours too. Why? What are the reasons and what are the factors which are affecting the receptivity? And we look into the factors: endometrial thickness, pattern, and the blood flow to the endometrium and the subendometrial zones are the major factors which are affecting the endometrial receptivity. If we look into the endometrial thickness, we have to know what is the uniqueness of the endometrium. It is a highly regenerative tissue, and one of the most complex tissue in the human body, is always changing and responding to the cyclical patterns of the estrogen and progesterone of the ovarian cycle. And here you could see we have two layers: the superficial functionalis layer and the lower 1/3, which is the basalis layer. And basically, if the basalis layer is damaged because of the vigorous curettage during the DNCs, and if the basalis layer is damaged, then I think the endometrium can't respond to any of the treatments which might be offering. So in this picture, I think we can see a very beautiful triple line endometrium. And here you could see the in between, have a marker, the echogenic basalis layer and the hypogenic functionalis layer. And whenever we need to measure the endometrium, we have to take the measurement in the sagittal plane. So never we should be taking a thickness measurement in a transverse plane. The endometrium measurement should be taken in the sagittal plane. And the measurement should be of the thickest echogenic area from one stratum basalis endometrial interface across the endometrial canal to the other stratum basalis interface. And the inner myometrial halo should not be included in the measurement. So, and the measurement should be taken at the thickest part near the fundus. And what are the various factors which can limit the accuracy of the endometrial measurements? If we have fibroids, adenomyosis, polyps, and because of the uterine contractions, sometimes because we have the uterine contractions, the endometrial contractions, wherein whenever we are measuring if the endometrium is contracted, we tend to see a thinner endometrium. But later, when we have the contractions getting released, we tend to have a good endometrial thickness. So these are all the limitations or the factors which can affect the thickness. So is it just the thickness which is important? No, even the pattern is also very important. And here we have the grading of the endometrial morphology by Gonen and Casper, which has been given in 1990. Type A, Type B, and Type C. And Type C is the most important multi-layered triple-line endometrium, which is consisting of the 3 lines. So the outer echogenic basalis and the inner endometrial cavity lining, and also the hypoechoic area in between. So this is the triple-line endometrium, which is very important, but these pattern is seen because of the hormonal changes during the cycle. So during the proliferative phase, we tend to see a triple-line endometrium, but under the influence of the progesterone, because of the secretory changes, we tend to see a more homogeneous and hyperechoic pattern, and with the central echogenic line gets faded off. So this is how, so if we see a thick endometrium during a proliferative phase, that might not be a very good endometrium, but during a proliferative phase, during the follicular phase, we tend to have endometrium which is a good, neat, triple-line endometrium, which is seen in the first image. Is just the thickness and the pattern which is important? No, even the vascularity also is very important. And we have the Applebaum scoring, wherein the vascularity of the endometrium is graded as zone 1, zone 2, zone 3, and zone 4. As and how the vascularity, the blood supply to the uterus is supplied. If the blood supply is reaching up to the endometrial cavity, that is the zone 4. Like here we could see in the image 4, wherein the supply is up to the endometrial cavity. So that is a zone 4 vascularity. And this is very important. And basically during the IVF cycles and during the frozen embryo transfer, whenever we want to prepare the endometrium artificially by giving a HRT treatment, zone 4 vascularity tends to give us a higher implantation rates. Higher uterine blood flow rates is associated with a positive pregnancy outcome, and while absent diastolic flow is associated with a no conception. So blood supply and vascularity to the uterus is also very important. And regarding the thickness and the pregnancy rates are higher if we have a trilaminar, when we compare the trilaminar versus a non-trilaminar group, and it is even higher, around 39%, if we have both a trilaminar endometrium as well as if the thickness is more than 6. So this is a triple layer endometrium and a thin. So where to draw the cutoff? How thin is a thin endometrium? Is it a 5 millimeter thickness, which we call as a thin endometrium? Is it a 6 millimeter, 7, and 8? What exactly? So where do we draw the cutoffs? So there is no definite cutoff for a thin endometrium. Various studies has taken it as less than 6, less than 7, and sometimes even less than 8. But 7 mm is the most accepted, although pregnancies have also been reported a very thin endometrium. And thickness under 7 would definitely define a refractory endometrium with a compromised success. And we have the Canadian Fertility and Andrology Society guidelines, practice guidelines, which have been released in 2019. And according to that statement, summary statement, they have given the thin endometrium in assisted reproduction is often defined as endometrial thickness less than 7 or less than 8. But why are we literally thinking about the thickness, and why is it so important? Because they have looked into the impact of the thin endometrial lining in a fresh and frozen embryo cycles, around 40 embryo transfers, and they have literally given us data. In fresh IVF cycle, the clinical pregnancy and live birth rate decreased, and the pregnancy loss rate decreased with each millimeter of the endometrial thickness below 8. But in a frozen embryo thaw cycles, if the endometrial thickness is less than 7, there is a decrease in the clinical as well as the live birth rate. So this is the Canadian guidance wherein it says in fresh transfers, the pregnancy rates and live birth rates are less when the endometrial thickness is less than 8, but in the frozen transfers, less than 7. Why does this thin endometrium causes the implantation failure? Why? Because the oxygen tension would be reduced in the functionalis or the superficial epithelium after ovulation and around the time of implantation. This is all usually happens during the ovulation. But in a thin endometrium, the quality of the functionalis layer does not sustain the seeding embryo, in part due to the proximity to the oxygen-rich basalis layer, and which is very toxic to the developing embryo. That is the reason whenever we do start certain vasodilators during the HRT treatment, we do stop those vasodilators just around the transfers. Why? Because we don't want the embryo to be exposed to the high oxygen tensions. And patients with thin lining are also known to have less VEGF expression, which leads to poor vascular development and ultimately a defective placentation. And that is the reason even whenever we do the transfers to the thin endometrium patients, we do add upon the vasodilators which would help them during their pregnancy, so that there is a lesser chances of them developing PIH and defective placentation. So if we look into the obstetric complications of thin endometrium, the patients who conceive in the setting of a thin endometrium have a significantly increased risk of early pregnancy loss, and they are also a twofold increase in the low birth weight and a preterm delivery. And there is a significantly higher risk of intrauterine growth restriction and composite adverse perinatal outcomes. So that is the reason whenever we have a patient who is having a thin endometrium, to negate all these things, we do start them on with a vasodilator before the transfers, and post, once the beta HCG positive, we do continue the vasodilators even during the first and second trimesters. So what are the factors which are affecting the endometrium? The three important factors which would affect the endometrium are the serum estradiol levels, the blood flow to the uterus, and the health of the endometrium itself because of the previous injuries and infections. So coming to the causes, most commonly the iatrogenic causes because of the DNC. As I told you, if we are going for a dilatation and curettage, and if we are rigorously going for a DNCs and we are damaging the basalis layer, yes, we might the patient might land up in a thin endometrium. And surgeries, myomectomy, in intracavitary myomectomies, where the endometrium is opened, and in if we are thoroughly cleaning the endometrial lining, and polypectomy if we are going in deeper into the subendometrial regions. These are the causes for the iatrogenic causes of the thin endometrium. Coming to the infections and the inflammatory causes, in India the most common cause would be the tuberculosis, and next common cause would be the the chronic bacterial infection, STDs, and the pelvic inflammatory diseases. As I told you, low estrogen levels, if the estrogen stimulation is not sufficient and the hormonal levels are not good, yes, we tend to have a thin endometrium. Excessive use of clomiphene, yes, because of the anti-estrogenic effect, because of the estrogen receptor downregulation in the endometrium, we tend to see a thin endometrium in ovarian stimulation protocols, and prolonged use of the COPs. Yes, congenital Mullerian anomalies, there is an association between the Mullerian anomalies and POF with refractory endometrium, and it is documented in the scientific literature. Idiopathic, the thin endometrium, which is not secondary to any disease process, it can result from individual uterine architecture, intrinsic properties of the endometrium that affects its growth. As I told you, why? Because of the insufficient blood flow. Why do we have the thin endometrium? Why so? Because Takasaki in 2010, they have demonstrated that thin endometrium is characterized by, in Doppler studies, high blood flow impedance of radial artery, poor epithelial growth, decreased VEGF expression, and a poor vascular development. What do we need to do if we see a thin endometrium during our stimulation, during our treatments? So here we are categorizing into two different ways. Non-IVF patients who are going for a simple ovulation induction with a timed intercourse or IUIs, and the second category would be a thin endometrium patients during the IVF cycles. What do the studies say? What does the literature tells us? Most of the studies which have been done in ovarian stimulation, non-IVF patient, they have been retrospective and very small studies, and most studies have not shown an effect of thin endometrium on outcomes. Only one study, it showed a very low pregnancy rates with thin endometrial thickness. And a prospective study of 168 patients found comparable pregnancies in CC cycles of various endometrial thickness, less than 6 to 7, and more than 8. So what does the Canadian guidelines, practice guidelines tells?
Excuse me, ma'am, time is up, ma'am.
If we have a thin endometrium during the ovarian stimulation, they can be counseled that the effect on pregnancy is unclear, and there is no need for any recommendation of changing the stimulation meds. But in IVF cycle, they have categorized into a fresh and frozen embryo. As I told you, in a fresh IVF cycle, the endometrial thickness, if it is less than 8, there is a negative impact on the pregnancy outcomes and the live birth rates. And it is advised that these patients who are going for a fresh IVF cycle, they can be counseled to freeze their embryo and can go for a frozen embryo transfer in the coming cycle. And in frozen embryo transfer cycles, definitely when the endometrial thickness is less than 7, it is better to defer the transfers because it has a negative impact on the pregnancy and live birth rates. But none of the protocols which are used for the endometrial preparation are found to be superior over one another. So how do we investigate and what are the treatment modalities? Yes, hysteroscopy, assessment of the uterine cavity is very much needed to know which are the patients who would be more beneficial with respect to the surgeries and what are the causes for that. And at the pointers of the surgery, yes, the ostia needs to be taken as a pointer, and we should not go far and go lateral. Chronic endometritis during a hysteroscopy, yes, these are the features of a chronic endometritis wherein we tend to see hyperemic spots in the cavity. Whenever we do see these hyperemic spots, yes, this is one of the feature for endometritis, and we need to treat the cause wherein the minocycline and augmentin can be given. Genital tuberculosis, as we can see, adhesions in the uterus. And if we tend to find that TB, yes, that treatment strategy can be planned. During the IVF cycle, if the estrogen levels are not sufficient, we can go for an extended estrogen therapy, and we can even go up to 24 to 30 days, and it has been, the pregnancy rates were slightly higher than the control group. And changing to a vaginal estrogen is also one of the modalities wherein we tend to see better improvements. Whether we can use the aspirin, we have plenty of cocktail of medicines in thin endometrium, aspirin, sildenafil. So what does the literature say? The Cochrane review found no benefit in adding aspirin for endometrial preparation. Even another Cochrane review in 2016, they didn't find any evidence in difference in CPR or live birth rate. And regarding the vitamin E, all these are very small prospective studies, and it did show an improvement in the radial artery resistance, and the endometrial thickness just improved in 52% of the patients. Pentoxifylline can also be given, but the studies are very inconclusive. All these are just only, we have few studies, 2 observational studies and a smaller group of patients. Sildenafil, as we all know, it is a selective inhibitor of phosphodiesterase, and it helps in vasodilation and improving the blood flow. Whether can we give sildenafil, but yes, still the literature or the evidence what we have, it did not show, it did show an improvement in the endometrial thickness, but all these are very smaller studies. The Cochrane review in 2014 on the role of vasodilators concluded that the evidence was insufficient to show that vasodilators increase the live birth rate in women undergoing fertility treatments. So Elagenine is also one of the things, but evidence is not sufficient. We can, if the patient is on the clomiphene and if she had any thin endometrium, shifting to a tamoxifen can be another alternative. Tamoxifen is also used during the frozen embryo transfer cycle if we tend to see a thin endometrium. There are many studies, but all are smaller case reports, comparative studies, and cross-sectional studies wherein the evidence is not sufficient enough to conclude that it might be the first line of treatment in all patients. But yes, it is a promising alternative for patients who had thin endometrium with the other treatment modalities. Role of HCG, yes, we do give HCG for patients who are having thin endometrium who didn't respond to any other oral medication. HCG at the dose of 150 international units is given during the hormone replacement treatment during the frozen embryo transfer cycle. And, but yes, the evidence is very small. GnRH agonists can also be tried, 0.1 milligram from the day of oocyte retrieval for just 3 days, but needs further validation. Growth hormone is also one of the treatment modalities which we use, but all these are given because to upregulate the expression of the VEGFs. Growth hormone is also given at the dose of 4 international units, 5 international units, but all these treatments are only reserved or can be utilized if the patient is going for a IVF frozen embryo transfer cycle than being utilized in a regular ovarian stimulation who are going for an ovulation induction with time intercourse or a IUI cycle. Because we need to even think about the cost effectiveness of the treatment too. GCSF, granulosa colony stimulating factor, is also one of the things wherein we use it as an intrauterine perfusion, but the evidence what we have is limited. We have plenty of studies, but all these are done on a small number of patients with and the data is limited. And coming to the next, what next we have the plated PRP, the role of PRP in thin endometrium. Yes, PRP is an autologous blood plasma which is enriched with platelets about 4 to 5 times more than the circulating blood. It contains various growth factors like VEGF, epidermal growth factors, and the platelet-derived growth factors. All these regulate the cell migration, the proliferation, and this is the concept which is used in the thin endometrial patients. But what the evidence what we have, these are the studies what we are done, is all done on the very smaller group of patients with the thin endometrium, and still we need a larger studies, RCTs, which need to be done in PRP. And this is a recent meta-analysis which is done in 2023, and it tells which included 8 studies. GCSF may improve implantation clinical pregnancy rates in ART and have a potential to increase the endometrial thickness among the women within endometrium. However, the results of the included study should be explained with caution due to their limited quantity and quality, and more studies with a higher quality were demanded. Regarding the role of stem cell, yes, this is the most upcoming thing and which is being utilized in thin endometrial patients, wherein we can use the bone marrow derived stem cells and adipose tissue derived stem cell. And first, in 20, like we have,
ma'am, we are running short of time.
Just few slides. Done in 18 patients with refractory Asherman syndrome, and what they have done was the stem cells were delivered into the spiral arterioles by catheterization, and all 11 Asherman syndrome patients exhibited an improved uterine cavity after 2 months of the stem cell. So this is one of the study which was a pilot cohort study which is done. So the evidence what we have, everything is very weak, and they say so only the hysteroscopy to evaluate the cavity is only shown as has a beneficial intervention, and all these are other modalities doesn't show a clear effect. So to conclude, optimal endometrial thickness is necessary for a successful implantation, And we need to explore the treatment strategies based on the treatment which the patient is going ahead. Adjuvants, they need a high quality evidence before introducing into the routine practice. Thank you.
Thank you very much. It's an excellent lecture. What do you do for in your patients, what do you do for thin endometrium?
For all our patients, because most of the patients who come to us, who are going for IVF cycle, whenever we see a thin endometrium, we evaluate the cavity by doing a hysteroscopy to see if there is any adhesions and any infection in the uterus. If the adhesions are there, definitely that needs to be taken care of. And when we take them towards the HRT treatment for the frozen embryo transfer, we go with the gradual increase in the dose of the estrogen. So we start with the 2 milligram TID dose. If after 6 days of stimulation, we do the scans and we look into the endometrial thickness. And if the thickness is not adequate, we increase the dose, like 2 TDS. If the thickness is not improved, we do add upon the vaginal estrogen. And along with that, we use the vasodilators, aspirin, and also the sildenafil, as well as we even go for a GCSF perfusion, intrauterine perfusions. And if none of the things are working for them, we use the PRP.
Are you going for the latest things like bio engineering things?
No, bioengineering things are also there, ma'am, but they need to the approvals, and so we are using up to the PRPs.
Are they available here?
They are, ma'am, but they're not in the routine practice.
No, for a simple gynecologist, the patients do come to a gynecologist also, not only to the IVF specialist. So what is your protocol to be given, for example, simple PCOS? First come for the infertility.
One thing which for any patients, if they are going for a simple PCO, if they are going for a simple ovulation induction, better if they have a thin endometrium, they can go for a letrozole stimulation or a tamoxifen, which can help them have a better endometrium.
Still the endometrium will be thin.
Still the endometrium is thin. Only if the follicle, because we need to monitor the follicular size as well as the endometrial
Synchrony will not be there.
Yes.
Yeah.
So if the follicle is growing and if the follicle is just 12, 13 millimeters, we can't add a estrogen at that particular time, because estrogen will definitely suppress the follicular growth. So during that period wherein we have a follicle which has not reached the size, so we can add upon the vasodilators. But only when a follicle reaches a 15 millimeter size, we can add upon the estrogen supplementation during the ovulation induction cycle.
Thank you. It's a good lecture.
Thank you, ma'am.
Thank you, ma'am. Now I request Krishna Kumari madam to present memento token of appreciation to Shivani ma'am. Shivani ma'am, please come on to the dais. Next, we move on to the next topic. I request Dr. Uma madam to please introduce Dr. Pooja madam. I request all the speakers to please confine to the 15 minutes time, as we are already running short of time.
Now invite Dr. Pooja. She's got a lot of work experience, and at present she is a fetal medicine specialist and visiting consultant in MediQuest Diagnostic Center in Secunderabad, where she practices radiology, ultrasound, CT and MRI. And she's got lot of things, and she worked in various hospitals. She's exposed to many of the things to perform MSK, USG and MRI of knee, shoulder, spine. Not only this fetal medicine, she is exposed in all the fields. So I think she's the best person to talk about IETA. So that's International Endometrial Tumor Analysis. So this is a good analysis where not only MUSA, this is also very important in for the ultrasonic point of view. The International Society of Obstetrics and Gynecology, Ultrasound Society of OBG. I think this is coming up very good. It's useful in all the things, I feel. Even AUB, not only fertility, even in AUB it's useful. So we want to know more about it. Please proceed.
Good afternoon, everyone. I'm Dr. Pooja here. I will be talking on international endometrial tumor analysis. It's very small, very simple, won't take too much time. So everybody's concentration span also, I'm sure it's saturated by now, but this will be quick. This organization was basically formed in Chicago at the World Congress of Ultrasound in Obstetrics and Gynecology in 2008. They aimed to develop standardized imaging techniques and descriptive terminologies where ultrasound findings of endometrial pathologies had to be elucidated. So it's only for ultrasound, only for endometrial, where we are making a standardized protocols for how to do proper imaging, the technique of it, and how to describe the findings, what you see. So this is only a descriptive terminologies. Like giving you a small example, when we measure just one measurement, which is the endometrial thickness when we take, we can reliably distinguish which woman is at high risk and which woman is at low risk for endometrial cancer. The commonest presentation of this condition is abnormal uterine bleeding. It can be seen in premenopausal, peri, or postmenopausal women. When do you call the bleeding to be abnormal? When there is a significant deviation from a woman's established menstrual pattern. The commonest causes that we see and we are sent for is endometrial polyps, endometrial hyperplasias including malignancies, leiomyomas, which are mostly submucosal, adenomyosis, ovulatory dysfunctions, ovarian masses, and systemic diseases like coagulopathies. When is the ideal time to send the patient for a scan? This is very important. As endometrium keeps sloughing, so when do you send the patient? So in a young woman, that is premenopausal woman, early proliferative phase is the best time. That is the 4th day to the 6th day of cycle. Why? Because the endometrium has already been shed off and the cavity is pretty much empty. So the pathology stands out way better than how it is seen in the proliferative phase or the other phases. In women who are postmenopausal, are they routinely sent for a TVS scan? Not really, unless they are presented with a postmenopausal bleed or spotting. And how about women who are not postmenopausal women who don't present with PMB and they are on HRT? So you have to send them 5 to 10 days after the last tablet has been consumed. Now, as IETA is dealing only with ultrasound, in ultrasound there are other modalities that we can resort to. Transvaginal scan is the most often preferred scan over transabdominal or any other scan. Why? Because the transvaginal probe is a high frequency probe. High frequency probes do not have greater penetration. So they can visualize structures which are more superficial and more close by to the probe. So endocavitary probes have better resolution for pelvic pathologies. That is why TVS is more preferred over TAS. Transabdominal scan has to be done in certain situations where the uterus is very much globally enlarged or where there are multiple fibroids, where it causes distortion of the architecture of the uterus. In such situations, when we put a transvaginal probe, we may not be able to see the zonal stratification always. In these conditions, we need a roadmap, which is a transabdominal scan, and then we ask the patient to empty the bladder, and then we do a transvaginal scan. In other inappropriate conditions, such as women who have not been yet exposed to sexual act, or they have vaginismus or vaginal stenosis, transabdominal scan is preferred. But if you think that the woman is very obese and the acoustic window is not great, then a transrectal scan also can be resorted to. What are the other modalities of transvaginal scan? Installation of saline into the endometrial cavity, that is hysterosonogram, is one of the other modalities. Then this can also be seen in 3D. Ultrasound can also be seen in 3D images. This is a transabdominal scan where the bladder has to be moderately to well distended. The uterus we are seeing over here, which is posterior to the bladder, in sagittal, that is the first image, and axial, the second image. Here we are able to see the entire uterus, including its endometrium, the cervix, and vaginal canal. Now when we see the first image, which is a transvaginal scan, this is an image of a retroverted uterus. Here, we are able to see only the uterine corpus, see what we are able to see. We are not able to see the other structures like the vagina, the entire cervix and all that. We are only concentrating on the uterus and we are able to see it very well. So the resolution increases and the visibility of any small lesions also become better. So this is the first image is a transvaginal scan. The second image is that of a saline installation sonography, where we have pushed saline into the endometrial cavity. When you see a lot of blackness, that is anechoic fluid, it offers a very good negative contrast to the pathology sitting in it. So the pathology stands out better. The outlines of the pathology are seen better. If the endometrium is collapsed and closed, like the first image, at times small polyps like 3 mm polyps, 5 mm polyps or small asymmetrical thickenings can be missed very, very easily. And we send a normal report but the patient has symptoms of AUB. So in this situation, saline hysterography plays a very good role. Next one is a 3D ultrasound, 3D transvaginal ultrasound. The first one is an axial, second is sagittal, third one is coronal. Here, by acquiring one single frozen image, the machine can reformate the image into 3 orthogonal planes. Here, it will give us better identification of which wall of the uterus is more involved, whether the right lateral, left lateral, anterior, posterior. It shows the pathology better, the localization of the pathology better. Now, examination techniques. Here, we always have to put first see the uterus in axial and sagittal planes. What is sagittal? We are putting the probe in the in the vaginal cavity, and we have to take sagittal acquisitions, that is from right cornua to left cornua. That means side to side ballotment, and axial sections, that is from endocervical canal to the fundus of uterus, which is images acquired from craniocaudal or caudocranial view. And as soon as we put the probe, we should not just say this is the endometrial cavity. No, we have to trace it from the endocervical cavity into the uterus. Then that's when you see the endometrial canal. And the angle of the ultrasound beam should close to be 90 degrees to the long axis of the endometrium. This is another image of an anteverted uterus, where the image is magnified enough to see only the uterine corpus, that is only the uterine body. And we're seeing the endometrium in entirety, that is in toto, in its entire length. This is a good magnification of a normal uterus. What are the IETA factors? Here we can assess the endometrium in quantitative measurements, which is ET, and qualitative way, where we see the echogenicity, the endometrial midline echo, endomyometrial junctional lines, vascular scoring, and vascular pathology pattern. In endometrial measurement, ET, we have to always take it only in sagittal plane. And both the calipers are placed at 2 opposing endomyometrial interfaces. And this is given in millimeters. When there is any fluid collection within the endometrial canal, that should not be included in the endometrial thickness. When there is asymmetrical endometrial thickening, then the anterior wall, the second image, is measured separately, and the posterior wall is measured separately, and a sum of it is generated. Now coming to qualitative assessment. First point is the echogenicity. What do you compare the echogenicity and say it's hypo, hyper, or iso? We have to always compare it to the adjacent myometrium. If it is lesser than the myometrium, it's hypo, more, hyper, equal to, it's iso. And not just see whether it is more, less, or equal to. It is very important to see whether it is homogeneous in appearance or heterogeneous in appearance. The first image here is a homogeneously iso to hypoechoic endometrium. The second one is the hyperechoic, homogeneously hyperechoic. The third image, bottommost image that we are seeing, is a heterogeneous endometrium. Here we are able to see hyperechoic areas, anechoic cystic areas, and hypoechoic areas. The more heterogeneity it is not normalcy. So we'll have to assess whether it is homogeneous or heterogeneous. Now coming to the endometrial midline echo. This is the thin echogenic line that is formed by the apposition of the anterior and posterior layers of the endometrium. It can either be linear, absent, or irregular. This is an image of a normal anteverted uterus. Are you able to see the thin endometrial line in the midline here? The thin line. That thin center line is formed by the apposition, the medial contact between the anterior and the posterior surfaces of the endometrium. This line always has to be thin, linear, and straight. If it is interrupted focally or diffusely, or it is absent, that has to be seen. But every time when you see the midline, at times when you don't see the midline, that is in the proliferative phase, no, in the secretory phase, the endometrium appears very hyperechoic. That is the second image. See, it is uniformly hyperechoic, but we are not able to see the midline. That is okay, because it is in the proliferative phase. Yeah, thank you. Because that is in the proliferative phase, secretory phase. So we may not be seeing in such situations. Here, this is a case of endometritis. See the endometrial midline echo. Are you able to see it regularly, thin, linear, continuous? No. It is interrupted and irregular. That is because of chronic endometritis. This is another sign to predict an endometrial polyp or an endocavitary lesion from the endomyometrial junctional line. This line. This is called the bright edge sign. Now coming to the endomyometrial junctional lines. They can either be regular, irregular, or focally interrupted. Here we are able to see the junction between the endometrial endometrium layer and the myometrium. See this white line. It is very linear, thin, well defined in its entirety, that is in its posterior, fundal and anterior walls. The second image, we are not able to see it. It is blurred diffusely. Here it is blurred only focally. That is because of a submucosal fibroid which is indenting into the endometrial cavity. Here again, though this is the endomyometrial junctional line, here we are able to see the white line between the endometrium and the surrounding myometrium. Are you able to see the endomyometrial junctional line here? No. And is it blurred focally or diffusely? Diffusely. Why? Because of diffuse adenomyosis. Now coming to another pathology. Here, are you able to see the endomyometrial junctional line here very clearly? Only over here, focally, it is not very well visualized. That is because of a submucosal fibroid, which is very small. This also is a submucosal fibroid, but larger. The whole of the posterior the lower segment posterior endomyometrial junction line also is blurred here. This is a long segmental blurring. Now coming to other pathologies, this is a postmenopausal woman who presented with postmenopausal bleeding. Here we saw the endometrium to be echogenic, thickened, but you can see the endomyometrial junctional lines fairly intact. In the second image, this is also of another woman who presented with postmenopausal bleed. Are you able to see the endomyometrial junctional lines completely? No. Why? That is because there is blurring, and this is an endometrial cancer which has infiltrated beyond the endometrium and has gone into the myometrium. That is why the EMJ lines have been blurred and broken. Now coming to the endocavitary fluid. The fluid can be anechoic, that is completely clear, or mildly echogenic, which is like ground glass appearance. It is always very mild, minimal echoes. This one is mixed echogenic, where the components of different stages of blood and serous fluid and other products which give this kind of an appearance. Now coming to the vascular scoring. This is an important thing to assess beyond the 2D mode, which is the color Doppler flow imaging. Here, the Doppler box should not just include only the endometrium, but then it should include even the adjacent myometrium. See the box over here. We are not just including this particular pathology or putting only over here. We have to put to the surrounding myometrium because the vascularity has to be assessed better. And the magnification should be adequate, where we see only the uterine corpus and not the other adnexa. The frequency should be set to 5 megahertz, the PRF to 0.3 to 0.9 kilohertz, wall filter to 30 to 50 hertz, and the gain should be reduced until all the color artifacts of the surrounding structures disappear. And a blood flow scoring is given. How do you assess the blood flow scoring? It is a semi-quantitative, subjective assessment. A score 1 is given when there is no color uptake, 2 when there is minimal color uptake, 3 when there is moderate color uptake, and 4 when there is severe color uptake. Anything which is 4 and it's taking severe color uptake, don't always think it's a very aggressive lesion. We also have to rule out other things, other conditions like an AVM or something, where we had gotten confused and we had given this as an aggressive appearing endometrial cavitary mass, but later it turned out to be an AVM. It was an AVM, ma'am. Now this is also another woman, a 72-year-old woman who presented with postmenopausal brownish spotting. Here you can again see the endometrium thickened. It is hyperechoic and with heterogeneous components. Junctional lines are slightly blurred, especially posteriorly, but there is no color uptake. So this is a score 1. This one is 2. This is score 3 and this is score 4. This also happened to be another AVM. Now coming to the vascular pattern. Because the scoring was a very subjective interpretation, now we're coming to vascular pattern. Vascular pattern is reported basically based on how the blood flow pattern is. Whether you're seeing a single dominant vessel or you're seeing a certain pattern of color uptake. What is a dominant vessel? A dominant vessel can be an arterial or a venous vessel which crosses the endomyometal junctional line to supply the endometrium. Like over here, this is called the vascular pedicle sign. Here we are able to see a polyp here in the anterior wall. And we are able to see one particular pedicle crossing the endomyometal junction line and supplying the endometrial polyp. So this is the dominant vessel. The dominant vessel can be single or it can have any branching after it enters the endometrium. It can arise from one focal origin.
Excuse me, ma'am, we are running short of time.
This is a tuft of vessels arising from one focal origin, like multiple vessels arising from one focal origin. Here there are multiple vessels arising from multifocal origin. The origin of the vessels also have to be seen because that determines the aggressiveness of the lesion. These two are other patterns of color uptake. Why am I calling a pattern and not a dominant vessel? That's because in the endometrial cavity you're able to see the color, but then we're not able to see a dominant vessel. So this is just scattered and diffused endometrial low flow color, very low flow vascularity it is. Or it can be like a rim or ring-like color uptake. This is again a polyp of a perimenopausal woman. There are two polyps here, anterior and the posterior wall. Here we're able to see a single vascular pedicle sign supplying it, and we're able to see low resistance arterial wave pattern. Here this is endometrial hyperplasia, where we're able to see multiple vessels crossing the endomyometal junctional line. This is multifocal color uptake. Coming to saline hysterosonogram, here fluid is instilled into the endometrial cavity so that the pathology stand out better, and not just standing out of the surface of the pathology, but then we can even differentiate whether the pathology is arising from the endometrium or the endometrial cavity is being indented from the surrounding myometrium. See, when the fluid is instilled into the cavity, we can see the midline echo so well, the surface of the uterine wall
Sorry
so
to
well.
interrupt you, Dr. Pooja, but we are running out of time.
Okay. So these are better visualizations when the fluid is instilled into all this. If there were collapsed endometrial cavities, we wouldn't have been able to see these asymmetrical polyps thickening. We have to see whether they are focal or extended, whether the contact is more than 25% or less than 25%, whether the thickening is asymmetrical involving one whole wall or both walls, whether it's pedunculated or sessile. Yeah. Just coming to the last slide, features of endometrial cancer, to just make it more interactive. See, the endometrium here is very hyperechoic, very much thickened. It is very heterogeneous. Endomyometal junction lines are lost. The midline echo is lost. Vascularity is taken. Here there is fluid. The midline is very nodular and polypoidal in configuration. Here the zonal anatomy is completely lost. Here there is no morphology also. Here significant color uptake is there. So the morphology of the endometrium helps in assessing the aggressiveness of it. And we can thereby stratify the risk, whether it is a low risk or a high risk, by just measuring one ET and seeing the appearance that's the morphology of it. Thank you.
Thank you, Dr. Pooja.
Thank you.
I think ITA has to be taken up as we have already been doing with Musa and Iota. So you want to ask a question? Do we have time, organizers? Sorry. I think, okay, one question, fast.
Wishes from my side, ma'am. That was an amazing presentation. My question is that how is the endometrial immune system, whether it is contributory or detrogatory for the endometrial cancer? I mean, how is it affecting?
I think that's a question for a gynecologist. Yeah. Ours is only a pure imaging field.
Fine.
Yeah.
Thank you.
Yeah.
I request both the chairpersons to present memento token of appreciation to Pooja ma'am. I request Lakshmi Ratna madam to present mementos to chairpersons. Now we proceed to the next session. Over to Dr. Nilofer.
Good afternoon to all. Lovely audience here. Hope you are all enjoying. Okay. So the next panel discussion will be about abnormal placenta. Our moderators are Dr. Meeta and Dr. Satyasree. I'm very happy and honored to introduce Dr. Meeta, who doesn't need any introduction. She is a consultant, specialist in menopause and osteoporosis, co-director, Tanveer Hospital. Her areas of interest is in obstetrics, menopause, postmenopausal osteoporosis, PCOS, and gynec ultrasonography. She is founder chair, Indian Menopause Society. There are many awards to her credit. Thank you, ma'am, for coming. Dr. Satyasree, she is MBBS DGO from, she's a consultant gynecologist and obstetrician, Ankura Hospitals, LB Nagar. She has done her postgraduate diploma in urogynecology and pelvic floor reconstruction from University of Kiel, Germany in September 2020. DGO from Jawaharlal Nehru Medical College under KL University, MBBS from Mamta Medical College. She is a consultant gynecologist and obstetrician at Ankura Hospitals, LB Nagar, and consultant gynecologist and obstetrician in Geeta Multispecialty Hospital. Her areas of interest are urogynecology, high-risk obstetrics, menopause, preventive cancer care, minimal invasive surgeries, and obstetric emergencies. Thank you, ma'am. Over to you, Dr. Meeta ma'am and Dr. Satyasree ma'am.
Thank you and a very good afternoon. Respected ma'ams all sitting in the front row, my colleagues, juniors, and thank you for being here. But I would request all of you all to maybe stand up and then sit down again, because we've been sitting in the dark for such a long time that we lose our concentration otherwise. Yeah, that's wonderful. Take a nice deep breath and then let it out, and we start this session, because this is not a 15-minute session. So I want all of you to be awake, because it's 45-minute session and we are going to make it 45 only. And so we would request the organizer to give a bell at 20 minutes, second bell at 20 minutes, and the last is 5 minutes for the expert. So we are just going to do that. And if I'm not able to finish in 20 minutes, I close. And the next is Satyasree, who's going to take over. That is the flow that, please sit down. Thank you so much. So the flow is, I start off. No. Yeah. So I would request Satyasree to introduce our panelists.
Good afternoon, everyone. With profound respects, I bow my head to all the teachers here and teachers of teachers here. I'm more privileged to stand in front of you and share this hall with all the dignitaries. Welcome you all. And today's panel is about abnormal placenta. Here we're discussing the structural abnormalities of the placenta, for which the expert panelists are Dr. J. Venkateshwarlu sir. He is a MBBS MD Radio Diagnosis, medical officer, Central Health Services for Government of India, and he's an assistant professor and associate professor, NIMS Hyderabad, and is a consultant interventional radiologist in Medwin and Apollo hospitals. He has a lot of national and international journals and publications, so please welcome. Next is Dr. Lakshmi Ratna ma'am. Ma'am needs no intervention. She is Joint Secretary IMS, laparoscopic surgeon, advanced ultrasound colposcopic training, then menopause practitioner. Welcome ma'am. I can't stop the credentials. Next, I welcome Dr. J.V. Reddy sir, MBBS MD DGO. He is a professor, Gandhi Medical College, and head of the department, Gandhi Medical College, and medical superintendent. He is expert, I can say he's a surgical expert at the time of catastrophe. Give a big round of applause to him, please. Next, I invite Dr. Sridhar Reddy Badam. He is working as a vascular and onco-interventional radiologist at Apollo Hospitals, Jubilee Hills. He is expert in vascular and onco-interventional treatments, one of the few experts in radioembolization treatments for liver cancer. He is trained and is specialized fellow in vascular interventional radiologist under Dr. Anirudh Kulkarni from Tata Memorial. Welcome, sir. Next, I invite Dr. Amita Indasen, MS Obstetrics and Gynecology from Madras Medical College, then post-graduation and a fellowship in advanced obstetric and gynecological ultrasound. And she has her special interests are fetal cardiology and multiple pregnancies. Welcome, ma'am. I invite on stage Dr. Aditya Kulkarni, his MBBS from Maharashtra University of Health Sciences, DNB Pathology from Apollo Health City, Hyderabad. His areas of interest are perinatal pathology, gynecological pathology, artificial intelligence, and computational pathology. Interesting. Associate Consultant, Fetal and Perinatal Pathology, Department of Histopathology, Apollo Health City, Hyderabad. Next, I invite Dr. Mamta Neely, our senior most consultant from Ankura Hospital's Kompally branch. She has a vast years of experience, around 17 years of experience in the field of obstetrics and gynecology. She has dealt with many high-risk cases at various hospitals. Welcome, ma'am.
Pointer కూడా కావాలి మేడం.
Just see whether it is coming. Connect. Yeah. Do we have enough mics? Mics together. So I think, thank you, Lakshmi, for giving me such a wonderful panel. And I hope we do some justice, we do justice because I know all of you are experts in your own area of work. And so today, as you see, Lakshmi has put up the last 3 sessions only on endometrium. And this is just a continuum of what has been said previously in a different fashion. So while they're getting, the things organized, I think endometrium is one of the most, thank you, sir. So endometrium, the topic for today for the panel is abnormal placenta. And we have none of us have any conflicts of interest over here. But when I saw this kind of a shape, it just reminded me of a diya. The normal placenta is the light of our baby, the humanity which is coming in. And I think that was so wonderful, I just put that up. And for me, endometrium is the essence of life. No endometrium, what happens, you can't even, plant the ART also goes for a toss. So it's a nurturer. But look at this, I had this very interesting case where she had a number of IVF failures and she conceived on her own and came. She had endometriosis, she had this big fibroid, and when it was, kind of submucous, type 2, type 1. And then when we delivered the baby, the head of the baby and the size of this fibroid were the same. And this is peaceful coexistence is what I call. Because, these are very rare kind of phenomena where we really don't have explanation of how things work well. Just like how you have an IUCD or a polyp with a pregnancy, but rare instance. But then don't forget the myometrium. How beautiful this myometrium is. The more you go into the depth of this topic, uterus is one of the most fascinating organs of the body. You see how at delivery, the entire thing changes and the uterus contracts and there's no bleeding. But what happens if things, don't go according to the way that they're supposed to be going? And I think that's where all of us are going to work on today. Trophoblast, again, a wonderful organ again. You see, the invasiveness is as bad as cancer, but the only difference is it is ordered against the disordered cancer pathology. Then it provides you with nutrition. It gives you all the endocrine autolysis. Maybe, one of the answers later on, that was an interesting question asked for the previous speaker, which was not connected. And then it also autolyzes when necessary, after it has formed. So it has got a lot of good things. So today, we are not going to touch upon the placental function at all. Because I think most of the time, we are talking about the preeclampsias. So I said we are just going to talk about the anatomy. So we're just going to go back to the basics of anatomy. And that is what today's entire session is going to be divided into 20 minutes, I'm going to take you to the site of implantation and the structural abnormalities of the placenta and the cord. And later on, Satyashri is going to talk about the pus. And that's how we are going to divide this. So structural abnormalities, as all of you all know, these are the various structural abnormalities that you have. This I've just put up some pictures over here. But I would like to ask the august panel as to what is the impact of these abnormalities that we find. One, so the clinician can take up this question. What is the clinical impact of this anatomical abnormalities? Dr. Mamta, would you like to take that up?
Because of this abnormal structural abnormalities, as a clinician, we should suspect a PPH. There can be velamentous insertion of cord. Vasa previa is the one which we should suspect. So ultrasound plays a major role where, and accreta can also be
I would also request the panelists to be very crisp because we have got very little time. So just stick to your question and your answer. Clinical outcome. I have not asked about the diagnosis. So clinical outcome, PPH is one of the things, but there are a couple of more things that we can actually add on to whenever you are having these kind of problems. Diagnosis, Amita? So what are you going to look for? One, so the questions are going to be how ultrasound is going to help. When are you going to start looking for it? What is your message for all the youngsters, level 1 gynecologists, not level 2 ultrasonologists, level 1?
When we are looking on ultrasound, it is important that we examine the placenta completely, giving importance to cord insertion, and we need to look at the margins also. And these kind of folds, that is the circumvallate, should not be mistaken for a amniotic band or a uterine band, correct, which is very common.
Excellent.
So that is
and how would you differentiate very quickly? What are the differential diagnoses of a band? So many times you'll find, very easy when we are here. But we are seeing that band, it's so difficult to differentiate between this and the other things.
We can see the continuity with the placenta. That is the most important thing.
Yes. Otherwise, you have the other white bands that you're seeing.
It is into the myometrium, not into the placenta.
Correct. So clinical implication, and does it really, by knowing all this, are we going to worry the patient and worry ourselves? Or do you think by understanding and knowing, is it, like forearmed is better and forewarned is better?
It is.
Do you think it's going to help? How is it going to help?
Yes, we keep it in mind, but we do not want to alarm them early because most of them resolve as the pregnancy advances.
So as a sonologist, how would you actually put it down in your report?
I would mention the circumvallate placenta and say for follow-up. If it is later in gestation in the third trimester, I would probably talk to the clinician also regarding
so,
this.
Lakshmi, would you like to just, 2 sentences, does it impact outcome if you want to? Not okay, fine. You stick to pus. We called you here because you are an expert in pus with a lot of experience. So anybody wants to contribute to, does it impact outcomes, sir? Because you are with the clinicians all the time.
Yeah, yeah, it is some sort of compromise. Fetal growth compromise can be there. That is the only thing. Probably any of you, it is so rare that any of you encounter circumvalent blood.
Sir, you can read it up. These are the things that are there, evidence-based. So these are the things which can happen. That is why obstetricians and the sonologist, whoever is performing a scan in the first trimester, at least, I will come to the Vasa previa, why it is important to start doing it, not just look at the baby, not just look at the heartbeat. Why is it important to look at the placenta and the cord? And where it is inserted is why we will come to. Because this is very important, umbilical cord attachment to the placenta. All of you are aware about this, isn't it? And how it goes about. So what do you think about the velamentous insertion? Would you just like to have...
The cord insertion will not be onto the placental bed.
Yeah, would you like to take up this question, doctor?
Me?
Yes.
Yeah.
Anyway.
I don't think...
Achha, okay, sir?
Yeah, see...
Where
the blood vessels are actually running through the membranes.
Yeah, sir can answer. Sir can answer. You wait for the pass.
There can be bleeding during delivery. That blood belongs to the fetus.
Yes.
That is the important thing.
Correct. So here for the postgraduates, we just wanted this figure. I have put it up so it's easy understanding. When you're looking, especially in the first trimester, when you're doing the scan, what exactly are you going to look? Because sometimes it may be difficult in the later half of the pregnancies to go to the cord insertion. Maybe it's easier to do it in the first trimester, where everything is small. You're seeing the limbs also much more better, the hands much more better. Similarly, you can define this in the first trimester much more better. That is the importance
and
of
it
this.
also warns us if it's a marginal or velamentous,
Exactly.
it tells us there can be IUGR.
Exactly.
So we start monitoring early.
Exactly. So if it is centrally located, absolutely at the corner, or not seen over here at this end, and if it is in the upper side or the lower side, so such a huge information you're going to get in the first trimester and the early second trimester, which is going to help you follow up this patient. I've got some more slides on that. So problems of cord insertion, we are talking, there is a lot of literature now about vasa previa. And why is it so? Sir, can you, if you have worked on the vasa previa and...
Yeah. Actually, when vaginal deliveries were so common,
Correct.
now they have become uncommon. So
not really, sir, not really.
Yeah. We used to see this velamentous attachment and vasa previa.
Vasa previa.
So the issue is when the membranes rupture and these vessels rupture and that blood belongs to the fetus. So there can be rapid exsanguination of the fetus. That is the thing.
So can somebody define the difference between a velamentous insertion and a vasa previa? Aditya? You are a pathologist, you should...
So vasa previa is just vessels, as I understand it. Vasa previa is just vessels in front of the cervical orifice.
Absolutely.
And then that creates basically a pressure-mediated hemorrhage. Velamentous insertion is more riskier because, velamentous insertion, the vessels will actually branch in the membranes. So they will lose all the protection of the Wharton's jelly. So we can actually demonstrate that on histology.
Yeah,
so,
from the pathologist's point of view, you are 100% correct. For you, the velamentous insertion is bad because it leads to other problems for the baby.
So, and
but
it's
for
important
the
to document that.
For the clinician, it's different. Velamentous, we are not so bothered because we are following up. We are bothered about vasa previa because if it's on the cervical os, then that's the biggest worry because
so that,
you don't
that
have
remains
time.
a clinical diagnosis.
Yes, so that's a clinical. Anybody wants to pitch in there?
Yeah, that's what, as we said before, when it is low
So
down.
there's a difference between velamentous insertion because velamentous insertion can be in the upper segment as well or anywhere. But when you say vasa previa, the vessels which are running across the internal os is vasa previa. Velamentous can be anywhere else and that's what the pictures are showing you. You just have a look at all the pictures, the vasa previa pictures and the cord and the difference between the vasa previa. And so what are the different types of vasa previa because it's very, very important. So what is the obstetrical management if this velamentous insertion and the vasa previa, not vasa previa, the velamentous insertion is at the fundus. How would you manage, Mamta? Supposing, Amita is very good with the ultrasound. She'll say, oh, there is a velamentous insertion. It's not, in the regular place and it's in the fundus. So will your obstetric management change?
Yes, madam. Usually we have to look for any intrauterine growth retardation in such cases.
Yeah, you're following them up.
Yes.
But would your obstetric management change only because of the diagnosis?
No, madam.
Just like the cord around the neck?
No, madam. No, madam.
Excellent. So we not. But then if it is in the lower uterine segment?
Then definitely we have to follow up because PPROM is one risk factor.
Not follow up. Probably you'll have to go for a you have to
C-section.
forewarn the patient. This is
Inpatient
one of the
management.
places where you need to do a section without a thought and you are going to save that baby. You know, the very interesting study by Nicolette's group, and they have come out with a screening technique, two-step screening technique for this. And we have different types of vasa previa. One is with the developmental insertion association, and when there are two lobes running in the membrane, then it becomes along type 2. And type 3 is the placenta is normal, the insertion is normal, but this sudden one umbilical vein decides to go out and then come back again. So anything that is going in the membrane is velamentous. Any cord on the os is the vasa previa. So that is the difference. So these are the clinical implications, and you know we have already finished this. But does this impact treatment? Yes, screening. So in this beautiful study, if anybody has read this study and talked, know about it, please you can talk about this. Amita, have you seen
No.
this? Seen this earlier?
No.
So if you have not seen it, and if none of you all have seen this, then I will talk about this. Yeah. Because this is, I think, a very important take-home message, because you see effective prenatal diagnosis of vasa priya can potentially contribute to prevention about total 10% of the stillbirths. So that's a huge number. That means if you're diagnosing vasa previa and you're taking appropriate action, 10% of the deaths, stillbirths can be prevented. So that is the importance. All pregnancy with a prenatal diagnosis of vasa previa have a 97 to 100% live births. Undiagnosed have only 50%. So 50% chunk you're saving, and that is the importance of the early diagnosis. Now I'll just come to another interesting case. Oh, I forgot to tell you, when I started with an endometrium, long back 30 years ago, I was a postgraduate, 33 years ago probably, and I had a hard night, and next day morning the sister calls me and tells me that this patient who I admitted with a previous section is having bleeding from a scar site. And what do I see when I go there? I was wondering, what can this be coming from the, the scar? Very emaciated, thin patient, previous one cesarean. And through that I could see the granulation tissue on the scar, a little at one end. And she just put a bandage over there, and we really didn't know what it was. I was wondering why this granulation tissue has come up over here. And you know what it was? It was the placenta. So that is the invasiveness of the placenta. And of course, she had a hysterectomy. The patient survived. Everything went off well. But I can never forget the invasiveness of the placenta, which can go not only through the bladder, it can go out through the, into the parametrium and also into the skin. Another interesting case, retained products of conception. When you say retained products of conception, we only think of first trimester and second trimester, isn't it? But then it can happen anytime. So any placental tissue left behind, any part of the, baby left behind, the bones and anything, that's all retained placenta at any time post-cesarean, post-normal delivery. Now I have this case who had come to us, and she came first on 1st of August 2020. She came with this torrential bleeding. I think I messed up, no, yeah. So this is the one. So 32-year-old, all LSCS, delivered 1 month ago, history of 2 attempts of DNC, torrential bleed, took her under anesthesia, didn't help. Then she had suspicion of a bladder injury, and then she was advised hysterectomy. Then she came to us, and this is what we found. You see the color? So RPOC, it will be type 0, type 3, type 3, completely filled with cover. And then you see it's away. So ITA person is here. It's away from the endometrium. It's almost like the whole thing is in the myometrium. So what would you call this, and how would you manage this? You're going to have AV malformation, and how do you differentiate between the two? Sir, maybe the interventional, you people come in over here.
Yes,
So-
ma'am. Ultrasound is the first modality. Then,
Yes.
then we can do a CT to look for the angiographic anatomy, whether it's arterial or a venous bleed. If it is a venous bleed, don't have to do anything, just we can observe. But if it is arterial and the bleed is, you see that the continuous bleed is there, then you can do a DSA angiogram. Based on the angiogram, you will know whether it is product of conception or the placenta or the AB malformation.
Without the angiogram, just based on the ultrasound,
Yeah,
do you think we can, what could your diagnosis be? Because she'll just come with you for a clinician with a post-cesarean bleed, 2 attempts at DNC, very dangerous. We don't know, it could be a mole, it could be choriocarcinoma. So many things go on to our minds, no? So many differential diagnoses that we have.
So it could be a placental polyp.
Yes, yes, sir. Placenta?
Placental polyp.
Placental polyp, yes, sir. But the thing is, it's mostly in the myometrium, as you see the picture. And this was what we had last year. And, No anomaly. No uterine anomaly. See, post-cesarean, they had a tough time delivering the placenta. So it is a focal pus, probably. So this is what it was. So to save up time, I'll just quickly tell you the history. Then what happened? So what would you do? I'm sure sir will say, send her to me, no hysterectomy. What will I do?
So another diagnosis could be a fibroid.
No, it's not a fibroid, sir. Yes, RPOC, sir, definitely. Because post-cesarean, something was left, which was difficult to remove, they said, in the history. And then they attempted to clean up afterwards. But the minute first they tried bleeding. Second try under anesthesia, bleeding. Yeah, somewhere around that area. No, I didn't have that question, but I didn't have the picture. Yeah. No, this is upper segment, sir. This is upper segment by the ultrasound. It's not lower segment at all. Yeah, it's almost like closer to the fundus. And she didn't have placenta previa. No polyp. Madam wants to say something. We have to take her.
I had a similar case. Yes. It was actually a patient who came with torrential bleeding. Yes. And when she was bleeding so much, I didn't know what exactly to do. And we didn't have this capacity and all. I got the ultrasound machine. They were all refusing. They were getting angry. I said, doesn't matter. I got the ultrasound man with the band. I said, show me where it is bleeding. I could found a placental polyp attached near the fundus because of previous placental piece that was left back. I could locate it and remove. This I did it in Shroff Hospital. I don't know whether you are. That's an old hospital. Yeah. Difficult. I had this.
When you see,
that bit of placenta has to come out.
Correct.
But they have tried it. It's dangerous to do it again and again.
Correct.
But you should be able. It may be morbidly adherent.
Part of that.
Yeah.
Her beta HCG was normal, sir.
Then it is not proliferating anymore.
Correct.
It is loose.
Exactly. So it was.
So you can just evacuate and pack the uterus. That will solve the problem.
No, that's what they tried twice. The DNC was tried twice.
Under ultrasound guidance, it should.
Yeah. So the next, I think, the second option is nowadays we have the hysteroscopy, where under vision, and then you have a cautery.
Yeah,
you can use the electrical cautery, but would you offer her anything else? Would you offer her an embolization or something like that? Or what is the role of methotrexate?
No,
if you're thinking in terms of placental
embolization
tissue,
may stop bleeding, but the mass remains.
Yes.
That necrosis gets infected. That has to come out somehow.
I will show you my picture, sir.
Yeah.
This year's picture
when
also.
you have done DNC from that mass, you must be knowing the histology.
No, I'll come to that. So 2 DNCs done, I said, blind DNC. So then
big uterus, no DNCs, please. You can only call it evacuation.
Evacuation,
with a very, very long instrument. No DNCs.
Yes, right. So actually, how I don't know whether, because there's no evidence, we did what we thought is the best. But this is what we did. So first we gave her a methotrexate. We said with this kind of type 3, vascular, again going and touching her, already bad experience. They said bladder also was perforated. She was with a catheter. And we didn't want to open her up. So we said, let's give her methotrexate and see how this works. And then the color flow just came down drastically. It became 0. So it was very, very convenient to do the hysteroscopy without tension, without having blood, nothing. And the tissue was removed and sent for histopathology. It just came out as those products of conception. Oh. And we've been following her up. The mass, most of it was removed, but it was almost like closing up on the serosa. So we had to not go till there because it was ultrasound guided hysteroscopy removal, both the ways. And then this is the follow-up of the latest is, as you can see, this is around November, early November. So, no, early October. So the small mass is there and this is what it is. So for the pathologist, yes, just give me 2 minutes and I'm done. So placenta previa, I had a lot of things, but I think I'm going to cut down the placenta previa. All of you all know. So I'm not going to talk about placenta previa. We're going to jump straight to the past. But before I do that, this was a very interesting, have you heard about this choreo-vitelline placenta? Maybe you can talk about it, Aditya. This was something very fascinating for me. And even Amita can talk about this because this is absence of the umbilical vessels and the vitelline vessels take over. Very few are noted in the literature. I thought it is kind of very interesting.
I have not seen.
You have also not seen. But this is very, the umbilical vein is not formed. So from the yolk sac, the vitelline veins, they take over and they form this choreo-vitelline placenta. So it's very interesting when you look into the way God really, the creator creates different things all the time. Very interesting. So thank you so much. And so I hand over the mic to... Yes, ma'am.
It ended with the abortion. Then torrential bleeding, and fetus was in one horn and another side is the placenta. Because of the torrential bleeding, we could not manage outside. I referred the patient to maternity hospital. Pratibha, I think you should be remembering. We gave methotrexate to that patient.
Yes.
Methotrexate. And for the first methotrexate, the bleeding has stopped, but she developed infection. And a very high temperature, it was so stormy for us. We were thinking all the time what to do with the patient.
Absolutely.
And second methotrexate we gave, and she responded for the third methotrexate and she aborted.
No, the problem there is didelphys uterus, they tend to be hypoplastic, thin uterine walls. So as we normally see in every uterus at the cornofundal attachment, near corno, the myometrium will be very thin. There also you get adherent placentas. I think it is everybody's experience when you find the placenta there, when you take out, they go on bleeding. We find a lot of difficulty. Maybe these compressive procedures of placenta previa, they may help there also. That we have to keep in mind.
Yeah. One thing,
packing is good, but not very definitive. Okay.
Yeah, because you mentioned about hysteroscopy in a patient with that bleeding, and you removed the placental tissue, and it has come as reported as. Yeah, in that Odyssey book, first book, we have published, mentioned it over there. Later on, published also. What I want to mention is hysteroscopy, whenever we think of as an elective procedure in infertility, abnormal uterine bleeding, postmenopausal bleeding. That's our concept. But this placenta, maybe she is going to come out with that. So we have published 5 cases. Later on also I did about 3 to 4 cases in an emergency of PPH. Now all these cases, even what Dr. Ambuja has referred to, all these cases have been referred to maternity hospital as emergencies. All the patients, almost all of them, previous cesarean section, they have done. During cesarean section, we expect that we would take out the whole placenta, but that was not the case. They have come back with PPH within a week or 2 weeks or 3 weeks, and then and most of them, the consultants have worked in maternity hospital and very senior, and they have attempted a DNC. And when you attempt DNC means, evacuation, as you have mentioned. Now what happens during evacuation is, if the placenta is partially attached, you catch hold of a bit of the placenta and remove. The rest of it you have not removed. That's when the torrential blood flow usually occurs. Partly separated placenta, not totally removed. Not contracting, the blood vessels are open. So in all those cases, what we have done, because these have been referred from outside to maternity hospital, so in an emergency setting, we have done hysteroscopy for postpartum hemorrhage. This is a secondary postpartum hemorrhage. And in all the cases, we were successful. you visualize where the placenta is and then take it out. That way you are very safe. And then after removing, while removing, it's a postpartum uterus. The uterus will be very big and your scope also will go so much inside. That is a little bit difficult. And distension also would be difficult because there is a dilatation of the os leak from below. So even getting distension. But still we could visualize the placenta and then put in a long sponge holding forceps, catch hold of it because we know where it is, remove it, again reinsert the scope and check it. So it's a very useful in this placenta accreta. That paper also I have published. Even others have published similar papers in literature where you can utilize hysteroscopic removal, even accreta, a small bit of the placenta, one cotyledon may remain, but it causes real havoc with heavy bleeding and hysteroscopy. And also there are so many cases in literature that are reported where they have already attempted different methods. They have done blind curettage, they have done embolization, still they have not succeeded. Uterine artery embolization to control the PPH, they have not succeeded. Finally, after all those procedures failed, they had to resort to hysteroscopy to remove. So it is for all the senior consultants, because such cases are dealt with by seniors, hysteroscopy in cases of secondary PPH, you directly visualize if it's an accreta, a small cotyledon is attached, you can very well remove it. You can't put these electrical gadgets into a sponge holding forceps.
What you did at that time was hysteroscopic assisted traditional method.
Yes.
But now they are such excellent equipment with the cautery and everything that the whole thing, I think I'm audible, the whole thing can be done by hysteroscope with the instruments that they have today.
Yes, but you also go into the literature because already I have seen the papers published.
Paper published exclusively only with the hysteroscope and the newer techniques.
Yes. Because in accreta, when we are discussing placental abnormalities, accreta, increta, percreta, yes, you do have. You must remember now we have a new instrument in our armamentarium, that is hysteroscope.
Yeah. Thank you so much. Thank you very much for the inputs, madam. Now coming to the next topic. Yeah, placenta accreta spectrum. This is one of the nightmares for every obstetrician here. So let's see how to tackle the situation. What can we do to prevent it? What care or which care we have to manage what? So let's go ahead. So dealing with the case now, she's a 29-year-old, young, sorry to say madam, 23, gravida 3, para 2, living 2, 34 weeks pregnancy. Then previous 2 LSCs, she's perceiving her fetal movements well. Then her antenatal care was at primary health care. So anomaly scan has revealed anterior low-lying placenta. So she was followed up, and her 32 weeks ultrasound scan suggestive of anterior low-lying placenta again with abnormal vasculature. There's thinning of myometrium. Placenta is seen just posterior to the bladder with increased vasculature to the bladder wall. Her hemoglobin is 12 grams per cent and blood group is O positive. Now, how to deal with this? She is undergoing her ANC at a primary care setup. So what kind of antenatal care shall we suggest her? Over to Dr. Mamta ma'am.
Initially, she has to be referred to a multidisciplinary referral center for her further care because she is at primary health care. And then she has to be introduced to that team where 24/7 senior obstetrician, senior anesthesiologist, blood and blood care products and level 2 critical care is available.
Yeah. So when coming to the antenatal care, we have first diagnosed it at around, in the anomaly scan, around 20 to 24 weeks of gestation. At that time, what a level 1 sonologist can tell when to suspect pass might occur in this patient. So can we know about the risk factors, or can it happen in a primary gravida?
It can happen in a primary gravida, but again, the history is very important, starting from previous any kind of procedure on the endometrium and the myometrium. So when you say primary gravida, even if it's a patient who's undergone ART or any kind of myomectomy which must have scarred the endometrium, any of such history is important. Other things like history of smoking, etc., are claimed to be risk factors, but I think in our scenario, most important is uterine procedures.
Yeah. Uterine procedures, again, we can see maternal smoking, as you said, and increased rise of IVF procedures, then previous history of manual removal of placentas, any septal resections which have taken place previously, previous myomectomies, and increase in the number of previous LSCS. So what can be the red flag signs for a primary care obstetrician to suspect placenta accreta spectrum? At the primary head, what could be the red flag sign when you have to rush the patient to a multidisciplinary team?
The placenta is low lying, and if she had a previous cesarean prior, then if she has bouts of bleeding or bleeding episodes, then we should suspect of PAS.
Again, Sir, J.V. Reddy sir, would you like to add something?
No. Placenta previa, all placenta previas, they bleed. All of them bleed. Some bleed less, some more. That is the only difference. All of them bleed. So they have to be in a good center with all the facilities.
Yeah. This is accreta spectrum, sir.
Yeah, they should be able to deal with that. If they can deal, they have to keep. Otherwise, they have to send to a center where that can be dealt with.
Yeah.
So what I am trying to say is all placenta previous bleed, whether accreta, increta, percreta. Okay. So they have to be in a good center.
So can we suspect this in a first trimester?
I think any patient who's had a previous surgery, if it is a low-lying placenta or a placenta over the previous scar, it's a red flag.
Yes.
And if it is a previa or a low-lying placenta which is not moving as the gestation advances, that is a red flag. It is adherent, which is why it is not moving up. It's not migrating up, as you say.
Yes. And now we see a lot of previous cesarean scar pregnancies. Which cesarean scar pregnancies can we leave? All, otherwise shall we terminate all the cesarean scar pregnancies?
Yes, we should counsel for termination if the fetal heartbeat is present in a cesarean scar pregnancy, because otherwise she'll land up in PAS in second and third trimester again, and the morbidity and mortality she has to face.
Yeah. If at all a patient is coming in the second and third trimester with the history of, not registered with us, I'm saying, with a history of cesarean scar pregnancy in the first trimester, then she has gone through a long course in the second trimester, but she hadn't had any bleeding bouts or any pain abdomen. Though now we can as well anticipate that placenta accreta spectrum is going to take place in the third trimester, where we need to raise our antennas. Then, whereas the same thing, cesarean scar pregnancies diagnosed in the first trimester, it will progress to placenta accreta spectrum is 100%. Other first trimester markers are, one is gestation sac located in the lower segment and multiple irregular vascular spaces at the implantation bed, right? Now, the same thing, what is the advice you give to a level 1 sonologist? What should they see in a just a implantation or any other? Do you have a checklist or a proforma?
Always look for the location of the placenta. Mention if it is coming into the lower part of the uterus, if it is covering the os, and indicate when the next follow-up to look for the placenta is. You are doing your TFA scan and everything, but mention placental reassessment at 32 weeks, because that is when you will know whether it is migrated or not. And mentioning it in the early pregnancy gives us a red flag which tells us that this is a patient who needs closer follow-up and management.
Yeah, this is a proforma, which this is the guideline which is given by European Working Group of Abnormal Invasive Placenta. Now it is an International Society for PAS. So they have given the 2D, 3D, 2D normal and 2D color Doppler, and a 3D things we have to see, specifications we have to see in an ultrasound and document. So when to refer to a level 2 scan? Having said all the things, tick, 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 then refer to a level 2
scan will be when you see any of those findings. Most commonly is placental lacunae.
Yeah.
And if it is over the scar region, I think that those two should be the most important points.
Yes. So there is an evidence saying that a contingent screening strategy for PAS is both feasible and effective in a routine healthcare setting, When linked to a past diagnostic and surgical management service, adoption of such a screening strategy has the potential to reduce the maternal morbidity and mortality associated with this condition. So the strict screening program has to be started at every level to pick up these cases and manage accordingly. Now, there is a consensus proforma from ISUOG. This proforma says that you have the details of the patient and the history, and coming to the ultrasound parameters, then color Doppler parameters about the bridging vessels, vesicle hypervascularity, subplacental hypervascularity. What about the bridging vessels? Then how about the placental lacuna feeder vessels? Are they there? Yes, no, or you're unsure? And how much is the parametrium involved in that? You have a suspicion of invasion into the parametrium? Yes, no, or unsure. So this is the proforma which is recently given by ISUOG. And now, what is the role of MRI? Dr. Sridhar, what is the role of MRI?
Definitely, MRI plays a good role. It helps in vascularity without giving contrast.
Yeah.
So you don't have to expose the patient to the contrast if there are any related issues. And also the extent of invasion, because it gives better imaging in involvement of the myometrium to the extent where it is invading into.
So when we have an eminent ultrasonologist like Amita ma'am, then is your MRI adding any importance to that?
If it is a posterior placenta, no matter how good you are, you can't see what's happening under the baby.
Yes.
So in which case I would send for an MRI.
Definitely. Yeah, posterior placenta. One more thing is morbidly obese patient where the, the picture is not visible on an ultrasound.
Parametrium involvement also.
Parametrium involvement also. When you suspect PAS on a normal ultrasound, then we have to go see for a parametrium involvement in the same setting. If we have suspicion of a parametrial involvement, then we have to go immediately for an MRI. And when to do an MRI?
Around 35, 36 weeks when we are thinking in terms of managing the delivery.
Between 32 to 34 weeks, we go for an MRI. So MRI may be used to complement ultrasound imaging to assess the depth of invasion and lateral extension of the myometrial invasion, especially with posterior placentation and also in women with ultrasound signs suggesting parametrial invasion. An unfavorable placental location or a high maternal body mass index do not present a problem for the MRI because the entire pelvis also can be studied easily, and it allows offline re-evaluation by different physicians.
Can I just, because you said that MRI 35.
When we are planning delivery, ma'am. So towards the end of the third trimester would be useful.
These cases of placenta, accreta, increta, percreta, they bleed, maximum amount of bleeding will be between 32 to 34.
Yes.
So that may be too late. They come with a bout of
they
bleeding.
don't have any bleeding,
if they have
maybe
bleed,
that.
of
But
course,
if they have, because we have a case at 20 weeks pregnancy, she started bleeding. By that time only the placenta has gone up utero vesicle
Patients
plane.
like that definitely
So
it's an
whenever there
earlier
is a
indication.
bleeding, we have to see where all and what is of the penetration. But if you think that we are very lucky and the patient doesn't bleed, we are very fortunate, then maybe you can plan.
This
Otherwise,
is where we are looking at, we have that ecolucent space where we are looking at only focal adhesion, not very deep penetration, then 34, 36 weeks. Otherwise,
even then
definitely
I
earlier.
feel clinical viability, that is about 28, 29 weeks, so that we can actually have a plan of management in our brain by doing a MRI mapping.
Yes.
Yes. So is the ultrasound going to decide my MDT team of surgeons? So if there is a parametrial involvement, is there a bladder involvement, then yes, I have to get a oncosurgeon, I have to get a neurosurgeon and to my MDT team and keep them ready. And how should an MDT center be? What is your team of MDT, multidisciplinary team? Dr. Mamta ma'am?
It should have a level 2 critical care, 24/7 senior obstetrician as well as anesthetist. Blood and blood products should be available. If possible, intensive intervention radiologist and a urologist with a good pathologist.
Yeah. So 24/7 MDT services, emergency care, then an interventional radiologist, colorectal or oncosurgeon, vascular surgeon or urosurgeon, hematologist, massive transfusion facilities, ICU with critical care team and an ICU. And that MDT center has to maintain a high volume of cases per year to maintain their expertise. And the research has showed that delivery at MDT centers have showed significant reduction in the composite early morbidity in terms of prolonged maternal admissions to ICU, large volumes of blood transfusion, coagulopathy, ureteral injury, and early reoperation. So there is significant reduction in these things. So when do you plan the delivery? Sir, JV Reddy sir, when do we plan the delivery?
Yeah, I think everybody is saying 34 weeks, no? Maximum 37 weeks, yeah?
Yeah.
34 weeks. See, here we have to see that earlier you deliver, you are safe, patient is safe. So whether you can save the baby or not, you have to think about the facility center. See, the smaller the uterus, easier to operate. That is the thing. But baby has to survive, isn't it? That's the balance you have to strike.
With the previous history of LSCS, if we know what is the reason behind the previous history of LSCS, is it a PPROM, is it a preterm LSCS? If those risk factors are there, we have to anticipate the delivery between 32 and 34 weeks. And if there is the previous LSCS are due to fetal indications at term, we can wait up to 34 to 35 plus 6 weeks of gestation for planning an elective cesarean section. So in the same way, we need to plan our antenatal corticosteroids.
It's like a volcano. We are sitting on a volcano for a case of severe placenta accreta or the percreta. So it all depends on the clinical scenario. You have to admit the patient. She should be under your vigilance and supervision. At any moment in the midnight, she will be having a torrential bleed. So you cannot be very strict with your 34, 36 weeks. To take that antepartum steroids, or whether if it's needed 24 hours before, magnesium for the neuroprotection, and keep ready. I think we cannot have a very definite term of pregnancy to have. If we are lucky, as I said, yes, we had till 37 weeks one patient did not have bleed, and then we could do a elective procedure. But we should be ready.
In public hospitals, once placenta previa was diagnosed, throughout her pregnancy, she used to be in the ward, because there was no problem of, cost and expenditure and all. So, the patient has to be in the hospital to be safe.
Weeks.
Yeah?
Yes, yes. If at all she has symptoms from early third trimester, yes, we need to admit the patient and keep her under observation and then plan the delivery as per the fetal maturation. Then, what should be our counseling and consent forms, Dr. Mamta, as a clinician?
The counseling regarding the transfusion of blood and blood products should be taken.
Yeah.
Counseling for cesarean hysterectomy has to be taken.
Yeah.
If there is invasion beyond the bladder and the parametrium, then uterine stenting, bladder injury, major organ damage should also be taken.
Yeah. There are few people who might not accept the blood and blood products also. If prior consent, whether they are ready to accept the blood and blood products also, we need to take a consent. Also, risk for other injuries, as you said, ma'am, risk of sepsis, hemorrhage. If at all we are leaving the placenta in situ, then need for the follow-up later on and need for further investigations. We need to repeat the coagulopathy, we need to do the septic screen and also all the need to follow up investigations and bowel and pelvic vessels, if at all anything is damaged, they have to cope up with the morbidity and all. All these concerns have to be very well explained in your consent forms and taken in prior before the patient bleeds or before the patient ends up in a catastrophe. Now, that is a reason only Yes, ma'am. I have her. So now the Joint Obstetrician and Gynecologist Committee of Canada has released a checklist for placenta accreta spectrum, and this is the checklist. Before we plan, we have to tick up the checklist whether all these things are available with us. No, a nearby MDT center have all this checklist available with them, then refer her to a nearby multidisciplinary care So you have the patient names and all, and the gravida parity, then expected date of delivery, blood type, antibody screen, BMI, previous LSCS and their number, previous uterine surgery, desire for future fertility. Do they want future fertility or not? Then number of APH episodes up to date. How many consultations did she have until today? Then what are her ultrasound parameters? Then, okay. Then what is the next designated delivery center? What is the MRI findings? All these things you need to take, say to it and fill the checklist and then take up your thing. Yeah. So I have one question to Dr. Lakshmi Ratna ma'am. So what is your experience in the surgical technique of managing cases of placenta accreta spectrum?
So Lakshmi, 2 quick questions because we need 5 minutes for the expert after this. So we are not going to have anything more after this. So now the final round will be yours. And you're going to tell us first your experience on the expectant management because you have done the maximum series over here. And second is the surgical, crisp 2-liners on the surgical technique. Yes, sir also.
No, as you correctly said that second list of surgical checklist is very important. About the blood, about the anesthesiologist, about the neonatologist, and check and recheck your consent forms because you may turn to any other things also in the extra surgeries will be there. Now, my patients in my series, there were many patients who were primees and who were very preterm where they wanted the retention of the uterus. I have done a lot of conservation techniques, placenta in situ. The credit goes to Dr. Venkateshwarlu because he was always by my side. We're doing the embolization, means catheterization, and keeping ready. So that we have to plan our incision, the vertical incision, and also on the uterus. Yesterday we were discussing what classical, like a classical cesarean, we have to go. If it is a placenta previa morbidly adherent, never give our fan and steel incisions and never give the transverse incision go up because we are easy to deliver the baby first and watch for bleeding. And don't touch the placenta at all and clamp the cord as close to the placenta, origin of the umbilical cord, and don't touch. If you are lucky, there will not be any drop of blood, believe me. If you meddle with the placenta and halfway it comes and half is intact, then we are in a thick soup. But
Sorry,
if you don't touch...
No. Unfortunately, all of us touch it. That is the problem.
We have to be masterly observer.
Yeah, that's right.
Observation. So,
don't
touch. So masterly inactivity we should be there, and luckily if it is really morbidly adherent placenta, we don't see the blood. Anyhow, we will be thoroughly preserve the blood products and all. So what I used to do is nicely close it, very easy. The procedure is simple. You are just delivering from the upper segment. It is very easy for us. There are no problems for the delivery of the baby.
You are talking about vertical incision in the abdomen also.
Abdomen also.
But even in the most critical times also we think about cosmosis. That is the unfortunate thing. Another unfortunate.
No, for the accreta.
That is what
any undiagnosed case you can say
for the cosmetic because life is more important here. Then when we keep the placenta inside, then we of course previously we have explained the patient because it's a long journey. It may be 3 to 4 months minimum if we are lucky, otherwise it may be 6 months. And we had in our series a thorough and very torrential hemorrhage. In the midnight the husband carried the patient to the hospital with torrential hemorrhage. That is one case we had, but otherwise they would come for a follow-up. Every week beta HCG will be done and we follow the trend, how it is. Usually I give only weekly injection methotrexate, 1 milligram per kg body weight. Beautifully the vascularity will come down. When you have to take vaginal swabs and treat accordingly whatever the infection is there. And then believe me, in 3 to 4 months time it regresses very beautifully. Probably at that time when she will be having on and off bleeding, dirty brown color or blood stained, maybe we may have to give 1 or unit, 2 units. But the end of it, you definitely have the credit. She will be very happy to have the uterus and come back with the pregnancy.
Have you seen any complications in the future pregnancies when dealt with such patients, madam?
Future pregnancies, you have to check where the placenta will be. Because if we have given the classical section, suppose again it is coming in the anterior, it may recur.
Always there is.
Yes.
Mike?
Usually it is associated with mostly placenta previa. If it is in the upper segment and anteriorly, and you have already MRI mapping of the placenta, then you can give the vertical incision in the lower segment for a quick delivery. It depends. See, if it is a preterm, your lower uterine segment is not formed very well. So you have to take a decision on the spot. And there is no hard and fast rule, you should not do it.
Evidence says that on table we need to go for a very sterile ultrasound technique, and at the upper border of the placenta we need to take a incision and then deliver the baby and manage. Yeah, so this is an important slide. What is the first line of measure should be an intrauterine tamponade, which could be a balloon tamponade. If this measure is not effective or the placenta remains in situ, an additional useful measure is uterine devascularization with or without uterine compressive sutures. The last measure is to be tried is a ligation of the internal iliac artery, as this procedure is associated with the highest risk of postoperative complications. When the woman is unstable or the bleeding is life-threatening, the surgical team should focus on the source of blood loss. In most cases, this would be found in the placental bed. In such cases, an emergency hysterectomy should be performed rapidly. Compression of the common iliac arteries or aorta has been reported as a temporary measure to gain time to temporarily stop the bleeding and to quickly complete the definitive treatment. This we can as well practice it even if our center is not a multidisciplinary care. If the expert gynecologist is managing it with the help of a general surgeon also. So I invite Dr. J. Venkateshwarlu sir to share his expertise of interventional radiology of the cases he has managed. Yes, sir. Yes. So my code.
Now, temporary occlusion of vessels can be done by surgical. During the procedure, you can occlude the aorta temporarily, or if it is possible, iliac arteries bilateral. That is also one technique. If you are planning for endovascular therapy, and see, initially, so I am practicing for almost 16 years. Initially, we started occluding the internal iliac arteries both sides, but it is technically very tough. You need a lab, you need a lot of devices, and a lot of time, punctures on both sides. So we abandoned it. So next we can do only iliac arteries on both sides. Again, 2 punctures, that is a problem. So what we thought was just put a balloon in the aorta, just infrarenal, because this concept of aortic occlusion is started from Ribova, a technique used for in the wars. They occlude the aorta to transport the patients to the centers where they are treated. So this is adapted in that line. So they were planning supraortic at the level of renal arteries, below the renal arteries. What we do for all our cases is below renal arteries. If you occlude across the renal arteries, there is a chance of increased blood pressure. There is renal ischemia and increased blood pressure. And okay. And I had 32 cases of aortic occlusion, and I am not talking about internal iliacs, so around 36 cases. No data on that. I am not planning to do that. So only the aorta 32 cases. Just I am analyzing for 25 cases. Next. Yeah. Next. So 15 cases underwent hysterectomy because of uncontrolled intrapartum hemorrhage, and 4 of them had a percreta and 11 of them had a percreta. So that is the data there. Hysterectomy 10 cases, and we avoided in 15 cases. The main idea is just to avoid the hysterectomy. That is the thing. And bleeding control during the surgery. Next. Yeah, what is the blood given? During hysterectomy case around 1200 ml and non-hysterectomy case around 800 ml. Next. Yeah. Cases. Cases. Yeah. Case లేదు కేసు చూపిద్దాం
Routinely you are doing.
Lakshmi ma'am, one question, madam. Can we give oxytocin when we are leaving the placenta in situ after the baby delivery?
Hello. Hello. May I answer this question? Hello. So we had done a series of 19 cases with aortic clamping in a placenta perpetuita at Pune. So in that case, I was about to just tell that because Lakshmi ma'am has almost told everything that was possibly should have been done. But in elective cases, when you are planning for obstetric or caesarean hysterectomy for that matter, it is always tell your anesthetist not to give any of the uterotonics as like what we are trying to fidget with placenta, it will start bleeding. Similarly, when the oxytocin or any of the uterotonics you are planning to give, it will certainly, anywhere the placenta is not adherent, that part will start to separate and that will cause a torrential bleeding. So unless and until we actually are dealing with the separation, like bladder separation and all, the bleeding is not expected until then. We are in a very safe zone when we take a classical incision and deliver of the baby. It's basically the lower segment and the bladder dissection which causes a major of the issue. So strictly there shouldn't be any oxytocins or oxytocics given during the placenta perpetuita syndrome, like anticipating a caesarean hysterectomy. Thanks.
So, when the cases are suspected and planned for that, next what to do is next slide. Next slide.
I'm a gyneco-surgeon and general surgeon and gynecologist.
Next slide.
So in emergency, when you are going to operate, if you won't expect, there is an instrument called bulldog. So you can apply bulldogs on both the iliacs. So you can have time enough to have a help. This is more useful. You can pass the umbilical artery. Bulldog clamps. Yeah, that is very vascular instrument. It is simple. Be ready with all the obstetrician should have any emergency, any PPH. During cesarean section, you can apply the bulldog and you can have enough time to have support.
Yeah, this case was, MR was also done. Next. Yeah, next. Yeah, again, next. Yeah. Generally, these are the balloons used for peripheral angioplasty balloons. See, the balloons length should be very important because due to high flow, sometimes if you use a shorter length balloons, they will be, going down in the aorta. So generally we use the size of the balloon could be vary from 16 millimeters to the 20, depending on the size of the aorta. But generally in Indians, around 18 is ideal this thing. So this is a balloon we use next. Yeah. So we access usually from femoral access. So you can see there is a balloon there. Yeah. The balloon there, and it is located infrarenally. You can see the renal arteries on both sides. Okay. Then just we keep the balloons and just ship the patient to the OT, and then once the baby is delivered, just to inflate the balloons, depending on the situation, whether they do hysterectomy or a conservative management is planned. So in this case, see, this is a placenta perpetuita, previa. So it took only just 10 minutes procedure. So inflation is only 10 minutes. This is another case. You can see now. Okay. Go ahead. Yeah. Is it, okay. Next. Again, a balloon is there. Again, inflated. Next. So in this case, this is a perpetuita case. So It took long time to, so it took 35 minutes of inflation. But generally we inflate for a 20 minutes at a stage. Sometimes one case we occluded for 2 hours because we did in it is a COVID time. We are doing in a, cellar and no AC, nothing. So at that time patient was very hypertensive. We inflated for 2 hours, only one case. But generally 20 minutes and after just 2 minutes we stop, then again inflate. So like that up to 1 hour we do. But only one case we did for 2 hours. Okay, no?
Yes, sir.
Thank you.
Yeah. Thank you so much. The time is up, so I have to wind it up. So final, I would like to place the take-home message. So early identification, counseling and concerns have to be ready, optimization of the mother's health and the hemoglobin status, early referral to MDT center, surgical expertise with interventional radiologist or oncosurgeon or a neurosurgeon, steps to reduce blood loss and to prevent anemia and future fetal-maternal hemorrhages. Follow-up after conservative management to reduce the emergencies, then preventing unnecessary LSCS and unwanted uterine procedures, which is the keystone to prevent further more pus.
Dr. Malti has been using what is the clamp? Iota clamp. So let her tell in placenta accreta spectrum. This is the recent. She went to Kerala and learned from Dr. Paley.
So any eclampsies, madam was mentioning about the bulldog. So what I have learned there from Dr. Piley in Kochi is to apply. This is something very friendly to an obstetrician where there is a long learning curve for an internal iliac artery ligation, and some of the many centers, including my center, doesn't have an interventional radiologist, sir. So what we have learned in our government sector is to apply Piley aortic clamp, which does not require any dissection. Bulldog requires dissection and it is commonly used by the cardiologist for open heart surgery. So this does not require any dissection, number one. It can be applied on the aorta or it can be applied on the common iliacs. And we have done this for 9 cases till now. And it is like completely bloodless field. It facilitates your cesarean hysterectomy.
No, aorta can be compressed by thumb also. Only thing is you can't be doing for so long.
So external aortic compression.
No, you can't be. It's impossible for a human being to do it for so long. You have those
not
instruments.
By the thumb, by the.
So when it is not there, don't bother. You put your thumb and compress the aorta.
No, by the fist actually. That we were practicing external aortic compression. We were practicing. Our anesthesia team was helping us. But this is more effective because there will be fatigue and it is not like continuous equal pressure. So this is more effective, we found. But one case where there were a lot of collaterals, that is the FIGO classification 3B, where bladder was invaded. Despite this aorta clamp, after post-hysterectomy also there was a bleed and we had to call the urologist is always called for our cases and we had to proceed with even internal iliac ligation in one case.
No, fist compression is for PPH in a normal delivery. Thumb itself will be enough for in an open case where you are doing a section.
Thank you, sir.
Okay?
So we have another youngster here like you who has done a series of 19 cases with and presented at FIGO, I believe. So just one line.
Actually, the pressure, amount of pressure that needs an aorta to be compressed is almost like 35 kgs per centimeter square. So that amount of a pressure to compress an aorta is impossible for anyone to sustain. And like in between also, little gush of a blood when it passes through, our whole purpose of having that procedure or having those things done, as like sir rightly said, it can only be done in a cases where you are trying to shift that patient to a tertiary care center. At a tertiary care center, we expect that management to be brief and like to the point. So like what you have said, compressing the aorta from the outer side is a fantastic idea. At our place, what we used to do, we are doing is we are dissecting the aorta just above the bifurcation of the iliacs, common iliacs, and clamping the aorta directly. Because above the peritoneum, retroperitoneumly clamping the aorta through the peritoneum, having the IVC very nearby, it actually gives us that a sense of
I think you need to interact with Dr. Piley. All your apprehensions, I can call it as a myth. And there were deaths where learning curve is more when you do a dissection.
No, correct.
And
I
once
agree.
injury,
I think all the seniors would also agree with you that a clamp is much easier than
because
going and
luckily
dissecting the
during
aorta,
pregnancy,
where you're
there
already
is-
mentally totally drained
during
out.
pregnancy, there is a lot of fat deposition.
Yes,
that
yes.
acts as a cushion
Yeah,
actually.
yeah. No,
that is helping in pregnancy.
Thank you so much, the panelists and the interactive session. And I can see everybody alert even in the afternoon.
Yes.
Thank you. Because when we started off, everybody was kind of sleepy and I was wondering what's going to happen. Thank you, everybody. Thank you, Lakshmi, for having me in and giving me a topic which is nothing related to menopause.
And she has written books also on menopause. So when I said you have to be a faculty,
Dr.
said,
Meeta-
don't give me menopause.
Dr. Meeta,
So I said I'll give you
cesarean
something
hysterectomy,
else.
again, the next phase is menopause only. So it's related to you.
Yes. So I think we'll, next is handing over the mementos. We don't want to, take
I'm
in more
just,
time.
sorry to interrupt, ma'am. I'm just posting the reporting what you have to do before sending a requisition for histopathology for cesarean hysterectomies. Just that I've missed the point and it is important. Our panelist, Dr. Aditya Kulkarni, is also sitting here.
Yeah, so I'll just take 2 lines. So both structural abnormalities of placenta and placenta accreta spectrum, both are absolute indications for a histopathological examination. And you need a trained perinatal pathologist to look at these things. So because these placenta accreta spectrums have distinct histopathological signs which you can diagnose, and sometimes it may not be a morbidly adherent placenta, sometimes it might just be a retained placenta, and you need a pathologist to diagnose both the diagnosis and the extent of the invasion. So I just wanted to say
Aditya,
that.
I think before we close, I've just requested them, can I take 1 minute more? Now in that 1 minute, you're going to tell the audience, when should the obstetrician send the placenta to you?
Okay.
What are the indications?
In general,
but very quick.
Yeah.
The important ones.
So,
Don't go into all the detailing.
Yeah,
The
so
important ones.
basically, like as a pathologist, I'll always tend to organize and classify things. So if you talk about indications, you have maternal indications,
Yes.
fetal indications, and
Placenta.
placental indications.
So the common ones.
So the placental ones are structural abnormalities, morbidly
All
adherent,
structural.
all of those things. Fetal indications is the major mainstay of our examination is fetal growth restriction, and if there are any anomalies. Then you have maternal indications where you have pregnancy-induced hypertension, diabetes mellitus, thrombophilias, infections, short cervix.
Yeah.
Bad obstetric history is another major one. So in these cases, we can really help because placenta is one of our favorite quotes is that placenta is a black box of pregnancy. So everything is recorded in the placenta if you
Very
know where
true.
to look. And,
So how many of us are sending the placentas for pathology unless there is an IUD or something like that? Are we sending it routinely in the indications that he has said? Placental insufficiency, IUGR.
Fortunately, if at all the placenta
So
insufficiency.
maybe you can share that form with everybody.
So
and
we have
should
a
be doing it
requisition
more.
form. Yeah, I'll share it
Thank
with
you.
Dr. Satyashri. and
Thank
we'll
you
check
so
it.
much. Thank you, organizers, for giving us a little extra time.
Thank you, dear
You have to
panelists.
send it in formalin in a big enough container. So actually, Western literature says that you can freeze it and keep it at 5 degrees Celsius and then transport it and all of that. We don't have the infrastructure for all of that. Not all of us might have. So just formalin in a big enough container so that it does not get distorted. That's the only thing you need to do. And then we will take care of the rest. We cut it up, we fix it properly for 2 days or so, and then we take sections.
Thank you so much, sir. We are running out of time. It was a wonderful session. Now it's time to give the mementos to our moderators, Dr. Meeta ma'am, Dr. Lakshmi ma'am will be presenting the memento to you, ma'am.
And I must thank Satyashri for being my co-moderator.
Dr. Satyashri ma'am.
Thank you so much.
Dr. Venkateshwarlu sir. By Dr. Meeta ma'am. Dr. Meeta ma'am, to Dr. J.V. Reddy sir, Dr. Sridhar sir, Dr. Amita ma'am, Dr. Aditya Kulkarni sir, Dr. Mamta Neely ma'am, Lakshmi Ratna ma'am, Meeta ma'am will be presenting to Lakshmi Ratna ma'am. Thank you so much, ma'am. Next session, I would call upon the chairpersons, Dr. Pratibha ma'am, Dr. Professor HOD and Superintendent of MGM, Usmania Medical College, Dr. Priyamvada ma'am, Consultant Obstetrician and Gynecologist, Ankura Hospitals, Gachibowli, and Dr. Lakshmi Ratna ma'am, Consultant, Ankura Hospitals, Mehdipatnam branch. For the next session is Mass in Breast by Dr. Pragnya. Can I request Dr. Priyamvada madam to introduce Dr. Pragnya, please? Thank you. Over to you, Dr. Pragnya.
Good afternoon, everybody. In this pre-lunch session, mild hypoglycemia, I think Dr. Pragnya is going to give us a good talk on mass in the breast. She is a general surgeon from Ramchandra Medical College, Chennai. She did her MRCS from Edinburgh, UK, her breast oncology fellowship from Tata Memorial, breast oncoplasty from East Anglia University, Norwich, UK, and breast oncoplastic fellowship from Stoke University Hospital, UK. She is currently working in AIG hospitals. I wish her all the best. Over to you, Dr. Pragnya.
Thank you, ma'am. Thank you for the introduction, and good afternoon, everyone. I'm going to try and keep this as short as possible, but I think this topic is extremely important for gynecologists, as you are still the first place that these patients actually come to. So my name is Dr. Pragnya Chigurupati. I'm a consultant oncoplastic surgeon from AIG. Breast masses as such, let's say, are the most common, and they are associated with a wide spectrum of diseases, from benign physiological adenosis to advanced malignancy. It is most commonly seen in the reproductive age group, but it's also seen in children and in men. Let's just say that 9 out of 10 lumps are actually benign, so there's no reason to panic, but they have to be diagnosed adequately. The ratio of benign to malignant breast diseases is 10:1. So a quick note on the anatomy of the breast. We know that it's a modified sweat gland. It has glandular tissue, which has the different components such as the lobules and the ducts. And they open, the lacticiferous ducts are the ones that open into the lobules, which ultimately open into the nipple. And amidst this is the fibrous tissue or the stroma and the fatty tissue. So the boundaries of the breast are the pectoralis major, the sternum, which is medial, clavicle, which is superiorly, and the latissimus dorsi muscle laterally. And we also know about the Cooper's ligaments, which spread from the dermis to the pectoralis fascia, and because of which there is dimpling of the skin. These are the different quadrants of the breast, and it's extremely important for a surgeon especially to understand where this tumor is located. And more than one tumor, more than one quadrant or not is again extremely important. Lymphatic drainage predominantly drains to the axillary nodes, but 25% of them drain to the internal mammary nodes, especially if the cancer or the infection is in the inner quadrant. So whilst understanding a breast lump, the most common thing, three most common pointers are taking a detailed history, a clinical examination, and then you investigate. So these are the different kinds of lumps that you might see in your patients, which needs to be diagnosed adequately. We all know the difference between benign and malignant, so I can actually skip this slide. But one important point in this particular slide is that sometimes malignant lumps, especially triple-negative tumors, can feel like benign lumps. So it's important to do what we call the triple assessment. No patient is diagnosed, especially with a breast cancer, unless and until it is a triple assessment, and which means clinical examination by us. And the second thing is imaging. Now, imaging, I would definitely like to emphasize on this because every woman with or without a symptom above the age of 40 should get a mammogram for screening, and those above the age of 40, again, with a mammogram. Below the age of 40, an ultrasound is okay for screening, but if there is any one particular symptom, she might have to undergo a mammogram with or without an MRI. And this imaging has to be done prior to the pathological evaluation, because otherwise it would distort the entire image of seen on the mammogram or the MRI. Although we know that FNAC is one way of pathological diagnosis, I would still say a biopsy is the way to go because of the answers that we get on a biopsy. And in no way should you go ahead doing an excision biopsy unless the lesion is very suspicious or very small. So imaging, like I mentioned, below the age of 40 is with an ultrasound, above the age of 40 is with a mammogram. And if it's high risk, a mammogram is indicated in women above the age of 25 with or without an MRI. So I'm not going to get into the details of the classification, but I will go through a few important benign breast tumors. These are the benign breast tumors that you can see on the screen. And we all know what ANDI is, aberrations in the normal development and involution of breast. So the woman goes through a plethora of changes through and through her life. But because we're talking about lumps today, I'm going to keep it to a few important lumps. And malignant tumors. We have both in situ carcinoma as well as malignant breast tumors, such as invasive breast carcinoma, which are derived from different parts of the breast, and they have different ways of dealing with them. These are the other rare tumors of the breast, which are epithelial, non-epithelial, and this is where your pathologist comes into play, because each tumor is dealt with in a separate way. So the common presentations of lumps are commonly under the age of 30, it's generally a fibroadenoma. Between 30 and 50, they're fibroadenomas, breast cysts, Phyllodes tumor, mastitis, and cancer. Above the age of 50, it's cancer, but rarely fat necrosis or abscess in diabetics. But please note that the demographic has changed today, and although our average age of breast cancer is 45, nowadays in my clinic I'm only seeing women with in the 30s and late 20s with cancer. So if you see a radiological and you feel a clinical diagnosis is still a fibroadenoma, please make sure that you biopsy to be absolutely sure. Because women in the late 20s and early 30s, especially in pregnancy associated or during feeding, and they're not subsiding on the basic medication that we give them, they might be misdiagnosed and it might lead to the next stage. So please make sure that you biopsy every patient in whom there's even an small index of suspicion. So benign lumps, fibroadenomas, we all know that they're the most common benign tumors which arise from the intralobular connective tissue. Common ages are 15 and 35, and they are seen in patients who take prolonged OCPs, and it is generally painless and freely mobile. These are the different kinds of fibroadenomas that we see. Giant fibroadenomas are about 5 centimeters. Treatment, obviously, although we have treatment based on certain guidelines, we can observe tumors below the size of 2.5 centimeters, but anything which is recently growing or anything above 2.5 centimeters should be dealt with. Again, a vacuum-assisted biopsy, which is a non-surgical technique, can be done in women who are not married or breastfeeding, just so, and those who have not been married and who need to be breastfed, who will be breastfeeding in the future, because that is non-surgical and scarless. But it's only tumors around 2.5 centimeters that can undergo a vacuum-assisted biopsy. There are other procedures such as cryoablation. Unfortunately, we don't have that in our country as yet. But anything above the age of 3 centimeters, it's a surgical excision. Very few medicines actually help in decreasing the size of fibroadenomas. The only thing that we have seen some sort of evidence is in SERMs, that is Saheli, that we see very often. For this, and that's ramiloxifene, sorry, I forget the name. But for SERMs, we can only give them for a short period of time and assess the size reduction with an ultrasound, although it's not shown to be much. Phyllodes tumor, again, it's a proliferation of connective tissue with ductal elements. It is seen in around 0.3 to 1% of all the breast tumors in females. It can be anywhere from 2 to 40 centimeters in size. And remember, again, this is not a radiological diagnosis. It is a pathological diagnosis, even better when you remove the entire lump, because there are 3 different kinds. That's benign, borderline, and malignant, and the treatment varies for every single lump. The current recommendations for treatment are wide excision, removing the underlying muscle as well as the overlying skin, because of the common origin of the tumor. Otherwise, it can recur. And remember that negative margins are absolutely essential. In cases of recurrence or malignant tumors, radiation is discussed. Breast cysts, again, something that we see very commonly in our clinics. It's again seen between 35 and 50. Overnight, if a woman comes to you saying that she has a breast lump, it could be a breast cyst, so please make sure you get the adequate investigation and ask your radiologist if it's a simple, complicated, or a complex cyst. Because if it's a simple cyst, we can just aspirate and we can just monitor the fluid. If it's complicated, we might have to give some sort of antibiotics, and if it's a complex cyst, we will need a biopsy to rule out papillary lesions or intracystic papillary carcinoma or an in situ component. So these are simple cysts which can just be aspirated and patient will have symptomatic relief. Papillomas are again most often an image-guided finding, and it arises from the epithelium of the mammary duct. Central or peripheral papillomatosis is what you might get on imaging. If it's a peripheral papillomatosis, please make sure that this patient is at a high risk of breast cancer in the future, so you counsel her adequately. For papillomas, if it's a central duct papilloma and if it's bloodstained nipple discharge, please go ahead for microdocectomies for a diagnosis or a Hadfiet's procedure, which is basically removal of all the ducts behind the NAC as the final definitive surgery, and only then will you get an adequate diagnosis. The main thing here is to rule out in situ or an invasive component. Nipple adenomas are again something very commonly seen in women who walk into a clinic, but just make sure it's more of a clinical diagnosis, but also you have to rule out the presence of a Paget's disease, and a nipple adenoma is generally, the treatment for it is complete surgical excision. And because recurrences have been noted, margins also have to be negative. Hematomas are again most commonly seen on imaging. You might not feel any lump, but the lump actually might be around 10 to 15 centimeters on imaging. There is no intervention that is required for this in most of the times. But if there is a clinical doubt or if there's an imaging doubt, that's when you require a surgical excision to rule out any cancer. Lipomas are again benign tumors that might be seen in any part of the breast. They are nothing but fat globules, and radiological diagnosis will reveal the final diagnosis. And in these cases, if you do a biopsy and it's conclusively given as a lipoma, you can just follow her up. Infectious lump. I'm sure most of you see a lot of lactational breast abscesses in your clinic. At that point, make sure that you diagnose it adequately and do not wait for a fluctuation in an abscess. Please aspirate the fluid and start antibiotics based on what your pus culture says. Most commonly, we use augmentin, taxim, or linezolid because 90% of these tumors are MRSA positive. So infectious lumps are MRSA positive. Also, this is a case of inflammatory breast cancer which has to be excluded in cases where the redness and erythema does not reduce with antibiotics for over 2 weeks. And once, if you see such symptoms in a woman who's around 40, 50 or 60, please make sure that once the mastitis subsides, you get an adequate imaging to rule out any cancer. So the last part of my topic would be malignant lumps, the big C. The most common type of cancer in India amongst women now is breast cancer. And earlier it used to be cervical cancer, but we all know because of the HPV vaccine now, breast cancer has superseded even cervical cancer. To put things in perspective, in India currently, in rural India, the rate of breast cancer is 1 in 64 women, and in urban India, it's 1 in 22 women. In the US, although it's 1 in 8 women, majority of them...
Sorry to interrupt, Dr. Pragna, only 2 minutes left.
Yeah, that's fine. Most of them present in the early stages, so it's completely curable, whereas in our country, around 40 to 50% present in locally advanced stage. According to the data, again, most commonly it's 11.7% of all the cancers are breast cancer with a mortality of 6.9%, which is quite disastrous. And like I mentioned earlier, we see a predominant number of patients between 25 and 40 years of age. When you see certain signs such as Purulence, inflammatory breast cancer, Paget's disease of the nipple, please make sure that you do not rule it out as a benign condition. Also be aware that patients with breast cancer might even present with just metastatic symptoms, so you have to adequately examine the breast at those points. This is a staging of breast cancer. Early breast cancer today is completely curable, around 95. It has a good survival rate of around 95%. And the multiple modalities of treatment are surgery, radiotherapy, chemotherapy, hormone therapy, and targeted therapy. And it is a multimodality approach with all of them being involved in it. But in my opinion, the most important are genetic counselors, breast radiologists, physiotherapists. And following up these patients is absolute key. Just one part of this multimodality treatment is not enough. It has to be an MDT approach. Just a quick note on what we do today. We don't just do a mastectomy, we also do breast conservation surgery, which is completely safe with radiation and a boost to the bed. And this may be associated with or without oncoplasty. A sentinel node biopsy, which is just either using a blue dye or ICG, is practiced in node negative tumors. Oncoplasty. To avoid scars like this, we do a simple oncoplasty, which can be any one of the types. And in those women who require mastectomy, we can do a whole breast reconstruction with either implants or using your own fat. That's autologous reconstruction. It's not going to the next slide. Okay. So these are just some examples of patients who have undergone breast conservation surgery. Okay. These are different procedures that we've done on patients, and it's not, something's wrong. Okay. Yeah, just a few pictures left. Yeah, din tarvata. Forward. Yeah, I am. It's. Okay, I guess the pictures are not showing up. But the last slide, I also want to have a quick note on family history. If a woman presents to you with a strong family history of breast cancer, please make sure that they're referred to a genetic counselor or a breast oncologist close to you, because they will have the option of getting the test done and risk-reducing mastectomy. And also, please be very careful in diagnosing the conditions of pregnancy-associated breast cancer or breast cancer associated with breastfeeding. They have to be adequately imaged and diagnosed. Thank you.
Thank you, Dr. Pragna. Anyhow, I have learned quite a lot from your talk. She mentioned breast cancer is the most common cancer, accounting for 25 to 30% in India.
Around 11.9 amongst all the cancers.
That's okay.
Around 11.9 amongst all the cancers.
Okay, that's the leading cause of cancer
Yes.
in women. Second comes cervical cancer. The other point that you mentioned, it is detected very late. in a late stage in almost 35 to 40%
Yes,
of
ma'am.
cases.
Yes, ma'am.
What makes me really wonder is, see, breast is not an internal organ, it is an external organ which is accessible for palpation and detection, early detection. Now, ovarian cancer, we can imagine it's an intra-abdominal organ, and late diagnosis is commonly, it's the rule, late diagnosis in stage 3 or so. But breast cancer, are we failing in our responsibility to detect breast cancer?
Ma'am, most of them, unfortunately, besides the fact that they don't know what these lumps are, some people think it's nothing, it just will pass on time. What I've noticed is women generally tend to ignore themselves. They have something ranging from a kid's birthday party to or a husband's illness, which just keeps them back at home. Right? So I think as our job, what we've also been doing is every woman, including anyone who comes as an attender to the clinic or the oncology division, we teach them how to examine their breast, even though they're not anything related to breast cases. We teach them how to examine their breast and encourage them to come for a screening from the age of 40. And that's the first thing we can do. And Mamo,
the government of Telangana is, has already introduced that Arogya Mahila program, wherein these people are trained to
yes, ma'am,
do the breast palpation
yes,
also.
yes, ma'am.
Arogya Mahila, they are still under training. But it is really, it reflects very badly on us gynecologists. What I would suggest is, from this hospital, and there are our OGSH and Foxy representatives here, what we must do is, because when I was working in CARE Banjara Hospital as professor and HOD, we made it mandatory that every case gynecology patient or obstetric patient, doesn't matter, every woman you must write their breast and is there any lesion, breast. And I gave this as a dissertation to Dr. Madhavi, I think. Yeah, she has written her dissertation, breast and lesions of the breast in women.
Yes, ma'am.
So that was completed in 2014 itself. But what I'm saying is, we must, as women and as societies, pay more attention to examining the breast. Your gynec examination should not be complete without you mentioning
breast examination.
Breast examination. When you mention external genitalia healthy or perspiculum, cervix, vagina and PV, uterus, first of all you must write breast. I don't know whether you are all doing, but from the time I was in CARE, I was we entertained that examination of the breast should be a part of gynec examination. Then you cannot afford to miss any.
Yes, ma'am, I agree. And to add to that, because every woman walks into the gynecologist clinic as the first day, I would also encourage an adequate radiological diagnosis, because half of them get misdiagnosed by not getting the right kind of imaging.
Thank you. Okay, one more point I would like to make. I don't know whether that WhatsApp message has reached you yet. There are 25, world organizations, all the top ACOG and WHO and all those organizations together, they have recommended, 25 recommendations have been made regarding the investigations, which you have to cut down and which you have to step up. So they have advised mammography to reduce the number of, I will send you the WhatsApp message. When you do mammography is indicated cases, okay. But what they are saying is routinely, like to prevent colon cancer, what we are doing, like that regarding 25 investigations they have advised. This is by the top world bodies. I will forward it to you. It's necessary for all of us to know that.
Thank you, doctor. Thank you. It was very elaborate. The only thing what I can add on to is, in our all gynec checkups, postnatal, if we missed in the antenatal, in the postnatal when we call them, just touch the breast. From our part of, at least that much of service we should do our women can. Thank you very much.
Thank you, ma'am.
Thank you, Dr. Pragnya.
One thing
Dr.
really surprises me, everybody is enamored by breasts. Is it or not? Everybody is enamored by breasts. They are exposing breasts like anything in all the get-togethers parties of Hollywood and Bollywood. So why are you not palpating? Take the opportunity to palpate those breasts.
Thank you. I think we will.
I
Memento,
request
Dr.
Dr. Priyamvada madam to hand over the memento to Dr. Pragnya. A quick update about cricket. As you know, today is World Cup, so it's between India versus Australia, and Australia has won. Australia has won the toss and decided to field.
Toss.
Won the toss. Okay, so the next session is about medico-legal aspects in obstetrics and gynecology by renowned Dr. Neeraj Nagpal, who is going to enlighten us about medico-legal aspect, which we need to know very badly today, as the patients have become very smart because of Google. So over to you, Dr. Sir, Dr. Neeraj sir.
Let me introduce Dr. Neeraj Nagpal sir. At the outset, I would like to
Ma'am, we are all hungry.
Okay.
I am very hungry and I can't afford to lose any further weight.
Thank you very much for agreeing, sir. Thank you. And I must thank Pamida also because who has put a word to him. He is a very busy person to give this much of timing. He was waiting from morning. Thank you, sir. So we'll start off the session.
The commonest introduction given in Chandigarh is Doctor hai, mota hai, shadishuda hai, rota hai. Yes.
He is not only a consultant physician and endoscopist, he has done a lot of work in the medico-legal issues of our obstetricians and gynecologists. So we will listen to him now.
Why is medico-legal issues a problem for obs and gynae? Because you are dealing with two lives. And in obs and gynae, I have found the maximum number of doctors doing law, doing LLB, doing LLM. I give talks in ENT conferences, in gastroenterology conferences, in neurosurgery conferences. Nowhere else is there so much awareness of medico-legal issues as there is among gynecologists. And rightly so, because more and more as time passes, we are finding the problems are increasing, not decreasing. Of all the laws under which the gynecologists fall foul of, I mean, I have listed just 12 over here, and I can recite maybe 60 odd more if I have to. But these are the common areas where cases have been filed against gynecologists. And I'm not including biomedical waste development rules. I'm not including things like municipal corporation where you are running a hospital from your premises, residential premises. So all these are also issues. But primarily for obstetricians and gynecologists, these are the areas which create a problem. Mostly the type of cases which come to me where doctors need help, somebody has been accused they have not done a triple marker test, not doing a level 2 ultrasound. And mind you, this level 1 and level 2 is in our minds. Courts don't recognize this. For the court, you have done an ultrasound. If you have missed, the excuse that this was not a level 2 ultrasound is not legally accepted. Either you are doing an ultrasound or you are not doing an ultrasound. In law, they do not accept this, that I was doing only a level 1 ultrasound. So, missing an anomaly is not a negligent act. So, this defense is not acceptable. Not doing thalassemia screening, not having pediatrician available during delivery, not getting premature child examined by ophthalmologist to rule out ROP, not referring to higher center, doing unnecessary cesarean, not doing cesarean in time, both sides. Not accompanying patient in ambulance and not informing police regarding underage pregnancy or MTP. I'll give you just some examples because I feel with real life examples, the message tends to go home better. In this particular case, this was a routine elective cesarean that the patient had gone into the OT for. 15-20 minutes later, The doctor came out and informed the relatives the patient has collapsed on induction or giving induction of anesthesia, and the patient is no more, and it is because of reaction to anesthesia. The relatives did not swallow that. They went ahead, made a police complaint, and post-mortem examination revealed there was a fracture of left sacroiliac joint and plenty of clots in muscles in front of the joint. Peritoneal cavity itself contained nearly 1.5 to 2 liters of blood. So, one side is claiming this was an anesthesia reaction, and the post-mortem says this is a major injury. Issues which were brought before the court were, did the patient suffer an injury due to a fall in OT? Why was post-mortem cesarean not done to save the baby? The baby also died in this particular case. And could injuries sustained during cardiac massage? This is what was the defense given by the doctors and the hospital, that during cardiac massage there was fractures of the 6th and 7th rib, and blood percolated through the cruciate ligament and went into the abdomen, and what blood you are seeing in the abdomen is because of the cardiac massage. This is the defense which was taken. Ultrasound was done in OT and the baby was declared to be dead. Problem was, ultrasound was done at around 12:05. Time of death at one place was written as 10:50 a.m. It was cut and corrected to 11:50 a.m. There was a lot of corrections which were made in the medical records in the time when patient was shifted to ICU, in the time when ultrasound was done. And ultrasonologist is writing 11:30 as the time when he has done the ultrasound, whereas the film which is being produced in court is showing 12:05. Besides that, they deleted all electronic records from the hospital data of the ultrasound machine also. So there was a lot of fabrication of evidence, there was a lot of tampering with the evidence. And following cardiac arrest of mother, the court had felt that cesarean should have been done within 4 or 5 minutes, and it was easily possible. Obstetrician had claimed that the fetus had died prior to death of the mother. Corrections and changes in timings, all this was there. But more importantly in this case, the obstetrician had gone out and told the relatives, ki, look, I haven't even started the cesarean. And this is a death. I have not done anything to the patient as yet. It is not my fault. This was the basic argument which was being taken up by the obstetrician. Now, the court took its own, and there was a criminal case which was filed, which is why the postmortem was done in the first place. The court felt that since any fall while the patient was in OT is not reflected in hospital records, is there an attempt at concealment of true facts? And the CFSL Hyderabad report clearly affirms that OT monitor readings, ICU monitor, digital copy of ultrasound have been deleted. Thus, opposite parties tried to destroy evidence and they indulged in unethical medical practices. The High Court did not quash the FIR. The matter went to Supreme Court. This was simply for quashing the FIR. The special leave petition filed in Supreme Court was dismissed. But interestingly, Karnataka Medical Council absolved the doctors in this case. They found no negligence in the conduct of the doctors. National Consumer Dispute Redressal Commission in 2023 came up with a compensation in this particular case, and 1.5 CR was awarded, 10 lakhs against the anesthetist, 1.5 CR to the hospital, and 2 lakh as litigation costs. In 2010, this case was filed. What do you think was the amount which was demanded? 24 CR. 24 CR was demanded. I know Hyderabad doctors are rich, so probably they don't need to understand the legal issues and they can afford to pay these kind of monies from their pocket if a situation arises. But the problem is, most of the doctors in our country, nearly all doctors in our country, cannot afford to pay compensations of more than 1 crore from their pocket and survive. I have had doctors who have come to my table, cried, 65-year-old gentleman crying, telling me I want to commit suicide. I have worked for 35 years in a semi-urban kind of a setup. I have served my country, and this is the reward I am getting. There are lessons to be learned in this. There were a number of experts which were produced by the hospital also in court. And one of the orthopedicians, he came and said that the type of injury of the pelvis could occur only in a high-speed crash. It could not occur by simply a fall from the operation theatre table. This was an opinion he gave in court. Court didn't accept it, different matter. Why I am bringing this point here is, you can also give evidence in favor of other colleagues if you feel what you are saying is correct. He thought the type of fracture which has occurred could only occur in a high-speed crash. It should not have occurred with this kind of a situation. What is the reality in this case, we all don't know. But the fact remains, to a lay person, it was a very, very shocking case. Though in this case, the obstetrician was not penalized by National Consumer Dispute Redressal Commission. But my request to you is, in case of a catastrophe happening in the operation theatre, do not try to dissociate yourself from your anesthetic team or the surgeons who are assisting you by saying, look, I have not done the cesarean as yet. Any problem which has occurred is not because of my doing, because I expect this case to go to Supreme Court and I expect the obstetrician also to be penalized heavily. Just because National Consumer Dispute Redressal Commission has not penalized does not mean this was the right approach to take. If death had occurred, the baby could have been delivered far earlier. The baby could have been saved. So just trying to get rid of any blame from the relatives as the priority is not probably what my recommendation would be from this stage. And remember, if you have a death where you do not know the cause of death, all you have to do is please inform the police, let them come, take charge, ask them to get the postmortem done. Relatives don't want the postmortem done. This is between the relatives and the police. It has nothing to do with you. Your job is done once you have informed the police. Another case, this was Chandigarh, Deep Nursing Home. Friends of mine, they had a massive PPH. The doctor, lady doctor, she had delivered my son also, and she had delivered 7 members of this family. And the grandfather was Advocate General Punjab. The son, the person whose child was being delivered was also an advocate. So when the child was delivered, the child did not cry, and when the patient asked, "Kya hua?" So there was a confusion. Whatever the reasons may be, she went into shock and started having PPH. And the doctors were not able to control it. Packing was done, whatever they could think of. Surgeon, my surgeon from my nursing home also went to help, and finally they decided to refer the patient to PGI for embolization. The husband, who's the anesthetist, he's a senior anesthetist, he went to PGI directly and made arrangements so that the patient is directly received in septic labor room, because PGI is a huge institution, it's a very good institution, but getting work there is a bigger achievement. because you need to be in the right place at the right time. To reach that in an emergency in PGI is next to impossible. So he went ahead, he made all the arrangements, patient was received in septic labor room but was declared brought dead. The penalty which was awarded here was that the anesthetist should have accompanied the patient in an ambulance, in the ambulance. He should not have abandoned the patient, because if something was happening to the patient in the ambulance, he was an expert and he could have helped her. You have to realize you cannot handle everything. There are hospitals which are tertiary care hospitals. I know of many specialized procedures where even institutions like PGI do not have the wherewithal. They need to refer to Shankar Netralaya, Chennai, or so many Tata Memorial Hospital, Mumbai. So if institutions of this size cannot provide the entire gamut of services which may be required, a small nursing home definitely cannot be expected to provide everything. But you need to know what you can handle, what you cannot handle. And in case of a problem, do not delay. That is the crux. If you have to refer, there is a particular way you have to refer. Be extra vigilant, of course, when you are dealing with advocates, and I say even doctors. Even doctors are not very medico-legally good patients. Oh no, I can give you examples. And know when to appeal, when not to appeal. State Commission gave them, there was a 20 lakh insurance they had. State Commission awarded 20 lakhs. So they came to me, they asked me, मैंने कहा छोड़ो इस चीज़ को, let's pay and get away from this thing, because उन्होंने छोड़ना नहीं है. There's a family of advocates, they are going to pursue the matter. He didn't, the ma'am didn't agree. She said, no, my sister is a senior advocate in Supreme Court, we'll fight the matter in Supreme Court. Now since that time, it is more than 12 or 13 years they are running around in Supreme Court. My fear is the actual compensation may get enhanced and not actually benefit them. So we need to know when to go in appeal and when not to go in appeal also. I can give you multiple examples where a crisis has happened for obstetricians, but again I think there is a paucity of time. And so let's keep only to the lesson that documentation, if you have done properly, you can manage to save yourself. Whether you have given oxygen, not given oxygen, I'm not concerned. Please document you have given oxygen. Whether you did cardiac massage, did not do cardiac massage, don't tell me. But write down over there, he gave cardiac massage from X time to Y time. What time arrest occurred? When there is a crisis, do we have time to think what time the crisis occurred? We are focused on there was a Yashoda hospital case from Hyderabad. The court is asking minute to minute you should be writing these things, these notes. Very interesting. I give one cardiac massage, go down, write 12:35, cardiac massage given, come back, given another cardiac massage, go back. Nonsense. But the fact remains, consumer courts are entirely about documents. Even high courts, Supreme Courts, matters are decided on the documents you produce. In this particular case, the patient, the moment she was induced, she went into bronchospasm. And once she went into bronchospasm, they gave Betnesol, Lasix, whatever else they could. And even AIMS people, they were asked to give an opinion. There's a criticism of that. But the fact remains that there are certain messages in this particular case that a medical board's opinion given even by an institution like All India Institute of Medical Sciences can be challenged. It is not the end. Then the issue of to revive or not to revive. ये क्या चक्कर है यार? Here the obstetrician assisted the anesthetist in reviving the patient. And again, everything was documented well. And once, look at what the anesthetist is saying. He says, because most of the smaller nursing homes, there is no pre-anesthetic checkup. You ring up the anesthetist, ki doctor sahab case karna hai. And he comes with his bag and he goes directly into the OT and he examines what he examines over there and decides to go, or rarely he will refuse to do a case. That will be extremely, extremely rare. There's no concept of PAC in small and medium healthcare establishments. Here also, there was no PAC. But the reply they gave and the documents they created, he mentions what all he carried with him when he went. He mentions what all did he do in the examination. He mentions what all things he laid down on the table before inducing anesthesia. Things which were probably not, if I ask anybody, any resident to write notes, they would never think of writing all this. But he went ahead and he has given 300, 400 ml of dextrose before he gives spinal anesthesia. He's given all explanations why spinal was used, why GA was not used. They have mentioned that he was checking the level of spinal by pinpricks. What was the level of spinal that he was talking to the patient. 26 minutes into the surgery, when the uterus was being sutured, the patient collapsed. So, based on documents was basically why they got away in this particular case, though, and when they had referred the patient to other hospitals, in the referral notes also he had mentioned all these things. So the court says that yes, you can claim that this medical records are not authentic and they have been prepared later, but when he has referred to the hospital, at that time also their hospital records also reflect the same things. So obviously whatever story the doctors are telling is correct. My point again is medical records, medical records, medical records. If your record keeping is good, chances are you will get away from it, even though they are advocates of the hospital. They took this plea that we had taken consent for anesthesia and any complication occurring after consent should not be admitted. The court didn't agree. You do not take a consent and do a procedure, it is negligence per se. But just because you have taken consent and a problem occurs, you cannot say we had taken consent so they can't come to court now. Understand the point? Complainant, they said also, this was the father-in-law, I think, who was going and to the court, and they said he has no locus standi. Court didn't agree to this also. So, point is, when we are fighting our case, advocates will give us a lot of opinions. I'm sure somebody must have given in the first case also the opinion that you claim that this was an anesthetic death. But obviously, these are things which can come up. This, most of you will be knowing, this was a case from Apollo Hospital, Delhi. And I think 1 crore 10 lakhs was awarded. Again, the issue was the doctors advised cesarean, the patient refused cesarean. Finally, they went ahead and did a cesarean and birth asphyxia was there and encephalopathy had happened. This was one of the first cases where more than 1 crore, after of course the Nizam Institute Hyderabad case of Prashant Dhanaka, where 1 crore plus was awarded. Important message in this particular case is, don't say one thing when your nurse's chart is speaking another thing. You are doing a cesarean at 3 a.m. after 17 hours of augmentation. You have started your Pitocin, and 17 hours later you are doing it for what is the term they have used? Failure to progress. Obviously, failure to progress, one, it has to be more than 24 hours, two, at 3 a.m. at night, and especially when CTG tracings are clearly showing fetal distress. The nurse's chart is clearly showing fetal distress. Nurses have mentioned, we have informed the doctor. So, have corroborative medical records. They should be complementary to each other and they should be contemporaneous. They should be as events unfold. This is something you have to realize because you don't know which of your colleagues is actually helping the patient party put up arguments in court. So number of things which you don't expect a court to know, in this particular case, the court is asking why the scalp pH was not done. I'm sure even a pathologist sitting there would think twice before coming up with some argument like this. Obviously, there were other people who were assisting. Another very important thing said in this particular judgment was corporate hospitals have to be more careful because they claim to be doing a job far superior than they are charging in crores. All this is mentioned in the judgment. So my point is, there is a complacency when we are working in corporate hospitals. My wife is working in Max Hospital, Mohali, and I find that she is relaxed here as a gynecologist compared to what she used to be in our small nursing home where it was always a stress. But this could also lead to complacency and that should not be encouraged. Lessons, refusal of consent was not signed. Patient, you have asked the patient for us to get a cesarean done. Patient says cesarean nahi karana, fine, mat karao. Likho yahan pe, sign karo. कि आपको बताया गया था, आपने नहीं करवाया. They refuse to sign. You write down कि they were asked to sign. They have refused to sign. Get another doctor or a nurse to countersign what you are signing. That is more than enough. Then, tampering with medical records. This I can go on and on. There is a 1-hour lecture on this. Rahul Mahajan's case was there, and Pramod Mahajan's secretary. They were brought to Apollo Hospital, Delhi. Both of them unconscious after a party with heroin and alcohol and God knows what all. And Apollo Hospital doctors were under a lot of pressure not to prepare a medico-legal case. So they did not. But 3 hours, 4 hours down the line, what happened was the other guy died. Now they were forced to enter everything. By that time, there were 10, 15 other admissions. So they could not leave any column blank. So the doctors were penalized separately for tampering with evidence, and Rahul Mahajan was penalized separately under NDPS Act. Samira Kohli, Prabha Banchanda, I refuse to talk about this case because I think all of you should be already knowing this by heart. This is not something which should be taught by people who are medical legal experts or law experts. This should be taught to you by your professors in your medical colleges. This is the basis of consent in India even today. It is going to change, but to date, this is the basis of consent. Important message for you is, you have taken a case under GA for X procedure, and you find you need to do procedure Y. In the interest of patient will not have to undergo 2 anesthesias, patient will not have to bear additional cost, patient will not have to bear a risk of another anesthesia. No criteria. You cannot proceed to do something for which you have not taken consent for. You had taken a consent for diagnostic laparoscopy. You should have done diagnostic laparoscopy. Let the patient come out of anesthesia. Give a consent later for doing hysterectomy and bilateral salpingo-oophorectomy, and then gone ahead and done it. I mean, when we were taught, we didn't have ultrasounds in those days, and gallbladder surgery, the standard was appendix to saath mein nikali, though it was like आलू के साथ धनिया ले रहे हो. So it was never asked. But this is as law stands today. So you need to be very, very clear on this. And please remember, you do not require to take an informed consent as by law today. What you require is something called real and valid consent. And real and valid consent is what, let us say, if I have taken consent and I have told 5 complications can happen, and Dr. Lakshmi has taken consent and she also mentions the same 5 complications, then the consent taken by me is real and valid. But the informed consent is, if I was to be operated and I was told 5 complications by her, and in case I was told the 6th complication, I would have refused surgery. Then under those circumstances, it becomes an informed consent, which means you have to tell everything. Patient can die, his wife can divorce him, patient can, you name it, everything has to be told. Informed consent is the concept you have in US. Real and valid we had in UK. But UK also, after Montgomery's case, is now shifting towards the concept of informed consent. And even in India, there are judgments which are favoring that, but they are holding on because Supreme Court has given this verdict for real and valid. But I expect this to change very, very soon. Can your husband or your son or your daughter who's not an anesthetist give anesthesia? Problem. We had a case where this was a mission hospital in the Far East. And the gentleman had been giving anesthesia for more than 20 years. He's a pediatrician. But one case, the lady died. And the issue was, he could not have given, so hence penalized. Similarly, number of cases on this issue. But my problem arises from this cross-speciality turf war. I'm going to take 2 minutes on this. Pain management kiska kaam hai? Anesthetist ka, neurologist ka. Intensivist kaun hai? Anesthetist ya chest specialist? Ovarian cyst kaun operate karega? Surgeon ya gynecologist? Radiotherapy, medical oncology, major turf war. Orofacial surgeries, ENT people, maxillofacial dental surgeons, plastic surgeons, everybody wants it. This is my job. How did you do it? And we are extending this turf war. These are the 4 types of super specializations you have started in gynae. I am strongly against this concept. Why do you need an MCH in cosmetic gynecology of all the things in the world? A gynecologist could have easily done it. You are starting these things. Tomorrow you will have DM obstetrics cardiology, DM obstetric hepatology, DM obstetric intensive care. You may also have DM obstetrics hypertensiology and maybe a DM MCH infertility. I don't think infertility is still there. I was checking the NMC website. I could not find it, but if it is there, I'll stand corrected. The point is, what is the problem with this? People who have been specialists in infertility for 20 years in the past, the moment you have 200, 300, 500 DM or MCH infertility, immediately a separate society is formed. Immediately the cry starts, or somewhere in court it will be said, Ki ji, how did she treat infertility? She is not qualified in infertility. When DM hepatology started, this is in our lifetime, we have seen all this. It was DM gastroenterology people who used to teach. Who taught the DM gastroenterology? It was the MD medicine who used to teach. But we are stretching it so thin. And simultaneously, if you see, the courts are allowing BAMS to do everything. The courts are allowing DIs to conduct deliveries. And you are wanting MCH in reproductive medicine. What is MD Gynae for? if it is not reproductive medicine? Look at this case. The appellant court has held that midwife is authorized to conduct such delivery. And we are talking of MCH and normal delivery, okay? All gynecologists who have treated high-risk obstetric patients, gestational diabetes so far for decades will suddenly become quacks. DM obstetric cardiology doing cosmetic surgery or gynecology will be labeled negligent per se. I have a case where MCH urology, he did MS surgery before he did MCH urology. Did he not? He got a case of cholecystectomy. He did a cholecystectomy, injured the bowel. The court says, no, you are MCH urology. You are allowed to operate only urology cases. You cannot operate just any case you want. Wisdom, our court's wisdom is phenomenal. I mean, we can't challenge that. And my biggest problem is, in a place like PGI, let us say in pediatrics, there are 8 or 9 subspecialties, gastro, neuro, endocrine, so on and so forth. Now, a DM, a person who's non-DM, who's MD pediatrics, joins the department as senior resident. And in the department, he is learning what? He is learning traffic management. आप न्यूरोलॉजी के हो, न्यूरोलॉजी में जाओ. आप नेफ्रोलॉजी के हो, नेफ्रोलॉजी में जाओ. आप गैस्ट्रोएंटरोलॉजी के हो, गैस्ट्रोएंटरोलॉजी में जाओ. That person, one, our training programs have become such, we are not making competent doctors even after post-graduations. We expect them to learn the craft after post-graduation during senior residency. And in senior residency, you will not be seeing nephrology, gastroenterology, neurology, endocrinology. What are you seeing? Tomorrow you will have a DM infectious diseases. I mean, you are senior people. You have been teaching all your lives. You are the ones who have to raise this issue. We are stretching things threadbare and this will break. India needs more doctors who know more and more, not more doctors who know less and less. If I can give this one message and somebody can spread it for me in your fora, I mean, my job is done. Can a surgeon give anesthesia? No. I mean, this is what is happening. Everybody wants. I sometimes get so irritated. I tell them, okay, fine, you should have taken out your liver, parceled it to me, I would have corrected the liver, sent it back to you, you could have fitted it back yourself. Because you are coming from a cardiologist, a neurologist, a psychiatrist, and you don't want me to see any of those prescriptions. You don't want me to see any of those records. You are, हम तो जी आपके पास गैस के लिए आए थे. Weird. And this cross speciality is going to create a problem. Surgeon operating on an ovarian cyst. IUD is a major problem medico-legally. I can give you umpteen examples. Death of a baby is a thing courts will always penalize you for. Autopsy. This is Jipmer Pondicherry. Child died. Court case has been filed. We asked for autopsy. Jipmer refused for autopsy. Jipmer says, we asked them to get postmortem done. They did not get postmortem done. The problem was Jipmer should have informed the police. We do not know the cause of death. You please come, take charge of the body, get a postmortem done. They did not do that. That is where the problem arose. And an unborn fetus is treated like a child and compensation will be awarded like compensation is awarded to a child. So keep that in mind. Another problem is government sector. How many of you are working in government sector? Ma'am, what is your indemnity insurance? 20 lakhs. What is yours? Very elevated thinking, I must say. Because in PGI, when I asked this question, out of 200, maybe 10 will raise their hands कि we have indemnity insurance. Because somehow this impression is there कि government hospital doctors do not require indemnity insurance. They do require, they do require, they do require. And even your resident doctors, you have to make sure whether they become members of FOGSI or not. They should have their indemnity insurance. That should be the first priority. हमारी problem ये है, tomorrow I want to stand for election for FOGSI presidentship. So I want maximum number of people in my hospital to become members of FOGSI so that they will vote for me. It is more important that they need to be guided correctly, that you require indemnity insurance also. People just, my daughter, my son, both had indemnity insurance during their internship. Make sure of that. Do not ignore it. And of course, those government doctors who feel they can pay 2.28 crores are of course not needing any indemnity insurance, so I will not elaborate on that. ECHS, ESI patients, also your consumers. R&R, Army Hospital. People think Army Hospital doctors do not need indemnity insurance. This is the case. Ask them to go through this. They should also take indemnity insurance. The problems for gynecologists, there is no limit on what compensation can be asked for. Consumer Protection Act has made asking for compensation in crores acceptable. Consumer Protection Act has made easier to claim compensation, hence increasing number of claims. And
Sir, sorry sir, the time up हो गया.
Even if you die, the case against you does not end. So your family will have to carry on fighting the case, and these are all cases more than 1 CR or so, which examples I have given. Mind you, complaint can be filed in at least 4 or 5 of these places simultaneously. Besides Consumer Court, it will also go to State Medical Commission, it will also go to the police, it will also go to Human Rights Commission, it will go under Article 226 to High Court. You will be pulled everywhere. If your hospital is NABH, they'll make a complaint to NABH. You will answer there also. And even CBI inquiry was ordered against doctors in PGI because the patient who died was a judge's mother. What is the role of CBI in this? How long to keep medical records? There's a discovery rule. Delivery cases, I would strongly recommend keep them lifelong. There is a Nagpal's rule which I had formulated many, many decades ago. But in short, elective things, 5 years later, give a small advertisement in an insignificant newspaper that you are going to destroy records which are more than 5 years old 30 days down the line. If somebody wants those records, they can come and collect it. Newspaper should be insignificant. Keep this carefully, this advertisement. Do not destroy your records. Once 20 years later a case comes against you, that time go to your advocate with the advertisement you had given and your medical records. If he wants the advertisement, he will use the advertisement. If he wants the medical records, he will use the medical records. Most of the times problem occurs when financial reasons at the time of billing. Death हो गई, सब कुछ हो गया, वो अपने में है चीज, मगर जो billing है, that is, and these are some things I'm very strongly in favor of, that resident doctors need to be taken under the wing and taught, because the steps you learn at this stage, you practice lifelong. You also need to know what are the good judgments in cases of medical negligence, so you can use the arguments properly in case of your own cases. What this has done is, we have increased defensive medicine, selection bias in clinical practice. Most senior gynecologists have stopped doing obstetrics. How does it help the society? It does not. These are all legal principles which say one case can be filed against one person only once and only in one court. Doctors are not citizens. You can drag them anywhere. And this thing, I take a knife and kill a person, whether the person is rich or poor, I am going to be given the same punishment. But under Consumer Protection Act, I kill a person who's belonging to Ambani Khandan, or I kill a person who's a beggar, the same amount of negligence, alleged negligence, but the penalty awarded will be drastically different. This is something I cannot understand. And there's selective accountability. Doctors should be accountable. Judges, lawyers, of course, they can't be held accountable. If you want to complain against the Press Council of India first asks you to give an affidavit that you have not filed this complaint in any other court of law. And with Dr. Fahmida Bano, Medical Legal Action Group, which I represent, and which today has around 16 writ petitions and PILs on common cause issues of doctors, like doctors' right to protest, like generic medicine issue, like integrated medicine PIL has been filed in Delhi High Court. So issues on behalf of doctors as a community, we are fighting in courts, in High Court, Supreme Court. We lost when we went ahead for a case against inclusion of doctors in Consumer Protection Act 2019. But we are not giving up, we are fighting, and we would request you to help us, become our members, contribute financially. If you cannot do anything else, thank you so very much. My apologies.
Thank you, Dr. Nagpal. It was an excellent and extensive eye-opener. But we know that day to day, new problems are coming because of the Google knowledge or whatever it is. For everything, I think we are counseling. I can give you an example. During the surgery also, we come out and explain and then go back and do surgery. Even then, the questions they are asking nowadays is very difficult to take in. So there is no end. Actually, I think each one of us must be having kind of a clinical issues or clinical problems where we face it in the day-to-day practice. It's a never-ending issue, I feel. Thank you very much. There will be some solutions for some and there are no solutions.
Not next 2 decades, ma'am. After 2 decades, yes, maybe. But right now, I don't see a solution for medical professionals. It is the business of medicine which is going to boom. But the medical professionals are going to have a very hard time for the next 2 decades, till the time these medical seats become like dental seats or like engineering seats where they have no value. I mean, I can hire a dentist for 5,000 rupees a month. And this is the situation, the way they are increasing MBBS seats and the way they are increasing gynae seats, the way they are, I mean, it is ridiculous. You are giving somebody a certificate which says he is a master of surgery. Have some shame. Can the person operate? If he cannot operate, how have you given a person a certificate of master of surgery? Do all MS gynae people know vaginal hysterectomy or laparoscopic hysterectomy? Why? Our generation, I mean, I was in CMC Ludhiana, Dr. F.C. Eggleston was there as head of surgery. Their training program, you were given hands-on work from the first day you were in the department. Your teaching was separate, you had to do all the history writing, push the trolley, all that you had to do, but you were also simultaneously given work. This is something I'm not seeing nowadays.
Thank you.
I think the take-home message will be documentation, be it in the middle of the night or in your busy OP. Still, documentation has to be done right.
Thank you, sir. Can I request Dr. Lakshmi Ratnam Madam to give the memento to Dr. Neeraj Nagpal, sir? Thank you, ma'am, for chairing the session. We'll break for the lunch, ma'am. Quick lunch, 15 minutes.
I would like you all to visit our stalls, our sponsor stall, that is STEMside, Zuventus, Vaso Organics, MSD, Cipla, Torrent, Pfizer, and a Sari stall.
Thank you for staying patiently even till 3 o'clock in the afternoon without having lunch. Kindly join us all for lunch.
Pratibha ma'am, can I request you to come on the stage? Lakshmida Priyamada madam will be giving the memento to you, ma'am. Thank you, ma'am, for chairing the session.
Ma'am. Ma'am, మీకోసం.
Good afternoon, everyone. Now for the panel discussion, Mysteries of Uterus. The moderator is Dr. Mamta ma'am. Mamta ma'am needs no introduction, but still I am giving a quick introduction. Dr. Mamta Deen Dayal is an icon in infertility treatment in India, a globally renowned gynecologist and fertility super specialist with a career spanning more than 40 years. She is the founder and medical director of Mamta Fertility Hospital and the promoter of Shinoy Hospitals. She has received several gold medals during her MBBS, MD, and DGO. She has received the Sarojini Pulla Reddy Gold Medal in Anatomy, University of Gold Medal in Pathology, P. Shiva Reddy Gold Medal in Ophthalmology, and University Gold Medal in her final year in MBBS in Obstetrics and Gynecology. She has been honored with several awards. She has won the Best Infertility Specialist Award at HiBiz Healthcare Awards, entering the Hall of Fame in Reproductive Medicine, Times Health Excellence Telangana in 2021. Her humanitarian activities knows no bounds. She has conducted various free health camps and awareness programs on fertility. What's more, her Positive Fertility Foundation helps treat and underprivileged women suffering from infertility issues. Thank you, ma'am. May I call upon all the panel members? Dr. Jayanti Reddy, ma'am is a consultant gynecologist and director, JJ Hospital, Hyderabad. She's a visiting faculty at SVS Medical College, former assistant professor at Obstetric Gynecology, Government. She was awarded the Young Foxy of South India or Asia in 2001 and IMA Excellence Award in 2019. Next, Dr. Vandana Hegde, ma'am. Ma'am is a clinical director and chief IVF consultant, Hegde Fertility Unit of Hegde Hospital. She's done MS OBG from JSS Medical College, postdoctoral fellowship in reproductive, BACC GHS, diploma in reproductive from Kiel, Germany. She has many awards to her credit. Next, Dr. Noori Madhavi, ma'am. She is consultant radiologist director, Madhavi Scan Center. Her areas of interest, woman imaging, fetal MRI, ultrasound MRI. And she has gold medals and cash prizes in MBBS, MD, and university first rank in MD. Thank you, panel members. Over to you, ma'am.
There's one more.
Dr. Prasad Kulat, our, what do I say, handsome young man from Ankura, Pune, is here to join Dr. Mamta in her panel.
Can I have the people? Yes. All right. Can I have the lights off if you don't mind? All right. I thank Ankura Hospital and specifically Dr. Lakshmi for having invited me here, Dr. Nilofer and Dr. Dr. Sapna, and there's another doctor by name Raghu Tejaswi, who are very kind in giving me whatever I wanted in terms of the small things that I needed. I have exactly 45 minutes. I'll try to keep within time. So I request my panelists to give very brief answers. And so today the topic that Lakshmi gave me was to discuss with my panelists the mysteries of the uterus, clinical challenges and ultrasound solutions. And I have Dr. Vandana Hegde, one of the pretty gynecologists from the infertility sector, and I feel very happy seeing you. She used to be a showstopper as far as I'm concerned. Jayanti Reddy, a very dear friend of mine. Dr. Madhavi Noori, whose reports I respect enormously. And I also have Dr. Prasad. I'm sorry, I don't know very much about you, except that you're a handsome young man. So with this, I start the panel discussion on the interactive session on AV malformations of the uterus. This is a difficult topic, but there is a fun way to learn, it's a fun way to learn gynecology, correlating clinics with imaging and improving the diagnostic efficiency by the latest advancements in the management strategies, learning from collective experience of my dear panelists.
In this session, it's going to be case studies and brainstorming, and this panel is going to be a practical one, essentially dealing with something that will help us in our clinical practice and how we use imagology to help us plan our individualized management. So we are going to talk about arteriovenous malformations, the clinical presentations, and the management strategies. The methodology of this presentation would be that there is a clinical case, how you approach it, how you use ultrasound findings to correlate with the clinical case, plan individualized management strategies, and then some take-home points. My interest in this subject, a very different subject to take up for a panel discussion, started in the year 2012, when for the very first time I saw abnormal vasculature of the myometrium in a patient who had come for post-abortal bleeding, and it caught my attention. I went into the referral books and I said, this is something very unusual. Today, of course, it's something that I see every day, but at that time it looked very unusual, and when I looked at the data in 2008, worldwide only 1,094 cases were reported. The management possibilities at that time were only hysterectomy, internal iliac ligation, embolization. Spontaneous resolution was never talked about. In 2023, in this year, from January till today, I have already seen 56 cases, and many of them were with cesarean scar pregnancies. So here is a patient who came to me in 2019 with an empty uterus. You could see very clearly there was a cesarean scar pregnancy. The myometrial thickness beyond was only 1 millimeter, and there were huge vessels. You know about this case. Okay, Dr. Priyamvada managed this case, all right? So it was a cesarean scar pregnancy, and we had to give her 16 doses of methotrexate, and then she resolved spontaneously. And I called her the other day and I said, please come, I want to see your uterus once more. And that's how her uterus looked. This was medical management, of course, but spontaneous resolution of that cesarean scar pregnancy. Today we know the incidence is high, diagnosis is easy, conservative management in acquired cases is possible, spontaneous resolution is possible, subsequent pregnancies can also be normal. But this is an extremely potentially dangerous, life-threatening complication. We should be aware of its presence. And that is why I took this up as one of the mysteries of the uterus I wanted to understand from my panelists. Once upon a time, ultrasound was only grayscale, and then came in 2000 the touch of a button, the color Doppler button, and once you pressed it, there came so much of color, and then the diagnosis of AVM started. So today we know that AVM can be diagnosed not only by grayscale, but also only by color Doppler. So there are many questions that need to be answered, and I'm going to have my esteemed panelists answering most of them. So can we start? Any one of you can answer, and we'll try to take it. We've completed 4 minutes, so we'll try to take it fast. What is an AVM? What is arteriovenous malformation? Any one of you.
There is an abnormal connection between the artery and the veins, which occur within the myometrium, and this is also known as the arteriovenous malformation, or an enhanced vascularity which is there in the myometrium. So this is the one which we see after any abortion or cesarean section.
Fair enough. Anybody else has a difference? When we have a panel, if you have everybody saying the same thing, you don't need the panel. Yeah, so if you all can differ, it will be much better.
Yeah, just physiologically, usually artery, capillaries, vein. So that's what happens here. Something, the connection directly happens between the artery and the vein. And it can occur anywhere in the body, where we gynecologists, we are only the uterine AVM is what we are probably concerned with.
So talking about this then, what are the synonyms?
It could be a fistula. So usually
No,
it's
what are the
AVM.
synonyms that you use for this? Already she mentioned.
It was also called as a AV fistula, or see, the only difference we need to find out is probably it's an enhanced myometrial vascularity or it is an AVM.
So what you are saying is the other synonym is enhanced myometrial
Myometrial vascularity,
vascularity.
yeah.
You have anything else to say?
From a diagnostic perspective, I would like to emphasize arteriovenous malformation is communication of artery to vein without intervening capillary bed. That is most important. So the most specific diagnosis of AVM is demonstration of early draining vein during arterial phase on an angiography. Rest all are enhanced myometrial vascularity.
Thank you for that. Okay, so that's a radiological answer. All right, so AVM in reality, according to the textbooks, is a cluster of abnormal, this I'm talking about is a cluster of abnormal connections in the intramural arterial branches of the uterine arteries and the myometrial venous plexus at the region of the endomyometrial junctional zone. This happens in women of the reproductive age group and usually follows a pregnancy or because of failed resolution of the uteroplacental bed and its vessels. Okay? So what then are the types of AVM that you see? Sorry for being like a teacher, but I just need to do everything in 45 minutes and I need everybody here to benefit because this is something nobody talks about, but it is such a dangerous complication. The first time a case came to me from a very dear friend of mine, she said, this patient required I just did a curettage for pregnancy and she nearly bled to death. I had to give her 6 bottles of blood and send her to you. Please tell me what it is. And that was an AVM with this is what we are going to talk about. And that is why I took up this and I said, no, let's discuss this. Because it is rarely discussed but must be known. Okay, so would you tell me?
The very simple types that we can think of is the congenital and an acquired type.
Okay. So in the acquired, would you like to further divide it?
Yes. Acquired are seen in the setting of trauma, infections or pre-existing uterine pathologies in the form of trophoblastic disease, infections. So this is the most common clinical scenarios by which the referral of AVM comes statistically in the setting of post-abortal status or post-uterine surgery.
Is there something called...
congenital AVM by definition is a morphometric abnormality in the angiogenesis of the uterine vasculature. So there will be multiple connections between arteries and veins. They will be profuse. There will be many collaterals. They are very rare. And ultimately, amongst all this confusion, we have to look at the background clinical history and against which the patient is presented with AVM.
Wonderful.
AVMs are very rare.
What about acquired AVMs? Dr. Prasad, would anybody want to answer? Anybody?
Acquired AVMs are usually post any procedures or any...
what she had mentioned.
Yeah.
Anything else? Okay. Can they be differentiated?
The congenital ones, as I told you, they'll have profuse. When you do an angio, multiple bilateral, multiple feeders.
See, we don't do angio for all our patients.
Yeah.
So we are normal gynecologists. Could you differentiate on an ultrasound and a color Doppler the difference between the two? See,
based on the extension. Yeah. Uterus, if you take from an organ perspective and hemisphere perspective, it will be bilateral, diffuse, extending into pelvic side walls and side musculature. And background clinical history. So that is usually congenital AVMs. Acquired AVMs, you usually have either it is myometrial without any cavity mass. That follows the definition of an acquired AVM. There will be plexus of vessels without any cavity mass.
Okay, so putting whatever she said quickly in a way that all of us can understand. AV malformation that is congenital and enhanced myometrial vascularity that is acquired used to be synonymous, but we know they are two different clinical entities. This is the congenital. It is extremely rare. Next is physiological. All right. So this is something I just wanted you all to be aware of. Physiological, and of course the most common and what we are really going to deal with is the products of conception and following miscarriage and enhanced myometrial vascularity. And we know that this happens because of some form of trauma to the uterine cavity. We are mainly now concentrating on products of conception and enhanced myometrial vascularity because that is important to us. We are not concerned about the rarest of rare. For the rarest of rare, we have the radiologist to help us. But for the common, we are regular gynecologists and we want to know what we can do. So this is usually because of subinvolution of the vessels within the endomyometrial junctional zone. What exactly is this physiological? Now, if you take a patient who has just delivered, 3 days after delivery, look at the placental site, 52% of these patients are going to have AVM, I mean enhanced myometrial vascularity. But the same patient you take after 6 weeks, you will see only 4% of them at the placental site still have the enhanced myometrial vascularity. This is important for us. The next thing is true AVM is extremely rare. Like Madhavi very beautifully described, it is a result of abnormal endothelial proliferation, delayed vascular remodeling, and during fetal angiogenesis. It is rare. We should know about it. We should be aware about it. And usually it is very difficult to handle. It never has any spontaneous resolution, unlike the acquired where there is spontaneous resolution. So, of course, the differentiation between the congenital and the acquired, already Madhavi has beautifully talked about it. The only difference is congenital will never regress, whereas acquired always undergoes either spontaneous or surgical resolution. The next question to the panels. Which are the type of cases that you see AVM that all our colleagues here in the audience should know? You all have already very clearly described it, so I'll quickly go through what you have said, Madhavi. There's only one point that you never mentioned here, and that is second trimester abortions, particularly after the 16th week. These are the patients who are very prone to develop AVM, I mean enhanced myometrial vascularity. This is something we should be aware of. And that is why in these patients it's always better to call them after 6 weeks or much before that if you wish, and always check for any problem, particularly if they are symptomatic. Am I right? Do you all agree with me?
I
Yes.
want to add one point, madam.
Yeah.
Even when there is a history of manual removal of placenta,
yes,
also we should call them back. And
yes. So these are some of the precautions that we take. But more important than that is these are the days of scar pregnancy, of cesareans being really high. So I think any patient, this is just a little statement that I make, any patient having a previous C-section, when she gets pregnant, always ask her to come early in pregnancy to get a scan done. The first case I saw with the cesarean scar pregnancy in 2019 had come for a routine evaluation to find out if her baby is doing well, and all we saw was a scar pregnancy there. So this is just a little point that we should know, and the others were already outlined very much in the beginning. So this is another slide that I wanted to put for all of us. It was something I learned when I was making this presentation. At term, the maternal blood flow to the placenta is about 600 to 700 ml per minute. Once the placenta is separated, there is prompt resolution of the vascular channels, and this is nature. When postpartum, that's exactly what you see. When the placenta is separated, there is resolution in 50%, in the remaining there is some amount of enhanced vascularity which spontaneously resolves. But when there is products of conception and the products are completely removed, you can see the diagram at the bottom there, when the products are completely removed, there is resolution that happens completely. But on the other hand, if there are products still remaining in the uterine cavity, these vessels persist there and produce enhanced myometrial vascularity. Are you all with me? Because when we understand this, then management becomes extremely easy. That is the pathological basis according to this paper. Enhanced myometrial vascularity is a natural manifestation of the pathophysiology of abortion. So this is exactly what you see. If there are products in the uterus, there is failed obliteration in the vessels, particularly in the presence of RPOC, and so that is why there is the presence of the bleeding happens and there is myometrial vascularity that persists, particularly seen in caesarean scar pregnancies. We must remember that it is possibly the erosive property of the syncytial trophoblastic tissue and the chorionic villi during placentogenesis that induces changes in the decidua and abnormal connections in the vascular structures. We must remember that the presence of products of conception is only 6.3%, but 77% of them will have enhanced myometrial vascularity. This is important for us. Again to the panelists. What are the points of concern? Why are we worried about this? Why should we have a panel discussion on this? Why are we worried about, clinicians?
Because see, the only thing is the bleeding that can happen. So that is our only concern, because if they bleed, it is going to be catastrophic and it is life-threatening. So that is a major concern for us. And at the end of the day, if a patient anticipates future fertility, we have to ensure her uterus is taken care of with respect to the complete evacuation has to be done. And risk of infection is always there. So concerning all three, RPOC with the feeder has to be clinically managed definitely. And the only thing is that when you showed the picture of RPOC, so the feeder vessel sometimes, we do see a single feeder vessel sometimes. So that is something that we need to do our Doppler to be sure, is it a single feeder vessel or it is multiple, like how the branching happens, and that differentiation we should find. So
how does it help you? How does branching or single
Because the AVM,
when a patient has to bleed, the patient bleeds, whether it's a single vessel or a multiple vessel. To call it AVM, to call it an enhanced myometrial vascularity, you should have multiple vessels.
Yes, that is why. Because a single feeder vessel, we need not worry so much, because you will see sometimes some vascularity, so that's not something that we should worry about. But yes, AVM is something that we have to have this difference for our clinical management.
Anything else?
Actually, to avoid this confusion, we did a study to understand the differentiation between AVM and RPOC of around 20 cases who presented in the post-abortal, post-delivery status presenting with menorrhagia or menometrorrhagia. So the most common takeaway points which we noticed were the RPOC is categorized into 3 based on color Doppler spectrum. Grade 0, 1, 2, 3. 0 mean, and this definition is putting up a color box against endomyometrial junction, that is including a part of myometrium and endometrium. Grayscale imaging will delineate the zonal anatomy of the uterus, and the most important thing, if you have to comment any time even without color Doppler, is presence of a mass within the cavity. First step, presence of mass within the cavity, straightforward, it is either RPOC, most commonly RPOC. Then you turn on color. Color will be graded as 0, 1, 2, 3 based on the amount of color in the endometrial cavity with respect to the myometrium within the box. If there is no color, 0, expectant management. 1 or 2, this is the most common, where the gynecologist go ahead, size more than 2 centimeters, they remove, DNC, case closed. The most confusing scenarios are grade 3 RPOCs, where you have this bunch of vessels blushing up against the color flow with aliasing with a scary picture. For the fear of bleeding, they don't touch. These patients move on multiple hospitals. By the time they present to the second or third persons, they manifest in the same manner. That is how the cases were referred as AVM. And when Venkateshwar sir was the interventional radiologist who did embolization for uterine artery embolization for all these cases. Then we realized when you do an angio, you see blush of the vessels, spiral arterioles distending and blushing into the cavity without demonstration of draining vein. Meaning they are all enhanced myometrial vascularities and not true AVMs. So, and And the serum beta HCG is a very important non-imaging biomarker guiding in the triage. Serum beta HCG will be positive and usually low. So with these 2 points, the gynecologist can straight away go and do a hysteroscopic removal. No complications were
That is
encountered.
your parameters that you use.
Yes.
We are coming to that. Just now, the question, what are the concerns? The question is, what are the concerns?
So when we have an AVM, one thing is, yeah, we need to think that there's a chorionic villi that's there. Then we have an RPOC sitting there. There's a blood vessel sitting there. So I think we need to, and the uterine contractility. All these 4 we need to take care in step by step.
Okay.
Because
You have any experience with any unusual case that you would want the audience to know?
yeah, definitely. Because see, we have had a case of where she took over she was already a Paris woman with cesarean. And she had visited a doctor for abortion without doing any scan. She was given medical abortion. So she presented later with this bleeding, on and off bleeding, suddenly a big bout of bleeding. So she came with a hemoglobin of 6 and then we saw there was an endometrial RPOC. The only thing is it was little lower down. It was not a cesarean per se. Now she's gone to another center and had an evacuation after that. After that also the RPOC remained. So then she was managed by giving embolization as a method of treatment, post which again she presented with bleeding. After that on hysteroscopy, what was noticed is actually she has had a tract inside which there was chorionic villi, which was then extracted and then she stopped bleeding. So it's a very unique
Anybody else having any unusual case?
So I had 2 similar cases where we diagnosed as AVM, and then after I put in the scan, I said, okay, this was a grade 1 type, and they did a hysteroscopic guided evacuation, and then we didn't have any problem, and then the bleeding stopped immediately after the evacuation.
That is the most important point. The minute you empty the product without damaging the endometrium, that is the crux.
Yeah.
When you see RPOC and you see an AVM, all you need to do is empty the uterus without damaging the endometrium, because that is where the bleeding starts. Okay, so we go into the points of concern. This has been discussed by the panelists. The only point here is that the patient can even come with postcoital bleeding, and it is usually these forms of menorrhagia are unresponsive to traditional treatment. It is usually heavy and the patient can come in hemorrhagic shock. That is what we are worried. If there is a patient who has a diagnosed enhanced myometrial vascularity and she tells you she wants to go back to her village, please stop her. Because I have a patient who we told her very clearly, you have enhanced myometrial vascularity, you have an RPOC, please do not go. She did not listen. She was taken in a collapsed state to a district hospital where they did a curettage. She was then sent in hemorrhagic shock, and it was really a horrible thing. And again, Dr. Venkateshwarlu did an embolization for her in another hospital, and she survived. That's another story, but you have to be careful. So we must remember that be careful when you're doing a DNC in these patients, particularly because it can produce a torrential hemorrhage. So proper diagnosis and proactive treatment, it can circumvent the complications. We all know that good clinical practice means to diagnose, to predict, to inform the patient, take the proper consents. We had Dr. Nagpal, who I'm sure woke up all of us and talked about consents, but this is the most important, and of course then treat the patient. So let's come one after the other. Let's come to the first diagnostic modality. Which is the diagnostic modality? Which are the diagnostic modalities that are available to us gynecologists in the diagnosis? Yeah.
Doppler.
Yeah. Second?
MRI is the second.
Third?
Angiogram.
Fourth? All right. So you've nearly listed everything: hysteroscopy and contrast CT. Okay. Now, what are the ultrasound features? Madhavi, we'll ask you because you'll go into such details that I don't even require to show my pictures. So Madhavi, quickly, the ultrasound features.
The first grayscale ultrasound, always I would say a good zonal anatomy. Uterine cervix, internal os, uterine body, myometrium, endometrial cavity. See, like in this clip which is undergoing, the uterus is anteverted. there is enhanced myometrial vascularity all along the periphery of the uterus with bunch along the anterior fundus. Now if I have to trace the endometrial cavity, if you can swirl or clip, there is a mixed echogenic mass in the cavity along the anterior wall in the upper body, to which these vessels are ending. So there is a cavity mass here. So although when you turn on color Doppler, now you turn on color Doppler.
No, I'm not going to turn on color Doppler. You need to tell me some more.
According
to the MUSA guidelines.
So
it's fun to talk to a radiologist. Being a gynecologist, I have Praveen in front of me, and it's fun talking to a radiologist because they will say so many things in grayscale that you don't even need color Doppler. So go ahead.
So basically this is a cavity mass with an enhanced myometrial vascularity, mixed echogenic mass. Okay. So next thing is we would ask the history, what is the serum beta HCG value, and then put on color Doppler and do all sorts of interesting things by measuring velocity. This is the most overrated diagnosis. Aliasing bunch of flow is not a surrogate marker for diagnosis of AVM. If anything has to be taken, it is this message which has to be taken. Yes. Because this is the most frequent indication by which it comes as the diagnosis of AVM. And here, once you turn on color, the grayscale is completely suppressed. And if you look at the first grayscale imaging, the echogenic endometrial cavity is showing a mixed echogenic mass in the anterior upper fundus into which the bunch of vessels are swirling into.
So I think the most important point is that the vessel should communicate with the cavity. It should communicate with the cavity. The color score was 4, low resistance flow and turbulent pattern. You don't agree with any one of them, you can count.
Here again you can go back to the definition of an AVM. AVM is a direct communication of artery to vein without presence of nidus or a mass.
But this is not an AVM.
That's what I'm saying.
This is enhanced myometrial vascularity where there is a direct communication because of non-regression of the peritrophoblastic vessels.
Here the mixed trophoblastic tissue is acting as a bed along which this spiral arterioles invasion is causing enhanced myometrial vascularity.
Exactly. So that is why you have to go by certain parameters, and you must remember that this vessel must communicate with the cavity, and it is a mosaic turbulent pattern, and you always go by, do you measure the PSV?
Peak systolic velocity. Yes, off late, because some studies, when the peak systolic velocities is greater 60 or 80, they do prior embolization before removing the RPOC.
Okay, we'll counter that in time. But then this is something that makes us diagnose. I've just put this up. Right. So what are the clinical conditions that mimic, you were talking about, you should be careful in your diagnosis, right? Which are the clinical conditions that mimic?
Gestational
trophoblastic disease. Okay. That is the most common. Second, scar ectopics. And other things which we have seen, leaking interstitial pregnancies in an unknown location which feed vessels. And the other cases which we had seen in clinical practice is subinvolution of placental site post full term deliveries and
I put them up
infections.
Here. Retained products, gestational trophoblastic disease. Only these are differences, the beta HCG, uterine and cervical carcinomas, and of course varicosities that we see. Here you can see very clearly there's no communication with the cavity. Okay? I'm coming to that, ma'am. I'm coming. I knew you're in the audience. Okay, so the next is you predict. What are the parameters that predict and stratify patients? Are there any parameters that you will take which stratify patients into high risk and low risk? Can treatment strategies be placed on them?
If it's a cesarean scar, definitely it's a high risk.
Okay.
And as she mentioned, peak systolic, it's not very important because there are studies which tell that yes, more than 60 is high risk because they tell that if the blood pressure increases, so spontaneously they may sometimes have a bleeding. Yeah, so those probably are the high risk.
Anything. What are the ultrasound parameters that will help you stratify?
The lower the RI.
Just now Madhavi had told us about the different color scores, 1, 2 and 3 and 4. That could be one. Is there anything else? So I'm just going ahead because I need to finish. The severity of enhanced myometrial vascularity is from the severity of the symptoms first. Hemodynamic stability of the patient, the velocity, the peak systolic velocity, because it can predict the natural history and guide management. So if the peak systolic velocity is high, it means this patient is going to bleed. So you must measure the peak systolic velocity and also the subjective diameter. You look here, you can see these are huge vessels. So in these sort of cases, what you are really going to do is embolization. So you must look at the diameter of the vessels, you must look at the peak systolic velocity as well. So Madhavi, for you, for all of us here, when you put the Doppler gate in different places, you will get different velocities. So how do you select the real vessel?
Usually
I put this only for you.
No, usually I take at uterine arteries, input vessel,
Okay.
at the internal os, where if it is more than 80, usually as you see, it will lead to a bunch of vessels, but the origin and epicenter of the vessel angiographically will be the vessel which is...
What is the peak systolic there that you take? What is the normal velocity that you see?
Normally it shoots above 80. This was when I presented in EPOS, European Society. There they questioned me and they told their guidelines are if the patient has increased peak systolic velocities greater than 80, then they choose to offer embolization prior to hysteroscopic removal.
At the origin?
At the origin.
Not at the point where the AVM is?
No, then that all will be completely aliased and mixed.
Okay. So what we do is, according to the guidelines that I have read in the ISIOG, what they really do is that they increase the PRF and see till one vessel comes, and then they take that vessel and consider that as the peak systolic velocity, and that is how they then divide their patients into different parts. So if the peak systolic velocity is less than 40, these are the patients you can treat conservatively. If it is between 40 and 60, you call them regularly for evaluation, and if they are symptomatic, irrespective of the peak systolic velocity, you take them up for treatment. If the value is more than 80, she definitely requires embolization. So this is how they stratify treatment. Okay, so now that we have come to the diagnosis, could you just tell me, a patient has come to you, Jayanti. What would be your steps?
After evaluating the patient, and I will make sure that is she hemodynamically stable or she is unstable. So depending upon that, I will decide what type of management I would like to give her.
So that's step one, you assess by a good history and symptoms. Second,
and
you said about the hemodynamic status.
Yes.
Fair enough. I'm just putting this for all of you because this is how we manage our patients in the clinic, and we've learned it over time. So the first step is you make your diagnosis, take a good clinical history, taking the symptoms, following which the hemodynamic placement of the patient is extremely important. Next.
Then afterwards I could do the ultrasound and then make sure that what is the peak systolic velocity, and depending upon that I can decide whether I will wait for spontaneous resolution also is known to occur in this, so whether I will go for that or I need to treat her.
And the last one is, don't forget, counsel the patient, tell them that at any point of time they may bleed, give them instructions that they should not travel, give them instructions that in case of emergency they come immediately, and they should be ready for a hysterectomy at the last resort. Okay?
Yes.
So take appropriate consent. So putting everything, confirm your diagnosis, calculate the peak systolic velocity, decide which group the patient comes into. If the peak systolic velocity is lower than 60 with no bleeding, conservative management, and if it is more than 60, then you have to think of embolization. So coming to the last part, which will take another 8 minutes and we'll complete. How do you treat? Do you leave it alone? Do you treat it or embolize it? So we'll go into this. How long does Dr. Hegde resolution take? Suppose you leave the patient alone. How long does resolution take?
It may take a few months also sometimes, or sometimes they can resolve within 6 to 8 weeks.
And
so
if you take away the products of conception, how long does resolution take?
Within 6 to 8 weeks, it will regress.
Okay, then this is a quick, this is what I've taken out from the data. The range of time for resolution is 2 to 10 weeks, and if you are treating them surgically, you can see very clearly here, in 10 days there is complete resolution. If you treat them conservatively, it is 48 days on an average. Okay? So the next thing is that this is a method of treatment that we have been following of late, and this is giving them, once the bleeding has started and you've diagnosed enhanced myometrial vascularity, we give them Trenexa IV, and 8 hours later we give them orally for 3 doses, following which we give them a GnRH analog and letrozole for 5 days. And we have seen in 80% of the patients spontaneous resolution happening. And then we, of course, do with ultrasound, we do a removal of the products of conception once 3 or 4 days have passed and the bleeding comes down. So always remember, do it under ultrasound guidance. And this is something, I just wanted you to see this. We always use this mechanical hysteroscopic resection. It is very simple. It doesn't traumatize the endometrium. The blood clots are sucked out. I just play this. It's about a minute. And then the RPOC, you can see protruding at the internal os. The incisor window is placed over that, and it actually sucks the whole RPOC, and you don't injure the endometrium. The most important thing is you don't injure the endometrium, and the bleeding is virtually nil in these cases. Okay? So embolization when? Now tell me, when would you do embolization? Can we have it fast, because we have another 8 minutes left?
When we know that the patient is not stable, and also when we know that the PSV is high, these are the conditions, and when she is bleeding also heavily.
Why don't you do it in every case? It's so safe. Why don't you do it in every case?
Because we know now that there is spontaneous resolution that occurs.
No, but why are you not wanting to do it as a primary procedure?
Because the fertility also can be affected.
One is fertility, okay.
Because persistence of trophoblastic tissue, it will keep on recruiting. There will be failure of embolization. We did such cases, they again came back with bleeding because it will recruit from the contralateral circulation.
Okay, here is a paper that I read on the short-term complications, post-embolization syndrome, vessel rupture, puncture site at aneurysm, ischemic complications, endometritis, effectiveness, the effect on fertility. And here we keep this paper, and whenever a patient asks us, what is the chance that I will have this complication, we show them this and tell them, well, if you have embolization, these are the problems that you can face. We tell them, we take the consent saying that we have given them the information. So information these days is extremely important. We don't do embolization as a primary procedure. It is only done as a last resort. So I put everything in order. When you have enhanced myometrial vascularity and no bleeding, expectant management. If there is bleeding, surgical removal. Remember, always be prepared. Always get an anesthetist to always help you. Do not try to do this without an anesthetist. Keep a cross-match sample and keep blood ready. Inform the anesthetist, inform the interventional radiologist. Surgical removal ideally is with ultrasound guidance or with a hysteroscopy like the way we do it. Keep the dilators ready. Always dilate the cervix and keep it ready, because suddenly if there's a tsunami of blood coming in and your cervix is tightly closed, it can be really a problem. So keep the dilators ready, do the HCG test, and of course you can use a balloon catheter, or last rescue is embolization. Keep your eyes on the stars but your feet on the ground. Okay, so I end this by, I have 4 minutes more, so I just end this by this, the latest case that I saw. This patient came to me for a scan. She was referred by a dear friend of mine, Dr. Tripura, and we did a scan for her, and what we found was a mixed echogenic mass at the lip. She had no history. She came for fertility treatment. She had no missed period, but on constant asking, she said she may have missed a period, and because she had excess bleeding, she went to a gynecologist who did evacuation for her, and she had excessive bleeding but stopped. She came back to the institute, and what we saw was a mass in the anterior myometrium. She had one previous section. She had a mass which was communicating with the uterine cavity, and the overlying myometrium over that mass was 1 millimeter. When I put in the Doppler, the peak systolic velocity in this patient was 80. I was so petrified, I rang up Tripura. I said, Tripura, here's your patient, take her and handle it, keep anesthetist ready, and she requires surgery. But Tripura decided that she wanted to embolize this patient, and embolization was done, and you can see post-embolization, the vascularity virtually came down, and then she went ahead and she even put music into this. And she gave me this video, which I think is nice that all of you all see. You can see the resemblance between the scan and what you see on the, and she excised it very easily. And hardly had 10 days passed, this patient asks me, Madam, when can I go for a pregnancy again? Okay, so those are the products of conception. Okay, so this panel is aimed at only creating awareness. I took up this topic only for awareness amongst all my colleagues. Gynecologists providing surgical and medical abortions or encountering patients after a miscarriage or C-section should be aware of this existence. Rule out before doing a DNC for prolonged uterine bleeding post-abortal. Rule out enhanced myometrial vascularity. Particularly be careful with patients with previous cesarean. Routine grayscale and color Doppler evaluation in early pregnancy in these patients with previous section is mandatory. Please advise them. Be aware, and this, my dear friends, is the real objective of this presentation. Thank you very much for your patient listening, and I thank my panelists. They've really been really good. Thank you so much. It was wonderful. I think they need a big hand. And thank you to all of you all for being so patient to listen to this unusual panel discussion that Lakshmi gave me. She gave me another topic, but I said, no, I need something unusual. Lakshmi, I'm going to talk about mysteries of the uterus. To me, this was a mystery. That's what I had to introduce again. First I said mysteries of uterus, and then I said, no, Mamta, this is a mystery. Challenging one. I finished in 45 minutes. He's looking at me. Every time he's after me.
Thank you, ma'am. Thank you, ma'am. Dr. Lakshmi Ratna, ma'am, will present memento to Dr. Mamta, ma'am. Dr. Hemlata, ma'am, can you please come on the stage and present the mementos to our panel members also, ma'am? Dr. Hemlata, madam, to Dr. Vandana Hegde, ma'am. Dr. Jayanti Reddy, ma'am. Dr. Jayanti Reddy, ma'am. Next. Dr. Pratibha, ma'am, to Dr. Jayanti Reddy, ma'am. Dr. Madhvi Nori, ma'am. Dr. Prasad, sir. The poster presentation PGs, can you please follow Dr. Tejasvi ma'am here? Can you meet her, please? Thank you. So for the next chairpersons, I would like to call upon Dr. Mahalakshmi ma'am. Dr. Mahalakshmi ma'am. Dr. Mahalakshmi ma'am is graduated from Kannur Medical College. Her MD was done in OBG in Kannur Medical College. She is a graduate, undergraduate and DNB examiner for various universities since 10 years, guide for post-graduation dissertations in 6 years. She has many publications to her level. We welcome you, ma'am. Dr. Vijay Lakshmi ma'am. Dr. Vijay Lakshmi ma'am, MD DGO, is a professor and head of the Department of Obstetrics Gynecology at Bhaskar Medical College and Hospital. She has 4 decades of teaching experience with the state government medical education department. She's trained in microsurgery, recanalization from Chennai and gynecological endoscopy from University of Kiel, Germany. She was awarded Chief Minister's Gold Medal in the year 1998 and was also an award-winning trainer in laparoscopy. She actively participates in national and state level conferences and chaired many sessions. Welcome you, ma'am. Dr. Jayanti Reddy ma'am, Jayashree Reddy ma'am. Dr. Jayashree ma'am. Jayashree Reddy ma'am is a consultant obstetrician and gynecology laparoscopic surgeon, infertility specialist, Ankura Hospitals, Banjara Hills. Welcome you, ma'am. Next session is on aorta by Dr. TLN Praveen sir. I request Dr. Jayashree ma'am to introduce Dr. Praveen sir.
This is my privilege to introduce Dr. Praveen. He is practicing fetal medicine for the past 35 years, past Vice President and National President of Radiological Association of India, I think. Past President, FUMB, past President Society of Fetal Medicine. He had several awards to his credit, Certificate of Excellence for first coronary angioplasty in the country, Appreciation Award from Foxy, Dr. Ashok Mukherjee Gold Medal, Indira Priyadarshini Award 2014, Lifetime Achievement Award 2018. So there is no end, and he has published several chapters in textbooks. Over to you, sir.
Thank you very much, and I'm sure you're all eager to go back and watch the World Cup. But anyway, I'll take you through very briefly, and the most important component of this is to make you all aware of what this aorta risk stratification is, because I'm sure all of us in our day-to-day clinical practice, we do come across these adnexal masses, and they are being referred to us as adnexal masses, which we need to categorize, and that is what is going important, because it is essential that to optimize the management of these patients. In order to optimize, we need to categorize these adnexal masses as benign or malignant masses. Now, IOTA has come up with a publication in 2000 stating the terms that are going to be used and the definition of the terms that are going to be used in identifying these adnexal masses as benign and malignant lesions. And at the same time, the idea of this aorta classification or aorta stratification is basically because to standardize or homogenize the assessment of adnexal masses to differentiate them between benign and malignant lesions. Now, this helps in optimizing the treatment protocols in managing these lesions, because not only that, it is essential that we need to identify with the lesions whether they need surgical exploration. If it is surgical exploration, what type of surgical exploration is that has to be, is it a minimally invasive surgery, laparoscopy, or extensive staging laparotomy? So these are all the various components that have to be addressed, and these things can be addressed by following the IOTA guidelines that have been published. Now, there are certain prediction models that have been proposed by the IOTA. One of the most important thing is what is called as the pattern recognition. That is one most important thing that which help us in almost about 60 to 63% of the cases to identify the lesion that we come across in the adnexa while we are doing ultrasound examination. And the other thing is based on the morphological features, whether there is a solid component. If there is a solid component, what is the size of the solid component is also to be addressed to, and it can also stratify whether it is a benign or a malignant lesion. As I take you through, I'll show you various examples. Then we have what is called as the simple iota rules. These simple iota rules can be categorized as benign features and malignant features, that is B features and M features. So there are certain set rules that have been laid down identifying certain features, ultrasound features, which can categorize these lesions as benign lesions or a malignant lesion. Now, in case if we cannot come to a conclusion in spite of all these strategies or prediction models, then we need to depend upon the mathematical models, which are called as the logistic regression 1 and logistic regression 2, where we take various parameters, particularly in LR1, that is logistic regression 1, we take almost about 12 parameters, but then it has become very extensive, so that's the reason why they have cut down, and they come down to 6 parameters which are going to help. But now we have what is called as the ADNEX model, which is an app-based model, wherein you can give the information that is required. It has almost about 9 parameters that taken into consideration. 3 of them are clinical parameters, 6 of them are the ultrasound features. So whatever the clinical features and the ultrasound features, if you can feed it onto that app, then it gives you a possible stratification, whether it is a benign lesion, if it is a malignant, is it a borderline lesion, or if it is malignant, is it a stage 1, stage 2 to 4, or a metastatic tumor. So this is how it is going to help us in strategizing these lesions. Now, there are other models also that are present which can be also used in evaluating, but quite often they are not very effective, particularly when we deal with, in dealing with what is called as the risk of malignancy index, wherein you take into consideration almost 3 parameters, that is the ultrasound features, the menopausal status, as well as the CA125. So these are the 3 components that are taken in, but then the specificity and sensitivity of using this RMI in strategizing whether the lesion is benign or malignant is not very sensitive. That is the reason why it has gone out of vogue. The second one is called as the ROMA, in which we take into consideration the CA125 as well as the human epididymis protein 4. But then this is purely a biochemical parameters or purely biochemical method of stratifying or identifying the risk categorization of these lesions. Now, coming to the pattern recognition. What is this pattern recognition? It's also known as easy descriptors. Why do we call it as easy descriptors? Now, I'm sure all of you will agree with me that this is a kitten. Yes, no? Yes. Why? Were you told or were you aware of? Just by seeing it, you know that it is a kitten. Similarly, you know that these are the pups, isn't it? So you don't need to be educated on that. So there are certain features, ultrasound features, which are so very characteristic, based on which you can make a diagnosis. You don't need any histopathology also. That is what is called as the easy descriptors or what is called as the pattern recognition. Now let us go through one of them, each one of them. Now here, I will describe the lesion, you tell me the answer, okay? Now we have a very clear-cut, well-circumscribed cystic area or a ground-law cystic area without not much of a posterior enhancement, and it is in a premenopausal woman. And now when I do this one, I did a transvaginal examination where I used my transducer to evaluate the soft markers. Soft markers are the site-specific tenderness and the mobility of the organ which I am examining. Now here, I am trying to push the ovary, which is very close to the posterior wall of the uterus, and can I move it around, and that is, can I slide it over? No. So it is stuck to the posterior wall of the uterus. So what is your diagnosis? Fantastic. So there is no, so how did you know that? It is not written there. But because of the features, this is what is called as the easy descriptors or the pattern recognition, which will help you in identifying these lesions. Now similarly, this is one more lesion I am going to put forward to you. Here it's a unilocular cyst with mixed echogenicity, and there is a hyperechoic area with acoustic shadowing. So what is your diagnosis? In a premenopausal woman, what is your diagnosis? Fantastic, great. So this is dermoid, right? These are all the pattern recognition. The third one is you have a unilocular anechoic regular wall, maximum diameter which is less than 10 centimeters. What's your diagnosis? Simple cyst. Fantastic. Great. Now here again we have a well circumscribed unilocular cyst with internal echoes, and there are septations which are there. And when I am doing the ultrasound transvaginal examination and I am trying to push that one, I can see this mass-like structure which is wobbling. So what is your diagnosis? Hemorrhagic cyst. Fantastic. So you're all experts, so I don't need to take you through this lecture at all. So this is what is pattern recognition. Similarly, you have another case where we have a absolutely solid looking mass, and when you put the color Doppler on, you find that there is increased vascularity, which is very, very typical of a solid ovarian mass. It has to be ovarian cancer, right? So this is how, these are all the features which will dictate the diagnosis or tell you that what sort of a lesion which you are dealing. And there is no need for any histopathological examination or any histopathological confirmation, because they are so very typical, and these are all called as the pattern recognition. Now, then in case if you cannot diagnose based on this, then you need to think in terms of what is called as the simple ultrasound based rules, which are called divided as M rules, M features and B features. There are various features that have been described. When you find these features, you need to think in terms of a possible malignant lesion or a benign lesion. Now, I'll tell you where the confusion starts with these things. Now, when you take the B features, that is the benign features, we have what are called as the unilocular lesion, that is one. Then the presence of a solid component. Sometimes there may be a presence of a solid component, but then that solid component will not be more than 7 millimeters in diameter. That is two. Presence of acoustic shadowing. Remember, in adnexal lesions, whenever you find a acoustic shadowing or a calcific area or a hyperechoic area, you need to think in terms of a benign lesion. Quite often it is a benign lesion. Then comes the smooth multilocular. There are certain situations where you may have a multilocular lesion, but the diameter of which is less than 10 centimeters. Then we call it as B4 or the benign feature 4. And whenever you put the color Doppler on, as it has been already stated, you can score the color Doppler. But then scoring the color score is a subjective parameter. Now we don't believe in that subjective parameter, because I may say it is color score 0, you may say it is color score 2 or 3 or whatever it is, but then there is no the agreement between it. That is the reason why we started using what is called as the vascular flow index, which will tell us exactly what is the color component in that particular lesion. What is this vascular flow index? It is nothing but the amount of pixels, the colored pixels in the whole area is what is going to dictate or tell you about the possibility of an increased vascularity or a decreased vascularity or no vascularity, right? So this is one thing that we have to keep in mind. Now, here we have the examples of each one of it. Here we have a very clear unilocular cyst, which is absolutely well defined. Internal walls are absolutely clean. See the terms which I'm using it, because these terms are extremely important. If you use the same terms, coming to a conclusion becomes much, much easier. So what did I say? I said it's a well circumscribed. 2, I said that it is absolutely anechoic. 3, I said that the inner margin is clear, outer margin is clear, there is no solid component, it is unilocular. That is 1. That is exactly the typical example of a simple ovarian cyst. Then we have a solid component which is definitely less than 7 millimeters. Not only that, when I put the color Doppler on, there is no color. So absolutely it shows that avascular solid polypoidal projection within the cystic area. Then we have here a calcification, which is absolutely producing the acoustic shadowing, which are definitely going to be a benign lesion. So this is B3. And when we have a multilocular cyst, but the cyst size is less than 10 centimeters, you consider it as B4. And whenever you have a lesion which has no blood supply, you call it as B5. So these are all called as the benign features, and these are going to help us in categorizing these adnexal masses as benign or a malignant lesion. Now, second situation is what is called as the malignant features, or the ultrasound features of malignancy, that is M features, wherein you have what is called as an irregular solid mass. You may find that there is an adnexal mass which is absolutely irregular and lobulated, and it is solid component. And then you have presence of ascites. Now, free fluid in the peritoneum is again a very derogatory finding which you find, which is very highly suggestive of possibility of a malignancy. Then we have at least 4 polypoidal structures. That is, as I said, in the benign features, that the inner wall of the cyst is absolutely clean, whereas here we find at least 4 polypoidal projections projecting into the cystic area. Then we have irregular multilocular cyst, which is more than 10 centimeters. There we said less than 10 centimeters is a benign feature. Here we say more than 10 centimeters is a malignant feature. Then we have intense blood flow, that is intense vascularity, color score 4. So these are all the features which are classical of it. Now you know, you agree with me that this is an obulated solid looking mass, which is definitely a irregular solid mass, which is M1. Then we have ascites here, which is very, very typical of the presence of a malignancy. And then we have a polypoidal projection. You can see that the inner wall is not regular. It is polypoidal projections which are projecting into the lumen of the cyst. And then we have a thick, septate, solid-looking, multilocular, solid mass, which is seen, which is more than 10 centimeters, which is again a feature of a malignant feature. And when you put the color Doppler on and when you find this sort of a abundant, intense vascularity, it definitely indicates that it's a highly vascular lesion. So these are the features which are called as the M features or malignant features. Now, the problem comes is when you have one or more of these features. Suppose you have only one or more of M features and absence of B features, definitely you will think in terms of a benign or a malignant lesion. Malignant lesion. If you have one or more B features and no malignant features or M features, you consider it as benign mass. But whereas a situation, that's not so simple in our clinical practice, that we may have one or two benign features, one or two malignant features, then you are stuck. That is where it becomes inconclusive. So for that also the IOTA has put forward certain parameters by which you can categorize them as benign or malignant, or they at least assess the risk of malignancy. That is what we are interested in. So the whole idea of this IOTA classification is basically to categorize a adnexal mass either as a benign or a malignant lesion. So in that, doing that, when we have no M features, but we have more than 2 B features, definitely the risk is very, very low. Whereas if you have no M features, but you have 2 B features, not more than 2, it is only 2 B features, the risk is also low, but it's not very low. Then we have no M features, but only 1 feature, and that 1 feature is also B1. B1 is a clear cyst. So in that situation also it is low risk. But whenever you have no features, or whenever you have equal number of M and B features, or when there is 0 M features and more of B features and M features, then there is an elevated risk. But whereas when there are more of M features and B, don't get confused, there is nothing to get worried about, because this is not going to be the way you are going to approach an adnexal lesion. This is only to give you an inference or idea that this is how you are going to. Now there is one more publication that has been done in 2007 by Dirk Timmerman, wherein they have said all lesions which have solid component, the incidence of malignancy goes up. Whereas all lesions which do not have a solid component, which usually have a lower incidence of malignancy. This is one statement that I have made as the conclusion remark of that publication. Now we have the mathematical models. Now you have used the pattern recognition. You know how to use the pattern recognition. Now you have used the simple rules, both B features as well as the M features, but you are not able to come to a conclusion. In that situation, you again get into a mathematical model, which are called as the logistic regression 1 or logistic regression 2. And then we have an app-based model, which is called as the adnex model. Now, all these things are going to be like this. In the sense, in LR1, that is logistic regression 1, there are about 12 variables they have taken into consideration. 1, age of the patient. Personal history of ovarian cancer, yes, no. It is just a simple method of identifying them. They put them onto the parameters that have been requested, you get the answer, right? The largest diameter of the lesion you have to measure. That is, basically we know that anything less than 10 is considered to be benign, anything more than 10 is considered to be malignant as one of the features. And the largest diameter of the largest solid component, anything less than 7 millimeters, anything more than 7 millimeters. Presence of ascites, yes, no. Papillary projections, yes, no. And then the irregularity of the internal cyst wall, presence of purely solid tumor, color score, presence of acoustic shadowing, current hormonal therapy, pain during examination. So these are all the factors that you have to consider. But then this is a huge component. That is, when you need to consider about 12 variables in order to come to a conclusion, which was becoming very, very difficult for us to practice. So then they cut down on LR2, and in the LR2 they have taken only 6 variables. One is the age of the patients, presence of ascites, presence of solid papillary projections, maximum diameter of the solid component, irregular internal cyst wall, presence of acoustic shadowing. So these are the factors that have been cut down as far as the LR2 is concerned. Now, with these things, there has been proposal that, now using all these parameters, let us say pattern recognition or the simple rules or the logistic regression 1 and logistic regression 2, you are going to tell that it is a benign or a malignant lesion, but then that is not sufficient for us in order to plan the management strategy. What you need is to know whether if it is benign, how far is the benignity is concerned, that is how much of percentage of this sort of a lesion with these features are going to be considered as benign. That is one. Second important factor is that I would like to consider whether it is a borderline tumor. The third possibility which I would like to consider is whether it is a stage 1 or it is stage 2, stage 4 or it is a metastatic tumor. So this is what is very, very important for us. So it is just not the benign and malignant, but in the malignant also we would like to get this sort of an information, which is possible by taking this ADNEX model into consideration, where they have 3 clinical parameters or variables. One is the age of the patient. Second is the serum 125, CA125, and then the type of the center. That is it being referred from an oncological center or is it from a general hospital? Has to be also known. But then remember, all these parameters, there is no hard and fast rules that you need to fill up. Suppose your patient has not got a CA125 with you, so you don't need to. You just say that CA125 is not available and still use the app. Okay. Now, the 6 ultrasound parameters are going to be that the maximum diameter of the lesion has to be put in. As you can see here, you can put them on, and then the proportion of the solid component, that is the size of the solid component, more than 10 cystic locules, number of papillary projections, presence of acoustic shadowing or ascites. So these 6 parameters have to be put into the ADNEX model, which tells you how to manage them. So I will take you through few cases so that you can tell me whether it is going to be helpful to you tomorrow when you start practicing tomorrow morning. Monday morning when you start, you do an ultrasound examination, find an adnexal mass. What are you going to do? This is a lady who has come to me at 31 years old female. She came with a adnexal mass, and this is what I find. This is the transvaginal examination, and this is the transvaginal examination with color Doppler. What are your findings? Right, okay, this is a 31-year-old female. Now I am going to put the unilocular solid lesion, which is about 38 millimeters in diameter. Then there is solid component of about 21 millimeters. Then we have a solid moving on probe pressure. This is an extremely important factor. Then we have the cyst content particulate. The internal cyst wall is irregular, and then the outer cyst wall is smooth. So these are the parameters you have to think in terms of. When you see an adnexal mass, your brain should start working in these lines so that it can be standardized and homogenized. And then we have the color score 1, because here you don't see a color at all. And then we have, there is no evidence of calcification or acoustic shadowing. So with these features, would you like to give a diagnosis? Yes, no? Yes. Yes, no? Yes, what is the diagnosis? Come on, shout. Okay, fantastic, hemorrhagic cyst. So this is the one. So once you have this one, these are the features. Can I use the pattern recognition? Can it be applied? Yes, it can be applied because it is very clear cut. I have shown you an example also, and which is definitely a hemorrhagic cyst. Now, second case. There is another lady who is 48-year-old and been sent with an adnexal mass. What I find is that there is a solid, unilocular solid mass. You agree with me? This is the unilocular solid mass. And the mass size is also more than 1. I'll show you that the 48-year-old and then unilocular solid mass, which is almost about 67 millimeters. And then there are multiple polypoidal projections. You can see these multiple polypoidal projections here. And then and the polyps are more than about 3 millimeters. Cyst content is clear, whereas the internal cyst wall is irregular because there are polypoidal projections within the cyst. And then we have the outer cyst wall, which is absolutely smooth. And then we have the color score. You can see here the polypoidal projection has got color score about almost 3. And then there is no calcification, there is no ascites. So with these findings, are we going to depend upon the pattern recognition, or you want something more than that? Come on, answer. You have to answer, then only I will move on to the next case. So we have all the data here. Would you like to use this as a pattern recognition? Is there a method of pattern recognizing this one? Are there easy descriptors? No, you don't have. So you can't apply that. So can you apply the IOTA simple rules? Yes, here there are two benign features and two malignant features. So it is inconclusive. So what is your next step then? What are you going to do? LR1, LR2. So I did the same thing. I put the LR1 and LR2, and the risk proportion is almost about less than 1. If it is less than 1, you usually consider it as benign. But then I put this into an IOTA adnex model, wherein I have filled up all the parameters that has been asked. That is the 3 clinical parameters and 6 ultrasound parameters, and that strongly tells me that it is a 82% possibility of a benign lesion, isn't it? And this turned out to be a borderline mucinous endocervical type of malignant tumor, borderline tumor. Okay? So this is one thing that we have to keep in mind. Next, another case. Here is a 67-year-old female who came to me with this sort of an adnexal mass, and then when I find it, then you have a unilocular solid which is about 54 millimeters, multiple polypoidal projections which are more than 9 millimeters in size, and then there is the cyst content is clear, and then there is a internal cyst wall is irregular, and then we have outer wall which is smooth, and color score, polyp color score is very only 1, because you don't find any polyp. These are all the polyps, but there is no color here. Only the peripheral color is seen, and then we have the color score 1, and then then we have the what happened? I know. Color score 1. So with this, would you like to use a pattern recognition? No, you can't. Can you use this as simple rules? Yes, no, because there is solid component is there, cystic component is there, so you can't use it. So simple rules are also not useful, whereas the LRH again says that it is less than 1. So we did it onto this thing. It shows, first and foremost thing, even though the possibility of a benign lesion is almost about 66%, but you have to see that there is a borderline lesion which is almost about 16%. So that means it has a possibility, higher possibility of a malignancy or a borderline tumor. So that is how it is going to give you a percentage value which is equivalent to decide whether it is a benign lesion or a malignant lesion. Once you have this information, management strategy becomes very easy, isn't it? Right. So this turned out to be an epithelial borderline serous tumor. The last case, I'm sure you're all getting bored, and then it is 62-year-old female, post-menopausal. We have a right ovary which is absolutely solid looking. Yes, no? Yes. And I put the color Doppler on. Yes. It is increased vascularity is there. Let it be color score 3, color score 4, it doesn't matter. Here I have another thing which is a power angio, which I can see that there is an intense, abundant vascularity which is seen. So it is a 62-year-old postmenopausal woman, solid mass, no calcification, cystic solid mass. Then we have the color score 4, and then there is no ascites. And then can you use it for a pattern recognition? Yes, no. Fantastic, great. That's because you know that it can be applied. You don't need to worry at all. You know that it is definitely a malignancy. But then that doesn't make my day end. I would like to know whether it is a borderline tumor, whether it is a stage 1 or stage 2, stage 4, or it's a metastatic tumor. So that is why we put it onto the adnex model, where you can see that the incidence of stage 2, stage 4 is very, very much. So this is how you are going to stage these things, and this is how we get the information as far as the adnex model is concerned. So this is extremely useful. Only thing is, you need to understand the terms that are being used, the definition of the terms that are being used, apply them in your adnexal mass, you get an answer. So that is how it is going to work. This was a high-grade serous carcinoma. So with this is the specimen actually of the same patient. So thank you very much for this opportunity, and I would like to thank Ankura for giving me this opportunity. Thank you.
Really mind-boggling. Any questions, please, from the audience? 1 or 2 questions. Thank you, sir.
Thank you, sir. I request Dr. Jayashree Madam to give the memento to Dr. Praveen, sir. Next session is on perimenopausal contraception by Dr. Prasad Kulat, sir. I request Dr. Vijayalakshmi madam to introduce Dr. Prasad, sir.
Thank you. First of all, I would like to thank Dr. Lakshmi Ratna for inviting me to participate in this very, very excellent program. I call upon Dr. Prasad Kisan Rao Kulat, sorry, for presenting the case on perimenopausal contraception, is it? He is a consultant in the Department of Obstetrics and Gynecology, Ankura Hospital for Women and Children, Pune. And he has got many publications and participation. And he is a co-author in aortic clamping for limiting blood loss at cesarean hysterectomy for placenta previa, a case series which is published in the International Journal of Gynecology and Obstetrics in 2021. And he is a co-investigator for GRACE RSP MAT 009 study, that is International Multicentric Study through July 2021 to June 2022. So I invite you for your presentation, sir.
Thank you, ma'am. So, to begin with, today's entire session is a brainstorming session of having all experts talking about different specialty aspect of the obstetric and gynecology. We'll coming back to, like, end of the day, we are coming down to the basics of gynecology again, to the contraception, and that to a perimenopausal contraception. So this is Lord Vitthal, where in Maharashtra, back in Maharashtra, we call them as a Vithu Mauli. Mauli basically means mother. So it was always a feeling that how come a male god is being called as Mauli, but it's more of a feeling rather than whether it is a male or a female. So I want to dedicate this entire lecture to all mothers and the Maulis in our hearts and in our life. So let's begin with today's topic, which I'm asked to share with you, is a perimenopausal contraception. Perimenopausal contraception, to understand, we need to understand 2-3 things. One is what's menopause, then comes a perimenopause is around the menopause, and third word in it is contraception. So menopause is defined, confirmed with the 12 months of amenorrhea in women's age 40 and above by NMS. And Faculty of Sexual and Reproductive Healthcare says that 2 years of amenorrhea in patients who are women who are 40 to 50 years of age, and 1 year of amenorrhea in ladies who are 50 years and above. So Solus has classified perimenopause into 7 stages from -1 to +2, of which it comprises from the beginning of like menarche to the menopause. The categories of interest to us would be early perimenopause, which is stage 2, late perimenopause, which is stage 1, final menstrual period, that is stage 0, and early postmenopause, that is stage 1. Of which the principal criteria to diagnose the early perimenopause is having the irregular or variable cycles, the cycle length which in a consecutive cycles increases by minimum of 7 days. It might be a cycle length might reduce to less than 25 days or might increase to more than 35 days. The late perimenopause is a time when the cycle length increases to more than 60 days. So annual risk of pregnancy is lower than it is considered in the younger age. At younger age, there is maximum around 20 years of age, which is around 25 to 27%, which drops to 10% by 40 to 44 years, and which drops further to 2 to 3% by 45 to 49 years. We must understand one thing, that even though the percentage drop, it has never come down to a 0. It's as if Quinton de Kock, in currently the World Cup is going on. He's announced his retirement from the ODI series, ODI competitions, but with the last series he has scored maximum centuries. The person who has played 138 innings in his entire life, Glenn Maxwell, has only scored 3 centuries until now, and at the late stages of his inning, he has scored a double century when it was required. The similar things happens in a perimenopausal age. When they are not actually expecting the pregnancy, they get that surprises. So we must understand the physiology which usually happens during the perimenopausal age. One is to begin with is primordial cells. They usually originate from the endoderm. The multiplication starts at around 6 to 8 weeks. The maximum during 20 weeks of gestation to around 6 to 7 millions. By birth, they are reduced to 2 millions. By the time the girl reaches the puberty, they are reduced to almost like 3 lakhs, of which only 400 oocytes ovulate, around with her 35, average 35 years of reproductive age, of which we must understand that almost like 88% of the cycles, menstrual cycles, are ovulatory until up to 5 years before the menopause, and about 23% of the cycles are ovulatory within the 1 year of menopause. So once we see the road like this, it's not always that the accidents would happen by the careless drivers. It might happen with a very skilled drivers also. At some times, it's like an accident many of the times. It might not be only because of overspeeding. It might be because of the hairpin band roads which are ahead, which the complexity because of the hormonal complexes, the unpredicted ovulation, the hormonal changes that are going on the patient's mind, the socioeconomic status that are associated with. So I would like to share a few cases which I have encountered during my residency, during my work experience in my hospital. So when I was working as a JR1, I had one patient walking in with with her son. She was almost in like late 40s. She was accompanied by a son who was around 20-25 years of age, with pain in abdomen. She was a widower for last 10 years. So she was referred directly from the casualty to the labor room. So my seniors told me to take her to the sonography to get her investigated for the pain abdomen, and if it's not a gynecological cause, just push her to the surgical cause, because gynecologists are like so resilient about it that we'll have to investigate and then only we can transfer it to the medicine or to the surgery fellows. So I went down, and to my surprise, to our surprise, it was their diagnostic as it to be a tubal ectopic, impending tubal ectopic rupture. So by the time I got her to the labor room, she was almost like in collapsing situation because of hemodynamic shock. We took her for an emergency laparotomy. We, as been like my seniors and lecturer, took her for this laparotomy. They had done a laparotomy. Afterwards, I got a very good firing from my HOU. That after like having seen so many things, I didn't do a UPT. Actually, it didn't strike to do a UPT in a widow. We are inhibited by our own things, whether to ask some questions or like how to go ahead with these situations. So that was a lesson learned for me. So when I was doing my lecturership at KEM, so a patient was referred from a gynecologist for a combined care with a surgeon and a gynecologist. I went down to see that patient in an emergency department. At that particular place, when I saw the patient had an acute abdomen. The sonography with which she was sent was suggestive of right iliac fossa mass, which was query some cyst rupture, query some appendicular mass or something, and that's why they wanted to investigate it further with a surgeon and have a combined management. So, like last lesson learned, I only asked them for doing a UPT. So the patient's husband told me, "Nahi sir, we have done a tubal ligation. She's previous to cesarean section. We have done a tubal ligation like in last cesarean section." I said, "Still we'll do a UPT." "Nahi sir, she had menses. It was just a couple of days ago." I said, "Okay, but still we will do UPT." And the UPT turned out to be positive. So we took her for the laparotomy. She had an ruptured ectopic. So even having a periods that was typically of a aristilla reaction, which had that 2 days ago bleeding, which was about impending rupture. That's how the bleeding was. But we cannot overlook these situations. The third situation which I had encountered during my early period of a consultancy was this. A patient was brought to our casualty with pain abdomen. This patient had undergone subtotal hysterectomy for obstetric reason for a atonic PPH when she had her twins delivered 20 years ago. So it was a subtotal hysterectomy, pain abdomen. This patient was referred with a USG saying that the patient has some ovarian malignancies. So when we did her, it was so suggestive and the pictures were very apt for some ovarian mass. So we did her hormonal assays, of which only beta HCG came positive. And that too was not in a malignant range, it was just borderline positive, leading us to suspect it to be a chronic ectopic. So when we explored this patient, had tremendous adhesions inside, that both of the tubes were actually attached to the cervix, which was like a part of a cervix which was remaining in the uterine wall. The tubes were attached to it, and that had got like a chronic ectopic. And so we had to remove the bilateral tube and the unilateral ovary, and this was another case which I had to go through. So when we talk about these situations, like it's always that situations like this always follow Murphy's law. Murphy's law is whenever the things can go wrong, it will go, and when you don't expect them to go wrong, they will 100% go wrong. So situations when this arises, we need to be sure about it. It's like I said, we are inhibited by own thoughts, whether how do we talk to the patient in this age about contraception. They themselves are so inhibited expressing those things to us. But we can take that chance when they come to us with so many of our gynecological issues, that they present with irregular cycles, AUB, increased possible occurrence of osteopenia, there's sleep disturbances, vaginal changes. There have been so many things going on at that particular phase that they require someone to talk to, someone can guide them through. We can take that opportunity and talk to them about the contraception. So obstetric complications that we are expecting in such patients is high risk of miscarriages, chromosomal abnormalities because of a chromosomal disjunction, abnormal chromosomal disjunction. There's increased chances of preeclampsia, diabetes mellitus, gestational diabetes mellitus, postpartum hemorrhage, and we don't want us to land up in a situation like a Badayu ho. So that's why the patient needs to be properly told about it. So once we are clear about what's menopause, what is perimenopause, what are the complications, anticipating those complications, we are now moving ahead with the contraception. Contraception is a method or a system which allows intercourse and it prevents the conception. Temporarily, it might be a short duration or a long duration. Many of the times, it is not only with the contraception, with many of the drugs would actually help us through her perimenopausal symptoms too. That we will see in the further slides. So to begin with, we'll start discussing with the combined hormonal contraceptive, which comprises of combined oral contraceptives. They are basically classified into monophasic, which are low dose and a very low dose. Monophasic means both the doses of estrogen and the progesterone are fixed. Low dose estrogen will have estradiol, ethinyl estradiol in a quantity of 30 mcgs, and very low dose will have somewhere between 15 to 25 micrograms. There is another classification, another class which is called as triphasic, in which the dose of ethinyl estradiol will be constant, but the dose of progesterone will change over 3 times. It's again can be classified into first generation, second generation, third generation, depending on the progesterone which is being used. The third generation occipils are the occipils which consist of the progesterone which have a milder androgenic activity, or the progesterone like drospirenone which have anti-mineralocorticoid and anti-androgenic activity. The mechanism of action is, as we all know, this all features are like we all know about it. We just want to revise through this. So mechanism of action is inhibition of ovulation. It causes endometrial asynchrony. It causes cervical mucus to be thickened so that the sperm doesn't traverse the uterine cavity. The dose is 1 tablet daily for the 21 days. The remaining 7 days.
Yes. Time is up, sir.
Okay. So different methods that are there are COCs, Nova rings, then transdermal patch, progesterone implants, LNG, IUS, and progesterone implants, POPs. So just to this one, the newer variety we can also use the centromone as ormeloxifene or centromone, and which also will benefit them from the DUB and fibroadenoma risk. Medical eligibility criteria, the patient as such, when it is only considered the age, patient have no risk as far as age is concerned. All the modality of contraception would be useful. Then when it comes to the different pathologies or different comorbidities that are associated, CSC should be avoided in a patient who who have higher risk of stroke, who has higher risk of like high hypertension, uncontrolled hypertension, they are better managed with POPs and copper Ts. Copper T is only contraindications or class category 4. This one is the PIDs or suspected malignancies. Now the only point where to stop with the contraception. The patient who are not on a hormonal contraception or using copper T, the contraception can be stopped at around 12 to 24 months after the last final menstrual period. With DMPA, monitor her FSH at the first day of an injection every 13 weeks. The first day of injection, if the FSH levels are more than 30 for the 2 consecutive things, the method can be stopped. When they are using IUS, POP or implants, if the FSH level are less than 30, it needs to be continued for another year and then recheck the FSH. If it is more than 30, continue it for another 1 year and then it can be stopped. The major concern is the CHCs where the FSH levels are really suppressed. The patient can present with amenorrhea because of the CHCs itself. Either you can change over to the another modality of a treatment, modality of contraception at 50, or stop the contraception when the there's hormone-free pill and do the FSH levels. If it is more than 30, it can be stopped on 2 consecutive levels. The key points are there's no risk with as far as age is concerned. Every contraception needs to be tailor-made for each patient. So, as the saying goes that everyone has contributed in building up a Ram Setu. Here also, Madam had done such a nice, fantastic job in having our journey from Utero to Senescence, and has given me an opportunity to contribute my little squirrel's part into this particular conference. So I really thank ma'am from the bottom of my heart and her team, and also to the all the fantastic gathering. Thank you.
Thank you, Doctor, for going through. Though there was a little short of time.
Thank you, sir.
For completing in time quickly.
Sir, with Dr. Vijayalakshmi ma'am, can I request you to present the memento to Dr. Prasad, sir? Thank you, sir, for the wonderful session. Next, the last session, Bone Health in Women from Childhood to Menopause by Dr. Sai Akangsh, our last batsman for today. And Dr. Mahalakshmi ma'am, can I request you to introduce Dr. Sai Akangsh, sir?
Yeah, it's a great pleasure for me to introduce Dr. Akash, MBBS, MS and SIMP. Is it Menopause Society?
Yes.
SIMP, very nice to have a orthopedic surgeon in the Menopause Society. He's focusing on challenging cases at High Trauma Center, dealing with a variety of scenarios such as arthroplasty, sports medicine, pediatric deformity correction. Awarded with Kanakala Balram Reddy Memorial Gold Medal, and awarded with Gold Medal instituted by Mankind Pharma Limited. Of course, I think he has a lot, many things. I congratulate you, Doctor, for all this, and I would like you to start.
Thank you, ma'am. Good evening, everyone. I would like to present a topic on bone health in women from childhood to menopause. I would also like to thank the organizing committee and Ankura Hospitals for giving me this opportunity. Coming to congenital disorders, especially like in Potter sequence and renal agenesis, it leads to oligohydramnios, which leads to other structural deformities and skeletal anomalies. One of them is CTV, congenital talipes equinovarus. They are usually divided into mild, moderate, and severe disorders. If it is a mild, we can correct it by French strapping method using dynaplast strips in a particular manner, which acts as a dynamic splint. If it is moderate to severe, we can go with Ponseti's serial casting from 5 to 7 weeks. And if it is still not corrected, or if it is severe deformity or presence at walking age, then we go for surgical correction. And we have amniotic band syndromes, where the amniotic bands entangle to the limbs and cause a constriction bands. And this is a particular case called as Streeter's syndrome. They have multiple amniotic bands with metatarsus adductus. We have released the constriction bands by circumference release with Z-plasty manner. This is another patient with torticollis. and she had a prenatal history of oligohydramnios. We have done a bipolar release from both sternal and mastoid attachments. After doing the correction, we place them in a halter traction to maintain the alignment. Developmental dysplasia of hip, which is much more common in girls with a ratio of 7:1. And in the first patient, we can see that if the hip joint is divided into 4 quadrants, it usually lies in the lower inner quadrant. But as you can see, it goes in the outer upper quadrants. And another particular manner, what I want to highlight is the position of child in a swaddle. It should be kept in a mild flexion and legs apart instead of keeping them in extension. This is also one of the causative factor for DDH. And it can be corrected by using Pavlik's harness, which is also a dynamic one. When the child starts to kick, it keeps the hip joint back into place. SCFE, slipped capitofemoral epiphysis. It is not common in girls, but I want to highlight the estrogen's effect, which decreases the physial width and increased physial strength, which explains the lower incidence in girls. You can see as in this X-ray, the capital femoral epiphysis is getting displaced, which leads to a painless limp initially. Perthes disease, it's idiopathic avascular necrosis of the femoral head. A 4-year-old girl presented to us with the right hip joint pain. You can see that it started with the mild avascular necrosis and collapse of the femoral head. We have corrected it by osteotomy and placed it in such a manner that the load weight bearing is shifted to normal surfaces. This is after 5-year follow-up. She is able to stand normally, climb stairs, sit down cross-leg without any pain or difficulty. Birth trauma, usually they involve the clavicle fractures, but they are much more easier to heal until and unless complicated by other nerve palsies. But today I want to discuss on pseudoarthrosis tibia. It is a very difficult condition to treat and usually ends up in amputation itself. It is caused by intrauterine trauma and birth fractures. It causes a membrane to form between the fracture ends, and these fracture ends do not unite and very resistant to even surgical approaches. But because of recent advances, we are using stem cells, PRP, and bone morphogenic proteins to induce fracture healing. Idiopathic toe walking, sometimes the parents are concerned that their children are walking on toes, and which is a normal phenomenon up to 2 years, but should be of concern if the plantar flexion is not reducing by 2 years. Usually it may indicate cerebral palsy or other muscular dystrophies. Normally it is because of femoral anteversion, which is normally 40 degrees at birth and gradually reduces to 15 degrees by the age of 16. And rickets, it is a defective mineralization of osteoid or cartilaginous growth plates. If it is of the osteoid, it is called as osteomalacia. If it is the cartilaginous growth plates, it is rickets, most commonly due to vitamin D deficiency. They cause osteopenia in looser zones, which are pseudofractures, and they cause epiphyseal widening and metaphyseal cupping. Some of the signs are genu varum, costochondral junction, bead-like presence called as rachitic rosary, and craniotabes. How to know my child is normal? A thorough prenatal, natal, and postnatal history is of importance, including the normal growth scans and even nuchal translucency scans. Sometimes even some episodes like prolonged labor or ischemia may indicate towards cerebral palsy. And gait analysis, which includes like equinus gait, broad-based gait, or waddling gait, they may indicate to a particular condition. And a general awareness about the developmental milestones and population-specific standard deviations is important to know the normal development of child. Juvenile idiopathic arthritis, it is a counterpart of rheumatoid arthritis seen in the young. It is a non-infective inflammatory joint disease for more than 3 months involving less than 16 years of age. The cause is similar to rheumatoid. It causes synovial inflammation, fibrosis, and ankylosis. It is due to a genetic predisposition to an abnormal antigen which causes an immune response. This is a sequence of a 5-year-old child till 14 years of age. By the age of 14, she has bilateral hip replacements and has also developed scoliosis. The pauci-articular form involving many joints is common among girls. They may be rheumatoid factor negative, but anti-nuclear antibodies are positive usually. And the treatment is with corticosteroids, continuous passive motion with the help of machines, night splints, and if it is still not corrected, surgical approaches. Feet pain is very common, but obviously most of the time the cause is very elusive. Posterior heel pain, it can be either due to apophysitis at the tendoachilles attachment, or it can be calcaneal bursitis called as retrocalcaneal bursitis. Both of them can be differentiated by appropriate clinical examination, and if diagnosed adequately, it provides good relief in treatment with non-steroidal anti-inflammatory drugs. Inferior heel pain, it is maybe due to calcaneal stress fractures, osteoid osteoma, or osteomyelitis. And in some cases of plantar fasciitis, they show good outcome with stretching exercises, local steroid injection and PRP injections. Pain over the midfoot in children, it is very rare. It can be due to Kohler's disease, which is an osteonecrosis of the navicle bone. A comparable disease in the middle-aged is called as the Brailsford disease, in which the navicle is deformed. In adults, especially if the arch is high, a ridge of bone sometimes develops on the adjacent dorsal surface of medial cuneiform, which restricts and causes pain while wearing shoes. Generalized pain, as seen, is metatarsalgia. It may occur either due to flattening of arches or unaccustomed excessive activity like stairs, walking, or running. Polymyalgia rheumatica. Symptoms include pain, stiffness in proximal muscles like shoulders and hips, often with fever, malaise, and weight loss. They do not cause any muscular weakness, but they cause joint pains. It is more common among 50 years of age and usually associated with giant cell arthritis. Findings include significantly increased ESR, increased CRP, but normal creatinine kinase. Treatment is with low-dose corticosteroids. Fibromyalgia, on the other hand, is between 20 to 50 years of age. It's chronic, widespread musculoskeletal pain associated with tender points, stiffness, paresthesias, poor sleep, fatigue, cognitive disturbances called as fibrofog. Treatment is usually with adequate exercise, antidepressants, and neuropathic agents like gabapentin. Polymyositis and dermatomyositis are both very similar conditions where both have increased creatinine kinase and positive to many antibodies like anti-nuclear antibodies, anti-Jo1, anti-SRP, anti-MI2. And they're usually treated with steroids followed by long-term immunosuppressant therapies. Polymyositis is a progressive symmetric proximal muscle weakness involving hips and shoulders again, characterized by endomysial, the mysial muscle fibers, inflammation with positive CD8 T cells. Dermatomyositis is polymyositis with dermal features including malar rash, Gauthron papules on the fingers, and heliotropic rash called as a shawl and face rash. Frozen shoulder, it is usually seen in diabetics over the age of 50 years. Active fibroblastic proliferation in the rotator interval, anterior capsule, and coracohumeral ligaments. They may also be proceeded after trauma or a trivial trauma, followed by aching in the arm and shoulder. Pain gradually increases in severity and often prevents sleeping on the affected side. It also restricts the active and passive movements in all directions. X-rays are usually not conclusive, but to rule out other diseases. Some of the other diseases which can cause similar complaints are cervical spondylosis, supraspinatus tendinitis, and glenohumeral arthritis. And the treatment is with anti-inflammatory drugs and pendulum exercises by physiotherapy. Manipulation under general anesthesia is done later if they see no relief, or they can even try intra-articular steroid injection. Osteoporosis, we know that it's a trabecular and cortical bone loss and interconnections despite normal bone mineralizations and lab values, most commonly due to bone resorption related to estrogen, and can also be secondary to other drugs. It is measured by using DEXA scan, and treatment is with bisphosphonates or teriparatide, SERMs, and a targeted monoclonal antibody called as denosumab. Coming to bisphosphonates, there are oral and IV drugs. Alendronate, risendronate, and ibandronate are oral drugs. Zoledronate is an IV drug. They have different trials trying to prove their efficacies. But in oral drugs, they should be given with caution in reflux disorders, and it is an absolute contraindication in Barrett's metaplasia and esophageal cancer because they cause rapid disintegration in the esophagus. In renal patients, however, oral drugs are much better to be given. Coming to the complications of bisphosphonates, two main ones are atypical femoral fractures, which are still of concern, and they should be given adequate screening in 6 months or 1 year at least. And the other complication is osteonecrosis of jaw. But however, some studies have proven that osteonecrosis occurs in bisphosphonates only when given in patients with malignancies like multiple myeloma or breast CA, not in all cases. And there are only studies proving this, that ONJ is a complication in retrospective studies, so it needs further scrutiny with prospective studies. In arthritis, there are two types of arthritis, osteoarthritis and rheumatic arthritis. Osteoarthritis, it is age-related and causes increased with activity, but rheumatoid arthritis, it is characterized by morning stiffness and eases with the daily activities. Both of them have different clinical presentation, like rheumatoid arthritis causes synovial inflammation and pannus formation. But however, the measures to take care of it and try to prevent it are equal, the same. Mainly lifestyle modification by weight reduction and healthy diet with calcium and vitamin D supplementation right from the perimenopausal age. And we also, the importance of quadriceps strengthening is a must because it improves the joint motion and as well as reduces the joint load directly bearing. And medical supplements like glucosamines, chondroitin sulfate, and collagen extracts are also useful in delaying the arthritis changes. Viscosupplements, which are directly injected inside the joint, like hyaluronic acid, is only useful in grade 1 and 2 and should be given in specific individuals only. Surgical management, total knee replacement is the gold standard, and many people have benefited from this. I think some of the brief topics have been completed. Thank you.
I congratulate you, doctor. You have taken us all through right from the newborn to post-menopause. I congratulate you. Thank you. And I thank Dr. Lakshmi Ratna Madam for giving me this opportunity. Thank you so much.
Dr. Mahalakshmi ma'am, can you present the memento to Dr. Sai Akansh? Hemlata madam. Hemlata ma'am, please hand over the mementos to all the chairpersons. Dr. Vijay Lakshmi ma'am. Dr. Mahalakshmi ma'am. Dr. Jayashree ma'am. Thank you, ma'am, for chairing this session. Now for the winner announcement for the poster presentation.
Postgraduate residents have presented posters today. So first prize goes to Dr. T. Shravanti Rao, second year PG resident from SOS Medical College. She presented a case on postpartum stress syndrome, diagnosis and management. Due to her health issues, she could not come today. So we have, judges panel have decided to give a token of appreciation to all the participants. So I invite Dr. Sadia Ziba, first year PG resident from Dr. VRK Women's Medical College. She is also not there here. So next poster presenter, Dr. Kasireddy Pujita, third year PG resident, SVS Medical College. She presented a case report on seromucinous borderline tumors.
What are you giving?
A book written by Pratibha Madam will be given by Lakshmi Ratna Madam to the Pujita. Congratulations, Pujita. Next, I invite Dr. Mohammadi Banu, first year PG resident from Dr. VRK Women's Medical College. She presented a case report on atonic PPH management. Congratulations, Mohammadi Banu, all the best. After this, valedictory session will be given by Dr. Priyamvada Madam.
Good evening, friends. So finally, we have come to the valedictory part of the whole CME. Gives me great pleasure to deliver the valedictory note. Thank you is a very simple word in the English dictionary, means appreciation. I would first like to thank the Almighty for making this conference a huge success. I would like to thank our MD, Dr. Krishna Prasad, Dr. Durga Prasad, Dr. Anil, and team for giving us this opportunity to be part of the Ankura family and making this a huge success. Dr. Lakshmi Ratna, our organizing chairperson, and team Attapur, a big thank you. Dr. Jayashree Reddy and team Banjara for making the PPH workshop a huge success. My team Gachibowli, including Dr. Jyotsna, Dr. Vindhya, my youngsters and staff for making all the workshops a huge success. Not to miss Dr. Paimida Banu's hysteroscopy workshop and Dr. Swati Vyas and Dr. Aparna's Doppler workshop, which was also a huge success. I would be failing in my duty if I don't thank our entire guest faculty who made it to Attapur and made it a huge success. Our seniors, Dr. Hemlata Rangachari, Dr. Sarojini Devi, and Dr. Pratibha Madam, who encouraged us and gave us tips on how to make things better. They stayed on till the end and took part in the ramp walk too. What enthusiasm and encouragement. Youngsters, please learn from these youngsters. As if they can do it, we can do it too. Please do learn to attend all CMEs regularly and share and part with your knowledge. I would be failing in my duty if I don't mention my dear young enthusiast, Dr. Satyashri from LB Nagar, Ankura, a meticulous perfectionist who came all the way from LB Nagar to Attapur for all our meetings to make this a huge success. Last but not the least, a big thank you to the Karl Stores Vishal team, our AV team, our housekeeping, facility and maintenance team at Attapur. All our medical companies who sponsored this meet. Of course, a big thank you also goes to Dr. Sandeep for the gastronomical delight. Finally, a big thank you for all those whom I've missed. Last but not the least, it has been an honor to convene this august gathering of incredible minds in gynecology. Let's continue to champion women's health, making strides that empower and uplift every woman's health journey. Thank you. We'll now have the national anthem. Yes, madam.